ऑन है, ऑन है, ऑन है, ऑन है। तरुणजीत, वो इधर से करना। So, good morning, everybody. Thanks for being here on this Saturday morning for these wonderful academic sessions, Lung Masterclass, 5th edition. Basically, the masterclass focuses on all the aspects in the lung cancer, basically, which are dealt with basically with the student perspective, what you should know actually. And we have various speakers across the countries who are specialized in this field, both in surgery, radiation, as well as in medical oncology, molecular oncology, pathologies, and all other aspects which will be covered during all these sessions. So I will not take much time. The first session today's is by Dr. Rushabh Kodari, who is a director, Oncovin Cancer Center, consultant medical oncologist at Narayana Multispeciality Hospital, Ahmedabad. He will be discussing chemotherapy in locally advanced lung cancer, neoadjuvant and adjuvant. Over to Dr. Rushabh.
Thank you, Kumar sir, Asai sir, Vijay sir for this invite. I will be talking on chemotherapy in locally advanced lung cancer, neoadjuvant and adjuvant. So, as we know that even in early stage and locally advanced stage lung cancer, the long-term prognosis is not good. Though this data is a bit old, but we know that stage 2, the survival is around 50 to 60%, and stage 3 is 25%. We have both local and distant relapses, and distant relapses are much more common than local relapses, especially when stage increases. Most of them recur within 2 years. So these form the basis of why we need something more than surgery. So from IALT trial to LACE meta-analysis, there are multiple adjuvant studies which have been done. So we'll go through them. In IALT study, which was presented in 2004, there was 4.1% absolute survival benefit at 5 years with adjuvant chemotherapy. The drugs used here were cisplatin doublet, but the partner chemo was variable. When this was updated at 7.5 years, the hazard ratio was 0.91 crossing unity. So it lost significance. Thing to note here was that around 33% patients were stage 1 patients. And in all these older trials, the AJCC was different than what we are using currently. The second trial was JBR10. Here, stage 1 and stage 2 patients were only taken. The absolute difference was around 15% at 5 years, 69% versus 54% with hazard ratio of 0.7, not crossing unity. And here, vinorelbine and cisplatin was used and was compared with observation. The benefit was maintained at the long-term analysis at 9.3 years. The benefit was largely driven by stage 2 disease. As we can see on Kaplan-Meier curves on the right side, stage 1 disease was not showing benefit with addition of adjuvant chemotherapy. Then came Anita trial, where stage 1B, 2 and stage 3A patients were taken post complete resection, and there was around 8.4% absolute benefit at 7 years. Again here, cisplatin vinorelbine was compared with observation, and in the subset analysis, it was shown that benefit was largely driven by node positive disease, and 0 patients didn't have much benefit with adjuvant chemotherapy. This is the most important meta-analysis for adjuvant drugs, LACE meta-analysis. The overall survival plot showed that hazard ratio was 0.89 non-crossing unity when individual patient data from 5 largest trials were compared. So around 4,500 patients were there with median follow-up of 5.2 years. 5-year absolute benefit was 5.4% from adjuvant chemotherapy. Benefit varied from stage to stage. For 1A, hazard ratio was 1.4, which was worse. So 1A should not be given adjuvant chemotherapy. 1B, again, hazard ratio was 0.93 crossing unity. So one need to be cautious. We need to select patients very well if we are giving adjuvant in 1B. Stage 2 and stage 3 patients should receive adjuvant chemotherapy. Hazard ratio is 0.83 in both stage 2 and stage 3, not crossing unity. The patients with good performance status had better benefit with adjuvant chemotherapy. And again, it was shown that platinum doublet, the counterpart drug, was not significant as per LACE meta-analysis. Then in 2010, we had LACE, the subgroup analysis of only cisplatin vinorelbine group, where 1888 patients from 4 studies were taken. The 5-year absolute benefit was 8.9% with hazard ratio of 0.80, which was better than what we saw in LACE meta-analysis with all the doublets. So according to stage, from the same cisplatin vinorelbine meta-analysis, stage 1 5-year benefit was 1.8% with hazard ratio of 1.01. Again, reiterating that even cisplatin vinorelbine should be avoided in stage 1 patients. Stage 2 5-year benefit was 11.6% with hazard ratio of 0.74. Stage 3 5-year benefit was 14.7% with hazard ratio of 0.66. So cisplatin vinorelbine was largely standard of care for stage 2 and stage 3 patients based on this analysis. So from all the available data, the 3 trials, LACE overall meta-analysis and LACE cisplatin vinorelbine meta-analysis, it was confirmed that for at least for stage 2 and stage 3 patients, adjuvant chemotherapy should be given. The benefit was there in overall survival at 5 years in all the studies given. So what are the indications for adjuvant treatment? Stage 2, stage 3, definite yes. Stage 1A, definite no. Stage 1B, the guidelines varies based on JBR data, and it's said that more than 4 centimeter tumors would benefit. There are some data which say that you can look on the high risk features like lymphovascular invasion, high grade, PET SUV more than 10, visceral pleural involvement. But we need to be careful while we are selecting stage 1B patient. Is age a criteria to select adjuvant? So in LACE meta-analysis, more than 65 years patient and less than 65 years patient had similar benefits. So age should not be criteria for choosing adjuvant treatment. But we need to be bit aware that there is limited data for 70 plus patient. Only 10% of the patients were 70 plus, and for patients more than 75, it was less than 2% of patients in the whole meta-analysis. In meta-analysis, it is shown that performance status is an important indicator. So performance status needs to be kept in mind while we are planning adjuvant treatment. Which regimens to be given? So largely cisplatin doublet has to be given. Cisplatin dose more than equal to 300 milligram per meter square showed to have maximum benefit when it was given in adjuvant treatment. Can we give carboplatin in cisplatin ineligible patient? So we don't have any positive study with it, but many guidelines suggest that it is consensus based on expert opinion that you can use only in cisplatin ineligible patient. For cisplatin eligible, everyone should use cisplatin. Try to give doublet and try to give cisplatin at least 300 milligram per meter square dose in total. So this 300 milligram per meter square came from this meta-analysis where the maximum benefit was for patients who received more than equal to 300 milligram per meter square dose. Again, the meta-analysis showed that cisplatin vinorelbine had maximum benefit when it was compared with other doublets based on this meta-analysis. The problem with cisplatin vinorelbine is that JBR10 and ANITA trial both had cisplatin vinorelbine as the intervention arm. So we can see that neutropenia is more than 70% and more than 80% in these trials. Febrile neutropenia of 7% and 9% respectively. And EMS is 15% and more than 15 and more than 25%. So cisplatin vinorelbine is bit toxic that we should consider. So is there any other options? So there is a study E1505 where 1500 patients were taken and different doublets were given: vinorelbine cisplatin, gem cisplatin, docetaxel cisplatin, and it was compared. So the overall survival efficacy wise was similar. The only difference between different regimens were toxicity profile. Vinorelbine neutropenia was 13% and around 9% to 10% of them had febrile neutropenia. Gemcitabine thrombocytopenia was 18%. Pemetrexed was the drug which had less grade 3 toxicity. So in non-squamous patient, pemetrexed is something which we should consider. So the most robust data we have is with vinorelbine cisplatin, but based on toxicity profile, we are safe to use other cisplatin doublets, especially from toxicity point of view. And now we know that efficacy is also similar. Pemetrexed cisplatin, based on GPENG study, the grade 3-4 neutropenia was 0.3% versus 12%. Again, assuring us that pemetrexed is way safer than vinorelbine. So this was all about adjuvant treatment. Do we have that strong data for neoadjuvant chemotherapy? So this is a meta-analysis for all the trials. The earlier trial, neoadjuvant and adjuvant trials were going hand in hand. But because we had survival benefit with adjuvant trials, most of them were stopped early and has not recruited well. So based on this meta-analysis, we can know that the hazard ratio for overall survival is 0.87, not crossing unity, showing that neoadjuvant chemotherapy will have equal efficacy. And based on this Kaplan-Meier curve and hazard ratio of 0.87, there is 13% reduction in relative risk of death, and absolute benefit at 5 years is around 5%. Now, the same analysis showed that the hazard ratio for adjuvant treatment was 0.80 and hazard ratio for neoadjuvant was 0.80. Again, assuring us that neoadjuvant has efficacy similar to adjuvant treatment. So why should we consider neoadjuvant? The major reason is compliance. So the above 5 trials are adjuvant trials where if you see that patients receiving 3 cycles or more is less than 60% or around 60% in most of them. While in neoadjuvant trials, which are the last 4, patients receiving 3 cycles or more is around 80 to 90%. So as we know that we have to give cisplatin 300 milligram per meter square, or at least we should try to give that which is achieved more in neoadjuvant setting rather than adjuvant setting. So what are the differences between neoadjuvant and adjuvant? Level of evidence is more for adjuvant. We have multiple randomized control trial and a meta-analysis favoring it. Compared to neoadjuvant, we know staging in a better way if patient is operated upfront. Neoadjuvant, we have a theoretical benefit of earlier delivery and benefit in micrometastasis being avoided. Compliance obviously is better with neoadjuvant than adjuvant. We can evaluate response. So we know that drug is acting, we can test the biology of tumor. That is something which will benefit in neoadjuvant and we won't know in adjuvant. So maybe for research purposes, a neoadjuvant is a better strategy than adjuvant. And the adjuvant, the benefit would be we would have a good tissue. And with more and more IO and TKIs coming in adjuvant, neoadjuvant setting, tissue would be an important thing while we plan perioperative treatment. So what are the modern options? So it is out of my topic, but I will just walk through it that now we have data for osimertinib in adjuvant setting in EGFR positive patient with an impressive hazard ratio for DFS. We are still awaiting overall survival data. For immunotherapy options, we have data both for adjuvant and neoadjuvant setting. Adjuvant atezolizumab in IM power 010 and checkmate 816 nivolumab in neoadjuvant setting. And there are multiple trials ongoing for IO and targeted agents. IO with chemo, IO plus IO, ALK inhibitors in both adjuvant and neoadjuvant setting, EGFR inhibitors in both neoadjuvant and adjuvant setting. So this field is going to be dynamic. So based on this, I would conclude that adjuvant and neoadjuvant chemotherapy should be given at least in stage 2, stage 3 patients, not to be given in stage 1A patient. We should try to evaluate patients when we are giving it in stage 1B, where based on risk factors, you can give or not give and discuss with the patients. The regimens which we should use should be platinum doublet. Cisplatin more than equal to 300 milligram per meter square should be our target. pemetrexed, cisplatin, vinorelbine are good idea for adeno. You can give PEMSIS. For non-adeno, you can give cisplatin, vinorelbine. Again, Taxane plus cisplatin or cisplatin etoposide. Also, we have data. So based on toxicity profile, we can choose, though the data is strongest for cisplatin, vinorelbine. And it looks like neoadjuvant and adjuvant have similar efficacy. So we have better compliance with neoadjuvant. So we generally practice and try to give neoadjuvant now, especially when we have locally advanced disease. Thank you.
Thank you, Rishabh. You have wonderfully summarized the role of chemotherapy. Now, next, Rishabh has already given neoadjuvant chemotherapy. So our next speaker is Dr. Sabita Jivnani. She's a professor, thoracic surgery, Department of Surgical Oncology at prestigious Tata Memorial Hospital. Dr. Sabita will be speaking about surgery after neoadjuvant in locally advanced lung cancer. Over to Dr. Sabita.
Good morning, everyone. Thank you for being here on a Saturday morning. COVID has really made all of us lazy, and the attendance in live physical conferences is dwindling. And even most of the presenters are opting for the virtual talks last minute. So I hope we can get back to normal soon. And I would like to thank the organizers for giving me this opportunity. So I will be talking about neoadjuvant therapy in non-small cell lung cancer, what it means for the surgeon. So I will be covering why neoadjuvant, what is the evidence that we have, what we worry about as surgeons, the morbidity, mortality, whether we can utilize it in extended resections, is it feasible to do minimally invasive surgery after neoadjuvant, what is the role of immunotherapy, how does it affect our pulmonary functions, and what is our data. So neoadjuvant therapy has been proposed to have many benefits as covered by the previous speaker, and compliance has shown to be better. The biological effect can be assessed, the disease can be downstaged, improving resection rate, and also we can tackle the subclinical micrometastasis early. So systemic therapy in resectable non-small cell lung cancer, locally advanced, is not been a new concept. It's been there for 30 years now. And we all know that the earlier trials and the LACE meta-analysis showed benefit. Tumors more than 4 centimeters, high-risk features, and nodal positivity warranted some form of systemic therapy to be added to surgery, because surgery alone was not enough, even if it was a complete resection. So what is the efficacy and evidence? This is a list of trials that has been published, and we started with Roth, Russell, and Depierre, the earliest studies, where they all showed that there was benefit in giving neoadjuvant chemotherapy in stage 3 patients who are about to undergo surgery. And then came the meta-analysis, which confirmed this. Not a very big meta-analysis like the LACE meta-analysis, but it still had 15 randomized controlled trials with over 2,000 patients. And the risk ratio for the reduction of death was 13%, and showing almost a similar overall survival benefit as adjuvant therapy, which was again 5%. But what we were worried about, does it increase the 30-day mortality? Does it increase the morbidity? Because finally, you can't stop at neoadjuvant chemotherapy. You have to operate on this patient after that. So there was no difference in R0 rates, and there was no difference even across subgroups. Another meta-analysis by Zhang et al. Also confirmed the same. They included many more trials, and they showed a significant OS benefit with giving neoadjuvant therapy. And this was higher in females as well as locally advanced tumors in stage 3. There was no difference in post-op mortality or complications. And this was very, very reassuring. There were also some trials of neoadjuvant targeted therapy, but they really did not pick up much speed, because even though there was a modest response and pathological CR rates, there was a trend towards improved progression-free survival. Nothing actually translated into a better overall survival, and these were largely abandoned. So one of the groups tried to compare neoadjuvant with surgery versus adjuvant chemotherapy. They saw that even though 90% of the patients in the neoadjuvant group took chemotherapy, the 5-year DFS and OS was almost the same in both the arms. Now, if more number of patients complete their systemic therapy before surgery, most of the people were anticipating this study for quite some time to show some kind of benefit. But the criticism was that there were only 200 patients in each arm. It was a 600 patient trial with 3 arms, and therefore no difference could be demonstrated. And there are no other papers which have tried to replicate this. So coming to locally advanced lung cancer, there was a meta-analysis by Zhao, 18 randomized controlled trials, more than 2,000 patients with N2 positive status. So N2 is really the where the conundrum starts. What do you do? Do you resect? Do you give CTRT? Now there's specific data, and what is really better for the patient. So this meta-analysis actually showed us that NACT followed by surgery followed by some more adjuvant therapy had the highest overall survival benefit, and there were no excessive deaths in the multimodality arms. So now coming back to the most important question, what are we worried about? What are the difficulties we think may occur or actually occur? So we're worried about tumor progression. As we all know, not all patients will respond to this neoadjuvant approach. We are worried about the surgery being more difficult, therefore leading to less R0 resection rates. We are worried about the tissue fragility and delayed healing. And also we are worried about our patients being immunosuppressed when we are taking them up for surgery. Already these patients are smokers, they are elderly, and they have locally advanced disease. So do they become more frail if you give systemic therapy first? And what happens to their pulmonary function tests, which are the most important determinant of their for quality of life? So there are some studies which showed about what happens to the perioperative complications in patients undergoing surgery after neoadjuvant therapy. This was an early study in 2000. Small numbers, 34 patients undergoing surgery after neoadjuvant therapy were compared to those who underwent upfront surgery. No increase in mortality, but I would like to draw your attention to this table where the major complications, life-threatening complications, are almost 3 times that of the arm which did not receive chemotherapy. 17% of the patients got re-intubated in the ICU. Almost 12% required a tracheostomy. So this really put off the surgeons from neoadjuvant therapy, and they were scared to adopt this approach. In 2001, MSKCC also published their experience, and this was a big number of patients, 470 patients with more than 80% receiving neoadjuvant chemotherapy. And even though the post-op complications were almost 1 in 3 patients had a post-operative complication, most commonly pneumonia and atelectasis, the mortality was comparable to other surgical series only. So the mortality did not increase, and right pneumonectomy was the only predictor of significant increase in mortality. So even from Kathy Albane's paper, where they had used induction chemo-RT, we know that right pneumonectomy is something that we have to be wary of when we are giving local radiation or systemic therapy. And this is again in stage 3 non-small cell lung cancer. 32% were post-neoadjuvant. Mean hospital stay is twice of what we normally see in patients undergoing surgery for lung cancer. Complications again 50%, but the mortality slightly higher, but they had a fair number of pneumonectomies and bilobectomies too. So after these older papers in the early 2000s, there are more contemporary series which have seen that can you still do pneumonectomy after giving neoadjuvant therapy? Because we are talking about locally advanced lung cancer, and pneumonectomy may be a necessary evil in a lot of these patients. You could do sleeves, bronchovascular sleeves even, you could do them, but in some patients, pneumonectomy is going to be required for a R0 resection. And in these patients, even chemo radiation may not be feasible in view of the large volume of the tumor. So there's no getting away that this is one of the surgeries we may have to perform. And when they looked at this, they saw that the major complication rates were much lower than the historic papers, that's 20%. And there was a significant bronchopleural fistula rate, but there was no difference in the type of subgroups. And the 90-day mortality was an acceptable 3%, which we see in high volume centers after pneumonectomy. Again, another paper looking at pneumonectomy, and here too, the mortality was not very high. So now we know that, minimally invasive surgery is the norm, is the accepted modality, is the accepted approach that we should be offering our patients, especially since we have level 1 evidence in the form of the Violet trial, which was published last year. So minimally invasive surgery is a better approach for patients who have lung cancer, who are undergoing surgery. But when we give neoadjuvant therapy, does this equation alter? So some papers on VATS after induction therapy, and they saw that the duration of surgery, blood loss, ICD, as well as the hospital stay was actually lesser in the VATS arm and not more. But a point to note is that a lot of the patients got converted. So this is a high volume center, Dr. Al-Torki's center. And year 2, they had 12.5% conversions, mostly due to adhesions. Another paper which showed that the postoperative complications were 26% and the conversion rate was less than 10%, but no difference in postoperative mortality. So where are we now? This is the era of immunotherapy, like we all know. And we have had impressive papers being published in the last 3 to 4 years. The first study that came out from Bott's group was a phase 1 trial of 22 patients where they were just experimenting, giving immunotherapy, neoadjuvant nivolumab in resectable non-small cell lung cancer. Most of the patients were stage 2 and stage 3. They converted half the patients from minimally invasive to open surgery, but they saw that the major complications were not too bad and there was no postoperative mortality. So that was really significant and reassuring. But what they noted about surgery after immunotherapy was that there was a lot of inflammation and fibrosis, especially in patients who had a good pathological response. Patients were inundated with pneumonitis, other endocrine abnormalities, and the conversion rates were higher. So if we want our patient survival to improve, there is going to be a trade-off. The surgeons need to adapt their surgery, maybe train themselves and retrain themselves to be able to do minimally invasive in these patients as well. There are a lot of studies that have been published, and the earlier studies said there were a lot of patients being converted to open surgery. Then came the phase 3 trials, and here we saw that the pathological complete response rates were increasing. The patients had good survival at 12 and 24 months. And then people started adding chemotherapy to this neoadjuvant immuno. The Nadeem trial, which showed an impressive overall survival of 90% at 24 months, really set the benchmark for the FDA as well as surgeons and medical oncologists all over the world to adopt this strategy. And recently we saw the phase 3 trial being published, which showed the event-free survival at 1 year was significant. But we have to remember that this study has to be taken with a pinch of salt. It was initially planned as a 3-arm study, and the Nivo plus Ipi arm was discontinued. But we are not sure, and the authors have not indicated if the statistics were recalculated after discontinuing the 3rd arm. They had highly selected patients, most of them ECOG 0, high volume surgeons who performed more than 500 lung resections per year, and tertiary centers of expertise where failure to rescue is very, very low. So we all know that we now have to adapt ourselves as surgeons to be able to perform surgery, not only after neoadjuvant immunotherapy and neoadjuvant chemotherapy, but also do it minimally invasive. But how do we determine which patients are really going to do well? Because after all, quality of life is also an important endpoint, and it's not just all about survival. So does administering neoadjuvant therapy impact the pulmonary function? A few small studies where they have done PFT pre and post neoadjuvant therapy, and they saw that there was a significant reduction in the diffusion coefficient for carbon monoxide, including the single breath as well as the alveolar volume, but there was no difference in post-op complications or mortality. Another study showed that the major complications were 30% when there was an 8% reduction in pulmonary function. And this is from Dr. Sarfolio's group, and we know this is a very high volume center. So a Japanese paper which looked at pulmonary rehabilitation while the patient is receiving neoadjuvant therapy saw that those who were smokers and those who had respiratory impairment actually did better if you started the pulmonary rehab during the neoadjuvant phase of the treatment. So what have we seen so far? we looked at these 6 years, 2013 to 2019, and 16% of the patients in our lung surgery database had actually received neoadjuvant. The indications were mostly for N2 disease, a few others, and the histology was mostly adenocarcinoma. These were the regimens that were used. And we saw that the intraoperative parameters, such as the blood loss, the operative time, and the mean hospital stay, was slightly higher compared to the patients who were undergoing upfront surgery. But major postoperative complications were not too worrying. That is Clavin-Lido grade 3 or more, it was 13%. And the mortality remained at around 3%, which is what we see with upfront surgery also. So neoadjuvant therapy is safe, it is efficacious, but we also had a lot of conversions. So in our video-assisted thoracoscopy group, 7 patients out of 26 got converted. So just concluding, neoadjuvant therapy is now going to become the standard of care. Whether we like it or not, we have to accept it and we have to live with it. This is the time when multidisciplinary joint clinics are really, really essential, where all the stakeholders need to sit down together and plan the treatment. Contemporary series have shown that surgery after neoadjuvant therapy is not so bad. The side effects are acceptable. Extensive resections as well as minimally invasive surgery can be safely performed after neoadjuvant therapy. We need to repeat the lung function test pre and post neoadjuvant. Neoadjuvant immunotherapy is no longer the new kid on the block. It is the standard of care already in the Western world. And when it becomes affordable in our country, we too are going to have more and more patients who have received neoadjuvant immunotherapy and will be coming up for surgery. And the future therapy will be biomarker based. With that, I would like to say thank you, and I'll be happy to take any questions. No questions? Thank you.
So anyone who is having a question, can they ask now, or they can also, discuss with our all esteemed faculties whenever it's possible. Now to discuss, we have already done with the chemotherapy and the surgery, now the radiation. And for that, I invite Dr. Anil Tibdewal, who is Associate Professor in Thoracic Radiation Oncology at Tata Memorial Hospital. He will be discussing about radiation in locally advanced NSCLC. Over to Dr. Anil.
Yes. Hi, good morning, everyone. So I'll be speaking on radiation in locally advanced non-small cell lung cancer. So the flow of my talk after the chemotherapy and the surgery will be how to select the patient who are best suited for the concomitant chemoradiation therapy. What should be the time, dose, and fractionation that we are going to use for the radiation therapy? What are the radiation volumes? What are the organ at risk constraint and the outcome of concomitant chemoradiation therapy and complication associated with them? So as you know that, so what do you mean by locally advanced non-small cell lung cancer? So what is highlighted in the red, you can consider them as the locally advanced non-small cell lung cancer. In the 8th edition, there has been certain changes that has happened in the locally advanced non-small cell lung cancer. For example, stage 3A, T4N0, N1 is also considered to be locally advanced non-small cell lung cancer. Now, so what are the patient factors when you want to select the patient for concomitant chemoradiation therapy or for example, for age, there is no exactly age cutoff. It depends upon the performance status and the other parameters. The performance status should be more or less 0 to 2 because majority of the randomized control trial have taken the patient in 0 to 2, and obviously poor prognosis confer the poor performance status confers a poor prognosis. Comorbidities needs to be considered because these patients are going to be on the chemotherapy also. The PFT parameters, there is no set lower limit of the PFT, but it would be wiser enough to take the FEV1 of more than 50% predicted, an absolute value of more than 1 liter and DLC of more than 40% because it will reduce the complication of pneumonitis and interstitial lung disease. The only thing that the radiation oncologists are most feared about is the interstitial lung disease because in this particular group of patients, the rate of radiation-induced pneumonitis will be much, much higher as compared to the normal lungs. The tumor factor, the T stage needs to be considered. For example, T3 is not only about the size, about the collapsed lung, also T4, the nodal status, especially so with respect to the location and the laterality of the primary tumor, the nodal status make an impact as far as the radiation planning is concerned. The size of the tumor as well as the PTV volume, because it has been shown that more than 700 cc of the tumor volume confers a bad prognosis, and the collapse of the lung. If you're having a collapsed lung, then the major airways are involved, and then the chances or the probability of radiation pneumonitis or other complication are slightly higher. The treatment factor, the motion management in radiation therapy is very essential. If you do not have the motion management technique, then it would be very difficult for you to assess the motion. The linear accelerator should be used and not the telecobalt for the treatment planning. The planning system should have the tissue heterogeneity correction because it can overestimate the dose, and you can really underdose the target in reality. The pulmonary rehabilitation in consultation with the pulmonologist are very important because this patient will need pulmonary rehabilitation before the start of concomitant chemoradiation therapy as well as afterwards. Now, so whether we should do the radiation alone or it should be combined with chemotherapy, there are various phase 2 and phase 3 randomized control trials which have shown that the combination therapy has a better overall survival as compared to radiation alone. So what should be the timing of the radiation therapy? Should it be concomitant with the chemotherapy, or whether we should do the, for example, chemotherapy first and then the radiation therapy afterward, or radiation therapy first or chemotherapy afterward? So this meta-analysis based on 5 randomized control trials have shown that the 5-year overall survival benefit is approximately 5% when you when you combine the chemotherapy and radiation therapy simultaneously. Now, so when I am speaking about the motion management, as you can see on the left-hand side of the picture, that the tumor is a static force when you do a free breathing CT scan, but in reality, the tumor is moving. As you can see, the tumor is moving approximately to 3 centimeter in the craniocaudal direction. So you need to increase the volume, you need to take into account the motion, and there are various motion management techniques that are available. I will not go into the details of all of this. First one is the motion encompassing technique. For example, the 4-dimensional CT scan, forced shallow breathing like the abdominal compression method, breath hold technique like the ABC, the respiratory gating and respiratory tracking. Every institute will not have all the 5 techniques. So whatever the technique and modality is available at the institute, you should be comfortable with that and you should produce their own result. Now coming to the radiation technique, whether we should all do the IMRT or all the 3D CRT is acceptable. There is no randomized control trial, but there is a secondary analysis of RTOG 0617, so which have shown that there is no outcome difference between the 3D CRT and IMRT. The overall survival and progression-free survival are more or less the same. But if you see the target coverage and the conformity, it is much better in the IMRT arm, and it also reduces the rate of the pneumonitis as well as the heart doses. So if you have the technique available of IMRT, it is preferable to use the IMRT. It's just to reduce the toxicity to a very significant extent. Now, so what are the radiation volume that we talk about in the radiation therapy planning of locally advanced non-small cell lung cancer? Here you can see in the pictorial diagram that the GTV is the gross tumor volume. Whatever is the radiologically visible tumor or the node, then you should consider that as a gross tumor volume. There is no role of elective nodal irradiation. You should only cover whatever the gross node which is pathologically proven or radiologically suggested to be involved. You should account for the tumor motion in the IGTV. Then you can have a clinical target volume of approximately 5 to 7 mm. So depending upon the histology, that you need to account for the microscopic disease which are not easily visible on the radiology. And then there's a planning target volume which will take into account the daily setup uncertainties, and the prescription should be done to the planning target volume. Now, but these are the ISTO-ACROP guidelines which suggest or which recommend that we should do EBUS for each and every patient. But in a country like ours, we have we don't have facility of EBUS at all the centers, and at the TMH also we are not doing on every patient the EBUS for the treatment of the concomitant chemoradiation therapy. So here the radiologist and the nuclear medicine will help you out about the role about the nodal involvement. If the CT the node is enlarged and it is showing a PET positive, the chances of having a nodal metastasis in this particular group will be as high as 78%. So if you have the EBUS, if you have the capacity, if you have the resources, then you can do the EBUS, and then you can prove so whether the node are involved or not. If the nodes are involved, then you can take them into the radiation therapy volume. If the nodes are not involved, then you can exclude them because it will reduce your toxicity. Now, what about the dose and fractionation? Till the published result of RTOG 0617, there was a lot of debate about the radiation therapy dose escalation beyond the standard dose of 60 to 66 gray in 30 to 33 fashion. But so after the publication result of RTOG 0617, the 74 gray arm has not done superiorly. Actually, it was harmful for the patient to give higher doses, but there was the criticism that they have performed the dose escalation to the entire planning target volume. Maybe we should not do that. But currently, there is no proven role of uniform dose escalation. And as far as the hypofractionation is concerned, if your volumes are large, hypofractionation can be a detrimental in view of the toxicity. So, can we do the accelerated fractionation schedule? What do you mean by accelerated fractionation? Accelerated fractionation only means that instead of completing the treatment in approximately 6 to 6.5 weeks, you are completing the treatment in 5 weeks by treating them on Saturdays or Sundays. And they have shown that the 5-year absolute benefit in overall survival of 2.5%, but it will come at the cost of grade 3 esophagitis, and it will be to the tune of 30 to 40%. So if you are considering that the patient is not suitable for chemotherapy because of various reasons, then you can consider for accelerated fractionation schedule, but not in combination with the concurrent chemotherapy, because it will increase the rate of esophagitis. Now, what are the organs at risk constant that we should consider before we finalize the plan of radiation therapy in this particular patient? The lung V20 should be less than 30 to 35%. I'll come into the details why we should do that. So these are the organ at risk constant that we should follow. Now, these are the outcomes of CTRT, as you can see from the 2009 to 2017 till the published result of Pacific. We have increased the median overall survival from 22 months to approximately 30 months. And the 5-year overall survival and the 3-year overall survival has also increased from 30% to 44%. So the results of the treatment has improved due to the concomitant administration of the chemotherapy, better radiation therapy technique, and immunotherapy after the completion of chemoradiation therapy. Now, what are the complications of chemoradiation therapy? There are various complications that can happen and that can go wrong when you are planning for chemoradiation therapy. The first and the foremost is the radiation pneumonitis. So fortunately, in good hands, the rate of grade 3 pneumonitis is not more than 20%. The esophagitis is also one of the main complications. The radiation-induced heart diseases is now coming into the picture after the published result of RTOG 0617. So what are the predictors of pneumonitis? How can we predict the pneumonitis rate, whether the patient will be having a radiation-induced pneumonitis or not? The lung minus PTV V20 gray has very significantly correlated with the incidence of pneumonitis. As you can see in this particular picture, Graham et al. Has shown that if the V20 volume is less than 22%, there are no risk of radiation-induced pneumonitis. But if you can increase the V20 to more than 40%, and it will depend upon your volume, it will depend upon the location of the primary tumor, the nodal status. If the V20 is more than 40%, then it will have approximately 20% risk of grade 3 to grade 5 toxicity. So we should be considerate in terms of reducing the V20 volume, so because it will impact the quality of life of the patient. And this is an individual meta-analysis, some individual patient data meta-analysis published by David Palmer et al., where they have considered the patient into high risk, intermediate risk, and low risk, depending upon the type of the concomitant chemotherapy, age of the patient, and mean lung dose. If we follow this, there is a better chance that the patient would be, then you can triage the patient depending upon the high risk, intermediate risk, and low risk. Now, can we predict the esophagitis? Because we know that there are nodal stations involved. So preferably in the subcarinal node are most commonly involved in lung cancer, in locally advanced non-small cell lung cancer. And the chemotherapy and the radiation therapy can have a grade 3 to grade 4 esophagitis rate. And it usually starts from 4th to 5th week onward. So we should be mindful of that. If the mean dose is more than 34 gray, the chances of esophagitis are very high. The concomitant administration of the etoposide chemotherapy can also increase the risk, the V60 volume. And this is also the published IPD meta-analysis by David Palmer et al., where they have considered the low risk, intermediate risk, and high risk, so based on the volume of the 60 gray received by the esophagus. Now, coming to the cardiac toxicity has gained much more importance in the last 5 to 10 years. So, because we know that the hard doses have a very significant impact on the overall survival in breast cancer and in the lymphoma patient. But in lung cancer, with the improving survival rate, so because of the targeted therapy and the immunotherapy and the salvage treatment after the completion of CT-RT or surgery, the doses received by the heart are a direct impact on overall survival. As you can see, the heart doses of V5 means the 5 gray received by the heart has a direct bearing on the overall survival. But we do not have any dose specific constraint directly to the heart, because heart is not a single organ. There are various volumes like the left atrium, right atrium. There are various toxicity that can arise from the concomitant administration of chemotherapy and radiation therapy and immunotherapy. So we should be mindful about the radiation doses, and we should try to attempt to reduce the heart doses as much as possible, because with the improving survival rate in non-small cell lung cancer, so these patients are at higher risk of delivering or having a risk of cardiac toxicity. We are still not aware what sort of cardiac toxicity will happen, but the majority of them will have a heart failure, maybe left ventricular or right ventricular. Heart failure is the most common complication. Now, for the last bit, what is the role of post-operative radiation therapy after the chemotherapy and the surgery, whether it is beneficial or detrimental? Till the last decade, we were still debating about the role of post-operative radiation therapy, but with the published result of 2 randomized control trials, the first one is the Chinese PORT-C randomized control trial. The DFS has slightly improved, but not to a statistically significant level. So the DFS and overall survival after the administration of post-operative radiation therapy does not improve the results of PFS and OS. And the same has been confirmed in the LUNG-ART trial of the European, that the post-operative radiation therapy did not improve the DFS and the overall survival to a statistically significant level. So if you are considering for the examination that whether PORT should be given, so the answer would be no. But in clinical practice, you should have to see whether the nodes are only one node is involved, or multi-station node is involved, or extranodal extension were there. So these are the clinical practice and that we have to take into consideration in the multidisciplinary tumor board. Now, the last slide about the prophylactic cranial irradiation. So because these patients are at high risk of brain metastasis, there was an attempt from the RTOG group to conduct a randomized control trial of PCI versus observation after the completion of standard therapy, and the trial has not met the sample size accrual. However, the 10-year overall survival was not different between the PCI or versus the observation group. However, the 10-year rate of brain metastasis was significantly reduced, but we have to take into consideration this is not a complete planned accrual, and we should not consider the patient for PCI as long as we do not have the randomized control trial. So with this, I would like to conclude my talk. If there are any questions, I would be happy to answer.
Hi, Anil. Dr. Vinay here. I just wanted to know about the pneumonitis. How do you differentiate radiation-related pneumonitis versus immunotherapy? Because in stage 3, we generally give durvalumab post-CT-RT. So when patient develops pneumonitis, how do you differentiate whether it is radiation-related or immunotherapy-related?
So basically, it is very difficult to differentiate between the radiation-induced pneumonitis or any systemic therapy-related pneumonitis. I will call it as a systemic therapy-related pneumonitis because the chemotherapy can also cause some amount of pneumonitis, and immunotherapy also can potentiate the pneumonitis after the completion of chemoradiation therapy. But there is one factor that we can differentiate. If there is a straight anatomic border line where we have delivered the radiation doses, for example, 20 gray. So you can clearly see the demarcation between the pneumonitis as well as the normal lung if you have done the radiation therapy. So if the pneumonitis patches are appearing in a non-irradiated zone, then you can definitely say that it is a systemic therapy related pneumonitis. But if it's in the radiation portal, then it would be difficult to say, but it is more likely to be radiation induced because we know that the radiation in a higher doses in that particular volume has been delivered. So there is a straight non-anatomic border that can be seen in the radiation pneumonitis portals.
Yeah, earlier we used to use a lot of 3Ds. Yes, you can correlate with 3D portals, but now it is VMAT. So all over the lung, radiation spillage will be there. So now my next question is whether that truly radiation portals matters in VMAT setting. And second, V20 or V5, which is most important in predicting pneumonitis?
In the IMRT and the VMAT area also, the doses which are significantly correlated with the radiation pneumonitis are the V20 and not the V5. V5 is not going to give you a prediction of the pneumonitis rate. However, we should keep it as low as possible. But if you see, the V20 and the mean lung dose are directly in correlation with the incidence of radiation pneumonitis. So V20 and V20 should be considered.
Thank you.
Anil, post NACT,
Yes, sir.
radiotherapy portal.
So post NACT radiotherapy portal, the nodal portal will not change. For example, if you have a 2-hour node and the 4-hour node, then especially the mediastinal portals are not going to change. Especially and in case of the only parenchymal margin. For example, if you have a tumor in the right lower lobe, which is approximately 7 centimeter, and after the completion of chemotherapy, it has reduced to 3 centimeter, we really don't know whether we should treat the 7 centimeter, because if you treat 7 centimeters, then there's no point of giving neoadjuvant chemotherapy. Yeah, for example. So in that particular scenario, we should consider the post-chemotherapy volume, approximately 3 centimeter, but the mediastinal nodal volume will be the same. So the primary will be reduced, but the nodal volume will be the same as that of the pre-chemotherapy.
Thank you. I think Sabita is not there. Maybe Priya can take this question. Post NACT surgical margin, same, different?
Intrasurgical complications, sir?
Margin for post NACT. So you have given NACT and the tumor has shrunk from 5 to 2.
Right.
Does the margin change or it remains same, especially the bronchial one?
So if you're converting it to something like a sleeve resection, we would do with a little less maybe, but which has to be negative on frozen. But other than that, if it is planning to be a lobectomy, it still doesn't make a difference. So yes, that's one advantage of giving NACT. We can potentially convert a pneumonectomy maybe to a sleeve resection or something. In that case, yes, it does make a difference, but the frozen has to be negative.
Thank you. Thank you both.
Yes. Thank you.
So thank you, Anil, wonderfully, and thank you, interactive audience. So next we'll go to the sessions, concurrent chemotherapy, regimen selection, result efficacy, complications, compliance by Dr. Amit Agrawal, who is Assistant Professor, Department of Medical Oncology, AIIMS Raipur. Amit.
Hello, sir. Am I audible?
Yeah, you're audible, Amit.
Yes. Hope my slides are visible, sir.
Yeah, your slides are also visible.
Then benefit over radiation alone. Then what are various regimens which are available and what are the evidence for these regimens? Then we'll compare various chemotherapy regimens. We know that CTRT is given either in the form of concurrent chemoradiation or sequential chemoradiation. We know that time and again, concurrent chemoradiation has proven superiority over sequential one. This is the screenshot from NCCN guidelines where we can see T4 stage, whether it is N2 or N3, there is definite role for definitive chemoradiation. Similarly, if it is N3 nodal disease, irrespective of T stage, definitive CTRT is the treatment of choice. For T3 stage, if it is invasive and N2 nodes are there, definitive CTRT is there, the treatment of choice, standard of care. And similarly, if a patient has undergone resection, if N2 nodes are there and especially if margin is positive, then it is CTRT, which is the treatment to be offered. This is from ESMO guidelines, which also suggests N3 disease or extensive mediastinal N2 infiltration. Then non-surgical multimodality treatment, that is CTRT, is the treatment of choice. So what are the benefit of CTRT over definitive RT alone? So we know that until 1990s, the radiotherapy alone was standard of treatment, but with very dismal or very minimal survival. The 5-year survival rate was less than 10%. But now CTRT has been the standard of care, and we all know the principle of combined chemoradiation. The radiation takes care of loco-regional disease, and chemotherapy has basically two effects. It takes care of distant metastasis, although the doses of chemotherapy given here are not that much what we give in the neoadjuvant or adjuvant or in the palliative settings, but still it takes care of distant metastasis. And the main effect is it acts as radiation sensitizer, and which increases the effect of radiation treatment. So there are various meta-analyses which time and again have proven the benefit of concurrent chemo radiation over RT alone. This is one meta-analysis published in BMJ in 1995, which included 22 trials, almost 3,000 patients. And out of them, 11 trials which have used cisplatin-based regimen as concurrent chemotherapy, 1,700 patients. And they found out that these trials which used cisplatin-based chemotherapy regimens had strongest evidence in effect in favor of chemotherapy. And the absolute benefit of 4% at 2 years and 2% at 5 years. So if you take this 2%, numerically it may not sound great, but when I told that before the era of CTRT, when we were giving RT alone, the 5-year survival rate was less than 10%, then 10%, and adding 2% over it, it sounds great now. So another meta-analysis which included almost 1,900 patients, and they used various chemotherapy regimens, these trials, and for cisplatin-based groups, they found that the odd ratio of decreasing the death at 1 year was 24%, and at 2 years was 33% reduction in mortality. So it again proven the efficacy of cisplatin-based regimen. Another meta-analysis which included 9 trials, and all these trials actually used platinum-based chemotherapy regimens, either cisplatin or carboplatin. They again found out that the hazard ratio of 0.89 for the survival, it means 11% reduction of the death, and the absolute benefit of chemotherapy at 2 years was 4%. Again, another meta-analysis which included 13 randomized controlled trials. They use various chemotherapy regimens. We can see here the regimens: platinum-based chemotherapy, carboplatin, cisplatin plus nevirapine, paclitaxel carboplatin, cisplatin etoposide, and so on. So what they found that with these 13 randomized controlled trials, at 1 and 2 years after treatment, the hazard ratio for overall survival at 1 year was 0.67, and at 2 years it was 0.57. So it again proven the efficacy of CTRT over RT alone in non-small cell lung cancer. So now we have clearly shown that there is benefit of CTRT over RT alone. These are the various regimens which are recommended by NCCN guidelines. Although apart from these, other regimens can also be used and is being used, but the preferred regimens for non-squamous non-small cell lung cancer are the pemetrexed carboplatin or pemetrexed cisplatin, then other regimens like paclitaxel carboplatin and cisplatin etoposide. For squamous, paclitaxel carboplatin and cisplatin etoposide. So now we'll see the evidence for all of these regimens. ESMO guidelines also suggest the efficacy of the cisplatin-based regimen should be used for concurrent chemotherapy. So cisplatin etoposide, there is one phase 2 trial of it. It was a single-arm phase 2 study where cisplatin etoposide was given as concurrent chemotherapy regimen, and what they found that the objective response rate of 84% with 68% CR rate, and the overall survival at 1 year was 70%, and at 2 years was around 40%. So this showed the efficacy of this regimen. Another regimen which is widely used is paclitaxel carboplatin. There are various phase 2 trials, single arm, 3 arms, and other regimens. So this is one phase 2 study of paclitaxel carboplatin where it showed the median OS of 20.5 months and also 1 year OS of 56%. Here it was given weekly paclitaxel and carboplatin, and the grade 3, grade 4 esophagitis was 46%. Another phase 2 study of paclitaxel and carboplatin where it was given in 3 different sequences. In one sequence, it was given as sequential chemo radiation. Another, it was given as induction chemotherapy followed by CTRT, and in another regimen, CTRT followed by consolidation paclitaxel carboplatin. And what they found out that the median OS was nearly the same. There was no statistical difference, although numerically the OS was higher in the arm 3. That was concurrent chemo radiation followed by consolidation paclitaxel carboplatin. And the esophagitis part, grade 3, grade 4 esophagitis, was seen in the arms where concurrent chemo radiation was given, that is arm 2 and arm 3. It was 19% and 28%. Another phase 2 trial of paclitaxel and carboplatin, it was given as, it was a single arm phase 2 study, and here also objective response rate of 71% with grade 3, 4 esophagitis of 38%. So another taxane platinum combination, docetaxel and carboplatin, we have 2 phase 2 studies for these where these have been given either in the weekly form or 4 weekly regimens, and they found that in one study the median OS was 12 months, and in another study objective response rate was 79%. The esophagitis grade 3, grade 4 toxicity was in the tune of 20%. So now coming to the randomized trials, we have different randomized trials which have compared the different chemotherapy regimens. One phase 2 study which compared paclitaxel and carboplatin with concurrent cis-etopo, and they found that they used 65 patients were randomized, and they compared both these regimens with the RT dose of 60 gray, and they found that the 3-year overall survival was better in etoposide cisplatinum arm, that is 33%, as compared to 13% in the paclicarbo arm. Obviously, the hematological toxicities were more with cis-etopo arm, but the radiation pneumonitis was seen more commonly with paclicarbo arm. Again, in the next phase, it was done as a phase 3 study. They compared both these 2 regimens, and they found that the median survival was nearly same. There was no statistical difference, but the grade 3, grade 4 esophagitis was seen more commonly with cis-etopo arm, although the radiation pneumonitis again was seen more commonly with paclitaxel carboplatin arm. There was another phase 3 study where they compared this paclitaxel carboplatin with 2 other regimens. One was cisplatin, vindesin, and mitomycin C, and another chemotherapy regimen, irinotecan and carboplatin. These 3 arms, and what they found that there was nearly similar long-term outcome, but the paclitaxel carboplatin arm has a safer toxicity profile. Then another phase 3 study where docetaxel cisplatin was compared against MVP regimen, and the objective response rate were similar, no statistical difference. The grade 3, grade 4 hematological toxicities were more commonly seen with MVP arm, while the esophagitis was seen more commonly with DP, docetaxel cisplatin arm. So with these randomized trials, we have shown that cisplatin-based regimens are probably having superior effect in terms of efficacy as compared to other regimens, but albeit with more toxicity, especially hematological toxicities, esophagitis, etc. Then pemetrexed cisplatin, which has been approved for use in non-squamous small cell lung cancer. This was a PROCLAIM study where previously untreated stage 3A, 3B non-small cell lung cancer patients of performance status 0 to 1 were randomized into 2 arms. In arm A, pemetrexed cisplatin was given with radiation for 3 cycles, followed by 4 cycles of maintenance pemetrexed. In another arm, the etoposide cisplatin was used as concurrent and the consolidation regimen. And we can see here the graphs, the survival curves are overlapping to each other. There was no statistical difference between the two. Actually, it was a superiority study, but the superiority of pemetrexed cisplatin could not be proven. This is the side effect profile, which we will be discussing later in coming slide. So we have shown that cisplatin-based regimens are the one which have shown their efficacy as the concurrent chemotherapy regimens, and we should use them whenever possible, whenever feasible. Now, coming to the complications of different chemoradiation regimens, we'll discussing through the various trials. This is from the trial where the cis-etopo was compared with the paclitaxel. We can see here the esophagitis in the cisplatin etoposide arm is 20% as compared to 6% in the paclitaxel arm. But if we see the radiation pneumonitis, it is more commonly seen with paclitaxel arm. Similarly, the gastrointestinal toxicity is also more commonly in the paclitaxel arm. So probably paclitaxel concurrent chemotherapy is causing more radiation pneumonitis as compared to other regimens. This side effect chart is from the trial where 3 regimens have been compared. We can see here the MVP regimen, irinocarbo regimen, and paclitaxel regimen. Almost all the toxicities, whether it is neutropenia, leukopenia, anemia, febrile neutropenia, all the toxicities are less with paclitaxel regimen. But if we see the esophagitis, which has been seen more commonly with paclitaxel regimen, pneumonitis, although statistically not significant, also more common with paclitaxel regimen. Now coming to the dosages versus MVP comparison, we can see here the hematological toxicities are more commonly seen with MVP regimen. However, the dysphagia or pneumonitis are seen more commonly with the docetaxel cisplatin arm, although statistically not that much significant. From the PEMCIS versus etopo-cis trial in the non-squamous non-small cell lung cancer, we can see here the hematological toxicities more with the arm B, that is the cis-etopo arm, and febrile neutropenia complication also seen more commonly with the cis-etopo arm. So PEMCIS appeared to be safer as compared to the cis-etopo for non-squamous small cell and non-small cell lung cancer. So how to choose different regimens? How to choose amongst these different regimens? We know that whenever we choose chemotherapy for any situation, whether it's NSAT, palliative, whatever, we take these factors into account, age, but we know that it does not, the chronological age does not matter. What matters is the physiological age most, then comorbidities, nutritional status, then lung function, any previous predisposing factors for pneumonitis, then performance status, and then platinum eligibility. As we already told that whenever feasible, we would prefer cisplatin-based regimens. Then also the toxicity profile of chemotherapy. So all these factors will have to take into account. So there is one meta-analysis which has compared these various regimens with concurrent radiation. They have taken articles from various libraries, including PubMed, Embase, Cochrane Review, and we can see here various randomized trials have used for this meta-analysis, whether it's phase 3, phase 2. Various chemotherapy regimens have been used: cisplatin, etoposide, paclitaxel, carboplatin, and so on. And what they found that if we take the single trials, we can see here the difference between etoposide cisplatin versus paclitaxel carboplatin. There is significant difference between these two regimens. The hazard ratio is for overall survival is 0.85, and for PFS it is 0.66. And the objective response rate is almost similar. The hazard ratio is 1. So for different trials, it has been done. And what they found that out of total 14 randomized controlled trials with nearly 3,000 patients, and with the direct comparison meta-analysis, the etoposide cisplatin was more effective than paclitaxel cisplatin or paclitaxel carboplatin in terms of overall survival and progression-free survival. The all regimens comparison did not produce a statistically significant difference in survival. But still, we can make it like etoposide cisplatin has proven superiority in terms of efficacy, but side effect profile wise, paclitaxel seems suitable option. Then I would like to also highlight that there is ongoing trial at TMH Mumbai, which is comparing these two regimens in the concurrent CTRT setting. Then just to highlight, there are various ongoing concurrent immunotherapy trials with lung RT. This is the brief summary of those trials. So to summarize, the platinum-based chemotherapy regimen remains the standard of care for concurrent CTRT, although associated with more hematological toxicity. Whenever feasible, we should give cisplatin-containing regimen, that is cisplatin etoposide. In other patient, taxane platinum combination can be used with more safety. And then combination of concurrent immunotherapy or TKIs with RT will probably change the outcome in this set of patients. Thank you.
Amit is there? Yeah, still.
Yes,
Yeah.
sir. Yes. Sir.
So just Amit, one question from my side. When we are now looking at adjuvant maintenance durvalumab, so do you think now the regimen selection becomes more imperative? Like, can we avoid paclitaxel carboplatin? And second thing is that if somebody is really going to take, say, maintenance durvalumab, can we really avoid giving a then concurrent regimen? I think Kumar sir is also there, so he can also throw some light. So two questions. Somebody is going for durvalumab, maintenance durvalumab.
Yes,
Can we avoid concurrent chemo, or shall we not use then paclicarbo? Because definitely pneumonitis is much more.
Correct.
Or
Yes,
that should also determine.
So first part, I think so. What Amit made a very pertinent point in the beginning. Maybe we missed that if you give only radiotherapy and then you add chemotherapy to it, it is a concomitant chemoradiation which adds 4% or 2% we talk about. But if you take radiotherapy and we have chemotherapy added to it like neoadjuvant, then the addition is around 8 to 10% odd improvement in outcome. So total outcome difference will be around some 10 to 12% overall. That's removing a chemotherapy will not be a good idea. That's the first comment. I do agree in future, if we have some more wonderful immunotherapy, it is a possibility. But at this moment, if you can, good to give it. Second, your question is very valid. What do we do with taxane? There is a decent data that taxane does lead to more reactions. Lung reactions are more, pneumonitis is more. So there is a issue regarding this. A good thing is that we do have multiple options, but somehow as a medical oncologist, we are so comfortable with weekly paclicarbo that we keep using it. And we don't have a definitive data that it harms, so we don't change it. But I think so. Your question is pertinent that if you can avoid it is better. You have a pemetrexed platinum, you have a etoposide platinum, you have vinorelbine. You have data from a whole lot of these drugs in combination to given with the RT. I don't know what Amit thinks. Amit, hopefully you agree with my comment.
Yes, sir. Definitely. After your comments, there is no need to any further comments, sir.
Somehow I don't know, but in our practice, I don't know. Vinorelbine cisplatin is really less represented. Maybe I think others can have. So definitely we are moving to the next session, which is sponsored by AstraZeneca, and I invite Dr. Srinivas from Senior Consultant Medical Oncologist from SCG Mysore. He will be speaking about maintenance therapy in locally advanced stage 3 NSCLC durvalumab. Over to Dr. Srinivas.
At the outset, I would like to thank organizers for giving me this opportunity to talk on this topic. After all neoadjuvant and surgical and radiation topics, there comes locally advanced stage 3 non-small cell lung cancer we do commonly see in our routine clinical practice. So just a quick introduction. The burden of lung cancer is huge, stands second most cause in males. And management of unresectable stage 3 non-small cell lung cancer is definitely a multidisciplinary approach. As you can see, surgeons, thoracic surgeons, pulmonologists, medical oncologists, radiation oncologists, and pathologists combined together will take a decision. A lot of diagnostic and treatment evaluation happens, including pulmonary function test, bronchoscopy, FDG PET, and pathological media and lymph node evaluation and brain MRI. So definitive concurrent chemoradiation is a standard of care for stage 3 unresectable non-small cell lung cancer. Concurrent chemoradiation is superior to sequential chemoradiation. We saw a previous speaker saying that. A lot of chemo regimes have been used along with radiotherapy in non-small cell lung cancer. I don't want to repeat the same thing. It's already been discussed. So the unmet need in stage 3 non-small cell lung cancer, even with concurrent chemoradiation given as a curative intent, the 40% of locoregional metastasis happens, and there is a 50% distant metastasis with a median PFS of 8 to 12 months and the 5-year overall survival of 15 to 25%, which is not enough. Something has to be done more. So there is a lot of attempt to make it better. So various trials have been conducted to evaluate consolidation therapy with a very modest benefit, and no phase 3 studies of consolidation with chemotherapy, a target therapy, or vaccines have demonstrated a PFS or a OS benefit in these patients. So if you can see this evolution of treatment approach way back to 1960s, RT alone, then came sequential chemoradiation versus RT and concurrent chemoradiation, which we discussed with a no OS benefit. So how to improve the this subset of patients? So there has been concurrent chemoradiation to be considered as a standard of therapy for patients with good performance status, while sequential CRT remains an option for patients with a marginal performance status. To improve prognosis further, strategies like increasing radiation dose, induction chemo, consolidation chemo were evaluated in addition to concurrent chemoradiation, with no significant improvement in OS was seen with these. So immunotherapy is increasingly being recognized as a safe and effective option as an adjunct to concurrent chemoradiation. So this is our first phase 3 randomized double-blind placebo-controlled multicenter international study, specific study design. Patients with stage 3 locally advanced unresectable non-small cell lung cancer who have not progressed following definitive platinum-based concurrent chemoradiation, 18 years or older with a good performance status with an estimated life expectancy of more than 12 weeks, were randomized on a 2:1 fashion in experimental arm durvalumab 10 mg per kg 2 weekly for up to 12 months, around 470 odd patients, and another arm placebo at 10 mg per kg 2 weekly for up to 12 months. So the radiation and the starting of the treatment, the gap of 1 to 42 days was seen in the study. The primary endpoints, PFS by BICR, and overall survival. The key second endpoints like overall response rate, duration of response rate has been measured. So these are the baseline characteristics. As you can see, it's well matched for age, sex, race. And in this study, there are around 50% of the patients in 3A and around 45% in 3B in both the groups. If you can see the EGFR mutation status, around 6% of the patients were EGFR positive, but this was not the primary priority of the study, but it was analyzed. So the PD-L1 expression levels were also taken into consideration, but again, this was I'll tell you when I come to the post-hoc analysis. So the PD-L1 expression TC less than 25% was seen around 40% of the patients in durvalumab arm and 45% in placebo arm, and TC of more than 25% in 24% of the patients in durvalumab arm and around 18% in placebo arm. So smoking, current smokers around 17%, 16% in durvalumab arm and 16% in placebo arm. So nearly almost 27% of the patients received induction chemo with variable regimes. So all patients received 2 or more overlapping cycles of platinum-based chemotherapy concurrent with RT. So patient may have received prior chemotherapy in more than one context. Majority of, that is 99.7%, had received concurrent chemoradiation prior to the study start. They had received induction chemotherapy. So these are updated 5-year overall survival in intent to treat population. So as you can see, around 43% of the overall survival rate of 43% was seen at the cutoff of 5 years versus 33% in placebo. Is something very overwhelming in so-called unresectable stage 3 lung cancer. So this is the first and only approved IO to demonstrate 42.9% of OS at 5 years. So this is the updated progression-free survival in blinded independent central review in intent to treat population. So you can, as you can see, the PFS rate of 33.1% versus 19% at 5 years follow-up. So this is again a first and only approved IO to show sustained and durable PFS of 33.1% benefit at 5 years. So if you see the first subsequent therapy after discontinuation of durvalumab, even in durvalumab arm, 41% of patients and 54% of the patients in the placebo arm received a subsequent disease-related anti-cancer therapy. That means the subsequent therapy, progression was also reduced even in spite of discontinuation of durvalumab in this study. So systemic therapies were the most common first subsequent anti-cancer treatments in both durvalumab and placebo arm. But as you can see in the durvalumab, it was 33% and it was almost 13% more, that is 46% in placebo arm. Even if you see the patterns of disease progression, as you can see in the left side, durvalumab intrathoracic progression is seen around 36%. And if you see in the placebo, it is around to the tune of 48%. If you see the extrathoracic lesions, it is around 7% in durvalumab arm and almost nearly double, that is 13% in placebo arm. So new lesions identified within the lung parenchyma or generally chest wall, including the diaphragm, were categorized as intrathoracic, where all the other lesions are categorized as extrathoracic. So intrathoracic progression was the most common in durvalumab arm versus placebo, that is to the tune of 80% versus 74%. But reduced rate of first progression was seen in durvalumab arm, that is 45% versus placebo, that is 64% of the patients. So the time to intrathoracic progression only or death as per BICR, the durvalumab improved the time to intrathoracic progression when compared to placebo. It is the median time was 25.2 months versus 9.2 months in placebo with a hazard ratio of 0.55. So there was a reduction in new extrathoracic lesion which was seen in durvalumab arm. It is around 8% at first progression versus placebo, which is almost double, like 16.5% in intent to treat population. And approximately 2/3 of patients had 1 or 2 extrathoracic lesion at first progression in subpopulation with progression. Even the number of lesions, if you see in the durvalumab arm, the number of lesions and the progression to the number of lesions were less compared to placebo arm. So this is a safety summary. Grade 3 or 4 side effects were seen in around 30% of the patients in durvalumab arm, which is slightly higher compared to placebo. So this was the French study to see when exactly you need to give durvalumab after concurrent chemoradiation, because a lot of discussion happened about pneumonitis. So what they have done in that specific trial also, the patient should have resolved pneumonitis or at least not more than grade 2 pneumonitis. If the patient has more than grade 2 pneumonitis, then those patients are not actually eligible for the durvalumab study in a specific study. So this is another French study where they analyzed around 591 patients enrolled with the durvalumab versus placebo. So this is the baseline characteristics, which is very similar to the Pacific trial actually. So in this study, around 78.5% had a partial response, 15.2 had stable disease, and 6.3 had CR. So the median interval between the end of concurrent chemoradiation and effective initiation of durvalumab was actually known in 161 patients in this French study. So around 2.5% of the patients received started durvalumab less than 2 weeks. And majority of the patients, that is around to the tune of 58% of the patients, they had the durvalumab between 14 to 42 days. Whereas more than 42 days, around 40% of the patients were started beyond 42 days of completion of concurrent chemoradiation. But what they found out in this study was the responses were like what was observed in Pacific study, despite almost 40% of the patients received durvalumab 42 days after CRT. So the concept that we need to hurry up in starting the durvalumab immediately after radiation may not be possible in many times, because patients recovery from pneumonitis, patients has to recover from the concurrent chemoradiation toxicities. In certain cases, you can actually wait up to 30 to 40 days in starting the durvalumab. That is what they have shown. So the 5-year survival is important endpoint. Optimum concurrent chemoradiation followed by IO should be the standard of care in all standard 3 unresectable patients, and converting stage 3 lung cancer into a never progressing disease is an ideal dream. So the key take-home message is Durvalumab demonstrated a statistical significant clinical meaningful improvement in OS and PFS versus placebo in this specific trial. The median OS was 47.5 months for Durvalumab versus 29.1 months for placebo with a hazard ratio of 0.68. The median PFS was 16.9 months with Durvalumab and 5.6 months with placebo with a hazard ratio of 0.51. OS and PFS improvement with Durvalumab was demonstrated across all pre-specified subgroups. The 5-year overall survival rate was almost 43% of patients randomized to Durvalumab remain alive at 5 years compared to 33% in the placebo group. A third remain both alive and free of disease progression in Durvalumab arm, demonstrating OS benefit and PFS benefit in this specific regime. Patients receiving Durvalumab had a lower incidence of new lesions, including new brain metastasis compared with patients receiving placebo. Tolerability profile of Durvalumab was acceptable. Low-grade pneumonitis is not a deterrent to use Durvalumab. And as I showed you in a French study, Durvalumab was started beyond 42 days after CRT and showed similar responses to the ones observed in specific data. Thank you. If any questions, I would like to.
So, good morning, everyone. And next is the debate. And what's the debate next one? Anyone? We have some students here. Can the students put their hands up? All the students who are here? Good? 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 I was told there are 14, 15 of them. हाथ पूरा ऊपर कर लो यार, इसमें क्या जाता है? अभी लाफिंग क्लब कभी देखे नहीं ऐसे करके ऊपर. Very good. So what's the debate? Next debate. Anyone? किसी ने नहीं बोलना? Everyone is a backbencher like me. Debate क्या next one? Anyone? वो जोर से बोलो यार, ऐसे आवाज थोड़ी. खाना नहीं खाया? अरे ब्रेकफास्ट नहीं दिया? किधर तरुण ब्रेकफास्ट नहीं दिया इनको? ब्रेकफास्ट नहीं दिया? दिया? ब्रेकफास्ट किया कि नहीं तुम? टॉपिक क्या है? व्हाट इज द टॉपिक फॉर डिबेट?
Systemic therapy in sequencing in early stage cancer, neoadjuvant versus adjuvant.
Neoadjuvant versus adjuvant. Very good, very good. अभी स्टूडेंट्स में से how many have given neoadjuvant chemotherapy or systemic therapy in lung cancer? And get up, फटाफट बोलो, टाइम नहीं है. There is a speaker there waiting for it. Neoadjuvant दिए? You can get up and keep speaking. There were some students who put their hands up. अरे उधर बेंच में नहीं है कोई? You can get up. No one. किसी ने नहीं दिया? अगर नहीं दिया तो बोलो you have not given. Anyone this side? No. अच्छा. Adjuvant की तुमने भी नहीं दिया वेंकटेश? तो बोला क्यों नहीं? हाँ तो नहीं बोला तुमने? वो बोला कि नहीं सर, अभी सब ना बोले तो मेजोरिटी के साथ. अभी तो डेमोक्रेसी है, जो मैक्सिमम लोग बोलेंगे हम तो वही बोल रहे हैं. तो सर अच्छा ओके. एडजुवेंट कीमोथेरेपी दिया वेंकटेश? दिया कि नहीं दिया? अच्छा. इधर में एनीवन दिया? ये एडजुवेंट कीमोथेरेपी लंग कैंसर बोल रहा हूं मैं. वेरी गुड. दर्शित? एनीवन ऑन दैट साइड? अरे उधर कुछ हाथ तो दिखाया था. मैं फिर से बोलूंगा, स्टूडेंट्स पुट योर हैंड्स. हाथ दिखाओ मुझे अपना. कौन लोग है? हु आर द स्टूडेंट्स हियर? और भी लोग. एडजुवेंट कीमोथेरेपी दिया लंग कैंसर में या नहीं दिया? कभी नहीं दिया? एक भी नहीं दिया? कोई इंपॉर्टेंट इंफॉर्मेशन है. और देयर वाज समवन इन द लास्ट बेंच. एनी स्टूडेंट्स? नो? हाथ तो दिखाओ यार. एडजुवेंट कीमोथेरेपी लंग कैंसर में दिया या नहीं दिया? हाँ या ना? जोर से बोलो. अब तुम इधर भी खाना नहीं खिलाया तुरंत तुमने, ये गलत है. वो सबको खाना खिला के लाना चाहिए था. दिया या नहीं दिया? हाँ या नहीं? नहीं. तो व्हाट इट मींस कि देखो, लंग कैंसर लोकलाइज्ड ट्यूमर कॉमन नहीं होते. दैट विल इंपॉर्टेंट टू लिसन कि भाई हम इसमें क्या करना चाहिए, कल अगर आपके पास आएगा डिसीजन तो लेना पड़ेगा ना. You might have given or not during your training, but when you start your practice, the patient is going to ask you, should I be, giving treatment or not? And should I be giving early or should I be giving late after surgery? Correct? बोलना पड़ेगा नहीं बोलना पड़ेगा, किसी और को बुलाओगे फिर कि नहीं, कोई और फोन द फ्रेंड, ये तो नहीं करोगे ना. तो चलो, इट विल बी वेरी इंपॉर्टेंट. लेट्स लिसन टू पीपल एंड लर्न कि भाई एडजमेंट देना चाहिए या पहले देना चाहिए या बाद में देना चाहिए. आशा, आई जस्ट टुक, ठीक है. तो जो पहला किसका है टॉक है? डॉक्टर कृपा इज देयर. डॉक्टर कृपा, एंड यू आर गोइंग टू टीच अस न्यू एडजमेंट क्यों देना चाहिए. आई थिंक सो वी आर मिसिंग सबिता हियर. सबिता ने पढ़ाया ना न्यू एडजमेंट कीमोथेरेपी, एज मच यू वांट, डोंट वांट. उसने क्या बोला? यू विल बी गिविंग इट, सो लर्न व्हाई वी शुड बी. हाँ, कृपा, podium is yours.
Good morning, everyone. First of all, at the outset, I would like to thank Dr. Kumar Prabhash sir, my teacher as well as mentor, for giving this opportunity, and all the organizers. And also thanks to Kumar sir for priming everyone and making everyone attentive. So now the very important discussion, neoadjuvant versus adjuvant. I hope Rudul Malhotra is online listening to me, the points which I'm making. I'm going to debate regarding neoadjuvant, why we should give neoadjuvant in lung cancer. So if you see, as the stage increases, the outcome of the lung cancer, be it a clinical or pathological stage, as the stage advances, the outcome is going to be dismal. We see the recurrence are pretty high from stage 1B to stage 3. These are considered as curative lung cancers. So if you see the analysis, like the analysis from both AIMS, TMH, as well as PH Chandigarh, significant proportion of curative cancers fall in stage 3. This is the TMH data by Narona et al. And this is the PGMR data by Kaur et al. Significant patients fall under stage 3 apart from the metastatic setting and curative setting. So, and stage 3 is quite heterogeneous. It is not equal, my friend. It's quite heterogeneous. Incidental N2, potential resectable N2, unresectable N2, multiple. It's a bag of different clinical conditions. And we have to be very open regarding the treatment options. So considering for the timing of treatment options in early cancer, these are the pros as well as cons for the neoadjuvant and adjuvant setting. So the Vantaby et al. After significant analysis, he said that an increased percentage of patients completing the planned dose of chemotherapy, that's the compliance to chemotherapy, is very high in neoadjuvant setting. And the ability to treat the micrometastasis, the tumor cell dissemination preoperatively, is very high with neoadjuvant therapy. The ability to evaluate the response to chemotherapy as a prognostic indicator. We all really hear a lot about this in breast cancer, but lung cancer, it's upcoming and validated data. But there is no improvement in resectability pertaining to chemotherapy. That's a neoadjuvant chemotherapy versus adjuvant chemotherapy. So later, like I just want to discuss, brush up regarding the chemotherapy trials, neoadjuvant versus adjuvant, NATCH trial. It's a very famous trial. It's like the first ever trial which was validated among all the oncology peers. It's neoadjuvant versus adjuvant was studied. This is the trial design. And significantly, the absolutely two curves are bang on. There is no difference in the outcome. The 5-year DFS is like equal in both arms, both neoadjuvant as well as adjuvant. But more patients were able to receive preoperative than adjuvant treatment. And the retrospective analysis subsequently, Brand et al. Published, it also showed there is no difference in the DFS or OS, be it a neoadjuvant or adjuvant. The similar thing we have seen breast cancer as well. The same here replicated with chemotherapy, I'm telling. Please mention like it's a chemotherapy. So, but the compliance to chemotherapy, the toxicity of chemotherapy is much better in patients who received in neoadjuvant setting than the adjuvant setting. And the benefit is like started opening the Tovey et al. In T4. The T4, we all know there is a lot of dicey situation whether to give before or not, whether to give neoadjuvant or adjuvant. They studied after giving neoadjuvant, there is significant improvement in the resection rates. That's a positive margin is got decreased as well as overall survival got increased by giving neoadjuvant therapy. This was the most talked paper than in surgical peers. I'm sure Kumar sir will agree with me in LACE meta-analysis all the time when we meet a surgery peers, they do say just 5% benefit. But things changed over the time. From my residency first year till now, a lot of things has changed in lung cancer. And coming to the prehabilitation, not just the treatment, but prehabilitation is also very important in lung cancer. As the time progresses, if you give 4 weeks of prehabilitation, the patient will have a good post-op recovery.
And meta-analysis on neoadjuvant therapy, which was published in Lancet 2014. So it included multiple trials, but 15 RCTs got included and 2,000 odd patients got included. The outcomes were again 5% benefit, similar to the adjuvant therapy in this as well. There is no difference in the both neoadjuvant and adjuvant outcomes. The preoperative chemotherapy was beneficial in distant metastasis, and very good compliance got noted again in the RCT. So what's the rationale for neoadjuvant therapy, immunotherapy? My friend Mrudul now, I think he must be shivering now. So if you see the neoadjuvant therapy, there's significant neoantigen load is there. In immunotherapy, we all know the biology of immunotherapy is like to prime for the antigens. So if I give a neoadjuvant therapy, lot of antigen load will be there and the T cells will get primed easily. The similar thing was published in Journal of Immunotherapy. That's a better priming. Tumor will be less heterogeneous if we start early, and the access to pre and post tissue and ability to assess the efficacy of therapy is very high if we initiate neoadjuvant immunotherapy. And also, after this, both chemotherapy and immunotherapy, the costly treatment has come. So pathologists were forced to work more. So they came up, the Travis et al., they published that PAT-CR as well as major pathological response are very important in lung cancer. PAT-CR, we all know, no viable tumor cells. And major pathological response, less than or equal to 10% viable tumor cells are noted. Not only that, they correlated retrospectively, there is a difference in outcome with the patient who attained major PAT-CR versus no PAT-CR, no major PAT-CR, in both squamous as well as adenocarcinoma. And these are the phase 2 trial. Out of this, the one stood like prominent is an NADIM trial. And these are the phase 3 neoadjuvant trials. Out of this, Checkmate 816 stood so prominent. And this is a phase 2 data of nivolumab alone. Remember this, in phase 2, initially they tested only nivolumab. It's going to help us in the patients who are not fit for chemotherapy. And again, they tested both immunotherapy plus chemotherapy combination. That's a NADIM trial, which is a path-breaking trial, which led to Checkmate 816 result like more prominent. So if you see this one, for it all, there's just 2 doses of nivolumab and 2 doses of atezolizumab. There is significant major pathological response and PAT-CR got noted. And later, atezo plus CT Xu et al. So still, this is not so mature, but again, the striking results were there. What's more important in NADIM study is all patients are stage 3. So the outcomes, we know that outcomes of stage 3 is very dismal. Lot of gray area is there, like how to treat these patients. So just 3 cycles of chemo plus immuno was given. Later surgery was performed. Again, 1 year of nivolumab was given in this study. If you see the outcomes, that's a PFS, OS, surgical outcomes, everything. There's a good PFS got noted, both intention treat as well as per protocol analysis. And OS was significantly, starkly outstanding. And if you see the neoadjuvant adverse events, the neoadjuvant adverse events are pretty low compared to the adjuvant adverse events in this study. So which is like really to be noted. And also the PAT-CR rates were as high as 63% in the NADIM study. Coming to the Checkmate 816, I'm a strong proponent of minimal therapy. If you are so, this trial is going to help you to tailor the treatment. So what's the Checkmate 816 design? It's a stage 1B to stage 3A. It's not just stage 3 like NADIM study. Here, Nevo plus chemo 3 cycles versus chemo followed by surgery, optional adjuvant therapy. There is no 1 year of nivolumab got included here. That's really beneficial, both financially as well as toxicity profile wise and compliance wise. If you see here, again, the stage 3 is the major chunk constituting 60% of the whole population. And 94% compliance to treatment is there. 94% people completed the neoadjuvant treatment. And also if you see, all the subgroups got a significant benefit. And the hazard ratio is 0.63 with 31.6 versus 20.8. If you see the PD-L1 more than 50 got more benefit and more stage, as the stage increases, the benefit is more. The PAT-CR, major PAT-CR also significant. So, and stage 3 got more benefit than the stage 1B2, but still the benefit is really stark. And OS, though it's not mature, but still it's really promising. So the surgery, already Dr. Sabita told, I'm not going to stress much on it. There is a less pneumonectomies, less like adverse events, less disease progression, and the conversion rates were very less in patients who received Nivo plus chemo. And ctDNA clearance were pretty high and correlated with PAT-CR. So adverse events like pretty low because only just 3 cycles of Nivo was given. So what about target mutations? I am sure Mrudul is going to target me regarding this. Mrudul, I will meet you next time with this trial regarding targeted mutations. As of now, non-targeted. What is Mrudul going to discuss? IM-Power 010 PEARLS trial. What are the pitfalls of it? If you see the IM-Power 010, though it got approval, the hazard ratio is really not appealing to me. And Pearl trial, again the same, the hazard ratio is not really appealing. More than that, the interim OS analysis, they say it's immature, but again, it's not so significant. Coming to the keynote 091, all of us will be reading from the back then. As the PD-L1 percentage is more, the response will be more. As the staging increases, the response will be more. But here, if you see keynote 091, stage 3 got a less benefit compared to stage 1B, stage 2, and PD-L1 more than 50% patients got less benefit. And again, compliance, the compliance is not good. Almost half of the patients opted out of the treatment. Coming to the adverse events leading to atezolizumab discontinuation and pembro discontinuation as high as 20%. So what is the conclusion summary? Pearl trial, Empower trial, the statistical significance boundary for DFS was not yet crossed. And out of these three, the winner is Checkmate 816. So the patch error rates were high, the compliance is high. 54% of NADIM trial patients had multi-stage N2. Almost 50% of Pacific trial patients had stage 3 disease. Were these patients operable? We have to see. Future is tailoring of treatment and duration depends on ctDNA, pathological response and radiomics. After this discussion, I'm sure all of you looking at Checkmate 816 as Bahubali, and Mrudul's discussion is going to be Balal Dev. And all of you are like Anushka, looking at him, going to look at him like that. With this is my debut debate. Thank you, Kumar sir, for this opportunity.
The second part of the debate. So I request Dr. Mrudul Sharma Malhotra, who is a senior consultant medical oncologist at Paras Healthcare, Gurgaon, to discuss about adjuvant chemotherapy.
Allow me to share the screen, please.
Slides. Hi, good morning, Mrudul.
Hi, good morning, sir. How are you?
Yeah, I'm great.
Greetings to the scientific committee and Kumar sir, and thank you for this opportunity. I wanted to come in person, but I was actually busy with my clinic. So I'll give a talk from here only. I just, if I can just share my screen, I'm not getting the option for that. So I think they have shared my screen from there only.
Your slides are visible now. Here. Yeah. Yeah. तो भाई slide change करने का access दिया है. You can just go ahead and you can change your.
I don't have that.
Yeah. So he will change it. You can say next. Yeah.
Thank you. Thank you so much to the organizing committee for giving me this opportunity. And Kripa, she has, I would say, a colleague and a junior, and she has done really wonderfully well in new adjuvant setting. And I would talk for the adjuvant part. And when I got this opportunity to talk on this, I was really like, PM Modi and India, and I really didn't know which way to go when the war really began between the Russia and the Ukraine. But somewhere there was an idea, and there was already a lot of things. So probably by end of this talk, I think it should clarify things. And this is the data Kripa has already shown. Early stage lung cancer, a very important presentation, and quite a lot of patients, although we don't see that much, but there are a lot of patients that have potential to get treatment. And I would just like to give an update on the 7th versus 8th edition, that in 8th edition, as we all know, there was more refined cut points in T category with each centimeter increase, and there were other refinements. So how does that change the staging? So basically, it is the stage 2 1B, which was in 7th edition, which now becomes 2A. Although most of the trials, they have now the 7th edition, but over a period of time, this will change, and we should know about that. Then Yeah. So where is the role of perioperative systemic therapy in early stage? So basically such patients which are T size of more than 4 centimeter and which are node positive N1, or there may probably a single station N2 diseases, they are the patients who are the potential who should receive the perioperative systemic therapy. And this is basically the overall survival curves according to clinical stage. Comparison of the 7th and the 8th edition, and definitely we can see in stage 1A the 5-year overall survival is 92%, whereas when we look at stage 3A the 5-year overall survival is 36%. So there is a lot of potential basically to stratify the treatment specific to the stages. Neoadjuvant versus adjuvant, Kripa has very well spoken. Each has its own pros and cons. The adjuvant would address the fastest time to surgery. There are no pre-surgical complications. It enables longer treatment duration for systemic control, and it is more flexible timing post-surgery to provide recovery time. Whereas in case of adjuvant setting, it is the earliest opportunity to eradicate micrometastatic disease, and it increases the compliance, the pathological response, and early assessment can give us the indicator of the sensitivity, and also it has the potential to eliminate the live tumor cells. And of course, all of us know about this LACE meta-analysis, which showed that there was an overall survival benefit of adjuvant chemotherapy in this meta-analysis and all these randomized trials. And it decreased the lung cancer death by 6.9% and increased the non-cancer death by 1.4%. The benefit was more in stage 2 and stage 3A patients, and it was not so much in 1B and 1A patients. And this was one of the confirmatory trial of CALGB 9633, which again put the cutoff of tumor size of more than 4 centimeter. But we have another meta-analysis of neoadjuvant setting, agreed with Kripa that both had almost similar curves, similar benefit, but it had some limitations. This trial had 15, this meta-analysis had 15 trials. Of these, 12 trials did not reach their target accrual. And there was also lack of using standard cisplatin-based regimen in this neoadjuvant setting. So how robust is this meta-analysis? And about meta-analysis, we were always taught the kind of studies we put in, the similar kind of result we get. So we need to be careful about that. But again, now we are today in 2022, and we have a lot of personalization in medicine. So I would discuss with respect to EGFR mutation positive or EGFR mutation negative. And Kripa, I think she forgot to speak about this trial, which is I would say now has become the gold standard in the adjuvant setting, where EGFR positive patient is there. And we know, everybody knows, this is an excellent data where adjuvant osimertinib was used in resectable stage 1B to stage 3A patients in exon 19, exon 21 mutations. And the study reached its primary endpoint, and it was the unblinding that was done by the Independent Drug Monitoring Committee. And it definitely reached its primary endpoint, and the magnitude of benefit was robust to the tune of 83% of the patients who were not basically progressing. And you can see that the maturity was good enough, although it needs a good follow-up. Similarly, when we add 1B to stage 2 and 3A, still the benefit was robust, it was great, and there was statistical significance. So this is the adjuvant setting. And here, if the EGFR mutation, which is more in our population, I think we should go with the ADAURA trial. All subgroup of patients you can see, all of them benefited, irrespective of any subtypes. And this is DFS by stage. There's again the same thing as Dr. Kripa told. So if the stage is higher, the benefit is more. If the stage is less, the benefit hazard ratio was 0.5. It is still much better than many trials. And even in 1B, even if you're not giving chemotherapy, this could be one validated option that will give the better outcomes. OS is immature. It is immature because now we have other primary endpoints, and it takes time for the OS to develop. And not to forget the CNS recurrence that osimertinib is actually preventing. At 12 months, the CNS DFS was 100%, and at 36 months, it was 98%. So with surety, you can tell the patient that by 3 years, 98% of the patients will not have CNS metastasis. So this is with respect to the chemotherapy. So whether the chemotherapy was given or not given, the benefit was seen across all subgroups. And it was an excellently tolerated drug, although it was to be taken for 3 years. But again, the grade 3 toxicities were not that much, although maybe Grade 2 toxicity, diarrhea, I do understand it can be a problem seen in 46% of the patients, but still it was manageable. So to conclusion, not to forget this trial in adjuvant setting, we should do a EGFR testing. DFS benefit was seen and benefit was seen across all subgroups. And it was a well-tolerated drug. OS data is immature, but I think it is a standard of care currently. Regarding the role of NSET TKIs, if the EGFR positive, we have problems with the biomarker testing. Although it takes, maybe 5 to 7 days, but still it is a kind of delay. Then the thing that is whether the TKI will be required after the neoadjuvant use, probably yes, because these are the different kind of tumors. They have a different drivers. Then the risk of progression and inoperability is always there in few patients in the neoadjuvant setting. And there is lack of randomized phase 3 study. Although there is a systematic review that shows there was higher response with neoadjuvant EGFR TKI, which did not translate into better surgical outcomes. So for me, I think osimertinib adjuvant for 3 years is like a newer generation, our Rohit Sharma, who has really taken this for a 6. Now coming to the EGFR negative population, which is best therapy. Dr. Kripa has really done a wonderful job telling about the neoadjuvant setting, but I will tell you about the adjuvant setting. It was the only trial where it was the only and the first trial where in the adjuvant setting, the atezolizumab got approval in the maintenance setting in the resectable stage 2 to stage 3A PD-L1 more than 1% patients who received adjuvant chemotherapy and then received atezolizumab. The study endpoint, the primary endpoint was met, which was stage 2, stage 3A patients with PD-L1 TC of more than 1%. And the study design was a bit complex because there was a serial hierarchical testing. So initially there were the specific subset, and then the subset increased, and then it was the intention to treat population that was tested if the previous endpoints came out to be positive. So it is just the basic general characteristics, and did include EGFR and ALK positive patients. And the subgroup analysis, around 75% of the patients underwent lobectomy. In chemotherapy, around 40% of the patients received cisplatin and pemetrexed, probably non-squamous. And the squamous regimens were 3. It was docetaxel, gemcitabine, and vinorelbine along with cisplatin. And as I said, the study met its primary endpoint. The DFS at 2 years was 74% versus 61% with the chemotherapy alone arm. And the hazard ratio was 0.66. And we look at the subgroup of the patients. So again, the benefit was there across all subgroups. And even the EGFR positive patients did have benefit, although the ALK didn't show that benefit. Similarly, when we look at the treatment that were given, so the benefit was seen along all subgroup patients, irrespective of the surgeries, which was more so with patients who had lobectomy. Among chemotherapies, very important, the benefit was seen along across all chemotherapies except for gemcitabine and cisplatin, and probably that should be the one that should be avoided. The best benefit was seen with vinorelbine cisplatin, and in non-squamous, there is always pemetrexed cisplatin. So this was the DFS in the, again, the same thing showing the benefit was there across all subgroups in the Biden variety. And with respect to the PD-L1 status. So when the PD-L1 status was more than 50%, the benefit was maximum and the hazard ratio was 0.43. So based on this, it also got approval in Europe in adjuvant setting when the PD-L1 was more than 50% in resectable stage 2 and 3A early stage lung cancer patients. And again, the similar benefits seen with respect to the surgeries and the docetaxel cisplatin in the all randomized patients, irrespective of the PD-L1. This is the intention to treat population. It did not reach, and the OS was immature, and it was relatively well tolerated. So definitely, I agree that the treatment discontinuations were there. But again, there is no risk of disease progression that we see in patients that I will subsequently talk about in the neoadjuvant trial. And this is the relapse pattern. We can see the relapse pattern was more or less same. Rather, the loco-regional relapses were more when the atezolizumab was considered compared with the best supportive care. So this tells us that this is actually acting systemically, and it reduces the incidence of systemic relapses. So to conclude, this trial had a DFS benefit in stage 2A, stage 2 and stage 3, stage 2A, stage 2 to stage 3 PD-L1 more than 1%, and stage 2 and 3 all comers, the benefit was seen. Higher benefit in PD-L1 more than 50%. If the patient is EGFR mutation positive, I think the magnitude of benefit was not that much. I would consider ADAURA and osimertinib. finances are an issue, and finances were an issue when initially the trastuzumab was launched and imatinib was launched. But over a period of time, I expect that the finances should come down and it should become affordable to the patients. So it has FDA approval in PD-L1 more than 1%, stage 2 and 3A, and it also has a European approval in 2 and 3A, PD-L1 more than 50%, EGFR ALK negative. Next trial, again, this is a pembrolizumab. It is a similar kind of study where the pembrolizumab was used in the maintenance setting. And the baseline characteristics were all well balanced, and around 14% of the patients didn't take chemotherapy at the baseline. And again, the study met its primary endpoint where the DFS was seen in the overall population, the hazard on stage 2 and 3 patients, hazard ratio of 0.76, and the statistically significant. And when we see in TPS more than 50%, here the benefit was not seen, contrary to the benefit seen in the previous trial. And when we look at the disease-free survival, it was again seen across all subgroup of patients. And again, the OS data was not mature to see. So again, pembrolizumab, not that great data, no yet approvals, but it may be an option where we do a PD-L1 testing and by SP263 to look for atezolizumab maintenance, but that comes out to be negative. Pembrolizumab adjuvant may be an option because it showed the DFS benefit in all comers. So adjuvant, as I told, it allows the fastest time to recovery, longer treatment duration for systemic control, although it comes at a financial toxicity. I do agree with that. So over a period of time, initially when had only chemotherapy, the two-year DFS came to the tune of 61%. With ADAURA, the two-year DFS came to the tune of 89%. And with IM Power 010, the two-year DFS came to the tune of 75%. And these are the ongoing studies where they are testing various other trials, and ENVIL where nivolumab is tested, durvalumab is under test, and Alchemist, I think most of the oncologists are waiting eagerly for this trial where it will address various questions. One of them will be whether concurrent pembrolizumab followed by pembrolizumab versus sequential pembrolizumab versus observation alone. So let us understand, we have talked a lot about NSCT, but we should understand where is the actual need for NSCT. Is it required in all patients? Do we need to put all patients at risk of progression of disease? Well, the actual indications for NSCT are where the disease is potentially resectable, where there is a N2 disease or a mediastinal node disease, where we think that the surgery will not be complete. And similarly is when there is a local invasion is high, where the T4 is there, where there is invasion of the chest wall or superior sulcus with N1 nodal involvement, or if the patient is not fit to undergo surgery. So these are the main indications for NSCT. So coming on to CheckMate 816, you have already blown the trumpet of 816, Dr. Kripa. Wonderful trial, nothing against it. I would again go with this trial, but only, as you said, it would benefit the patients who were N2 disease, because there we actually face the real problem. It had a great PATH CR rates of 24%, and it is approved by the FDA. So study design, I would not repeat again, but I would like to bring your attention to this place where around 16% of the patients were there who were not able to undergo surgery, whether it was due to disease progression, it was due to adverse events, or due to other things. If the patient is resectable, if it is stage 1B, stage 2, why would you like to pose a risk of progression and making the patient incurable by there is almost 1 in 6, 1 in 7 chances that the patient may not undergo surgery. And here again, wonderful trial. The patients who had a PATH CR rate, they had a wonderful control of the disease. This is a correlation with the event-free survival. But those patients who didn't have PATH CR rates, their 2-year event-free survival was even 58%. And similarly, when we look by the major pathological response, that is less than 10% of the viable tumor, those patients who didn't have major pathological response.
We are running out of time, so kindly conclude your talk, sir, please.
Sure. I'm just going to finish it only. So if you compare this with the IM Power 010, so again here if you see at 2 years it reached 74% versus comparable arm. So when the patient is not responding to the neoadjuvant chemotherapy, the outcomes are definitely inferior. That is the point I just want to make. So those patients who had PATH CR or major PATH CR, they were doing better. Whereas those patients who didn't achieve these outcomes, they had definitely inferior outcomes when we have indirect comparison with adjuvant atezolizumab. So to conclude, again, 16% surgery is cancelled. Maybe role of biomarker testing so that we are able to monitor better surgical outcomes. It is a good option in advanced stage, maybe T4 and N2 disease. But again, we need more data. Then Nadim trial, as Dr. Kripa has already told, I would just say it achieved a PAT-CR rate of 63%, whereas a Checkmate 816 achieved a PAT-CR rate of 24%. Why so much of difference? Probably a small trial, small number. That could be one main reason that I could find. And these are all neoadjuvant trials already ongoing. So there are various data that are pending for each of the trials. ADAURA OS data is anyway awaited for any of these trials, and it will take some time so that we can conclusively see. And NCCN recommends both the options, neoadjuvant systemic therapy and adjuvant systemic therapy, osimertinib and atezolizumab. So to conclude, I think there is absence of direct comparison. Both are valid options for a different subset of patients, potentially resectable or questionable fitness. We should go for neoadjuvant. Who had undergone resection and negative margins and have adequate fitness, they should undergo adjuvant chemotherapy. So with this, I think so many months after the war, India has its stand, and the world is clear as where the India stands on which sides. So we are actually with both the sides, but it depends on the options and the choices that we make. Thank you.
Dr. Kripa, 30 seconds if you want to reply.
Dr. Mudal, you boasted a lot about osimertinib and like downtrended like NACT TKI, but you say I'm going to come up with neoadjuvant trials soon, as well as your CTONG trial is a negative trial without any OS benefit. So is the data you mentioned regarding first gen TKI, but I'm going to come with neoadjuvant trial. And also regarding IMpower 010 as well as Keynote 091 trial, what you spoke, there's a lot of financial toxicity, not just immunotherapy toxicity. See, just 3 cycles of nivolumab is going to give a very good benefit. And a lot of tailoring of treatment can happen. That's a way in future regarding the lung cancer management. So IMpower 010 as well as Keynote 091, the hazard ratio 066, again updated to 0.79. So not so significant, like not expected to be so significant. We will meet again with the neoadjuvant trial as well as OS data of IMpower 010 as well as Keynote. Can you tell me why in Keynote trial, more than 50% of PD-L1 population didn't get any benefit, like not much benefit, in spite of giving 1 year of pembrolizumab, which is like lakhs of money? Can you explain that? And what's your rebuttal regarding my comments?
Definitely. Great comments. So Dr. Kripa, so one thing, you have a positive data in atezolizumab, right? And you have a negative data in pembrolizumab. And that has been proven to be a statistically significant. These drugs, although more or less they are different drugs, although ultimate outcome they have similar, that is they are boosting the immunity. So we know in which subset of patients which drug to use, right? There may not be explanations for a lot of things. Why was the overall response rate to the tune of 68% in Nadim and not so in the other 816? Can you explain me that? So the biological reasoning may not be there, but at least we have the statistical reasoning in front of us, and that is how we take things forward and offer to our patients. Regarding the CTONG trial, the CTONG trial saw the PFS benefit did not extrapolate to the OS benefit. In osimertinib, we do not have the OS benefit right now, but looking at the magnitude of benefit, you cannot deploy the patients with such a great magnitude. You can offer that, and it has approvals for it. I think it is valid option, and there is no confusion about that. And definitely, the first or second generation TKIs may be used in patients who are basically not fit enough for chemotherapy.
Thank you. So I think so. This debate was primarily for the students, and I hope students, they have not gone away. They are around. Good. What have you learned? What? Take a mic. So new adjuvant, when what? Take a mic.
Hi.
So what has happened is, I'll tell you, in my time it was easy because there was no adjuvant or neoadjuvant chemotherapy for lung cancer when I was getting trained. So life was easy for me. Problem happened when I became a consultant, then the adjuvant chemotherapy came. That was the first problem. Again, relatively easy because adjuvant mein dena hai jo platinum based chemotherapy. Your life is tougher. Now you have immunotherapy, now you have Dr. Kripa told and Dr. Mridul that you have a targeted therapy, many more of them. Now it is a trouble. So maybe let's see.
Sarama, MD medicine, who is interested in oncology, not yet a trainee, but from the session, I understand, and from what I've seen sitting in OPDs with my consultants in oncology, what I take from this lecture is, if a patient has got a potentially resectable disease with an N2 disease and is affordable for immunotherapy, I would definitely offer him a neoadjuvant therapy, including immunotherapy. And in other cases, offer an adjuvant therapy.
So it looks like you convinced him more. So other two of your friends looks like they ran away. They were there around three of them. Yes, ma'am. Anything? What you could decipher from the discussion? Any opinion you have? Ajo, mic pe. Anyone? There are students? No students. Anyone here?
Sir, what I understood a bit of it is that neoadjuvant I'm getting convinced with. If the patient qualifies for the therapy, they are affording for the same. I feel, sir, we can plan for it.
Neoadjuvant.
Yes, sir.
So I think so. We had a good debate, and maybe just to decipher for if the student setting, you have a chemotherapy, non-N2 disease, by and large, you give adjuvant. N2 disease, by and large, give neoadjuvant for various reasons. Immunotherapy, you can keep debating neoadjuvant, adjuvant. Cost is less if you give neoadjuvant. Apart from that, benefit looks similar. Sure, no answer for the questions you asked. TKI, all the answers is there in adjuvant at this moment. Yes, future, as Dr. Kripa said, we'll have more answer in neoadjuvant. Thank you, both of you. Thank you, both of you.
So thank you, Mrudul, being there, and thank you, Kripa. I mean, quite a dynamic discussions which we had. Now, I just would like to invite Dr. Nikhil Kalyani, consultant radiation oncology at Jaslok Hospital, Mumbai. So we will going to have a case for Viva, NSCLC locally advanced. So Dr. Nikhil Kalyani is going to moderate the session. I will request him to invite and introduce all the panel.
Thank you. So we move on to the next session, which is a new format for a masterclass. So here we are going to discuss a case, and there is a eminent examiners who is going to ask the questions to the students. So first of all, I would invite the students first. So they are Dr. Pragna Chopade, Dr. Arnav, and Dr. Srinivas Gopin. And the examiners are Dr. Tanvir Shahid, who is the head of the department and head of academics at Apollo Hospital, Kolkata. Dr. Moses is a consultant clinical oncologist at Tata Memorial Central, Kolkata. Dr. Purvesh Parikh is a medical oncology and hematology professor and head of clinical hematology at Tata Hospital. Dr. Sanjay Sharma, who is a professor at Bombay Hospital. Dr. Sarvana is a thoracic surgical oncologist, and Dr. Amita Athawade. So in this format, the students are going to present the case, and this is like an exam. So the examiners are going to ask the questions. So we are going to divide into the three things. First will be the history and the physical examination. Next session will be on the investigation, and third will be on the management part. So let the case presentation start.
Excuse me, Dr. Kalyani. Are these all surgical or medical oncology? Anybody surgical? And both to all of you are radiation?
Medical oncology.
Medical.
Radiation.
She's from it. Okay, equal to you.
Okay, fair enough.
Good afternoon, respected teachers and colleagues. This is a case presentation of a patient of locally advanced lung cancer. To start, A 44-year-old gentleman, a smoker, also with hypothyroidism on thyroxine at 50 micrograms once a day, with no other comorbidities, was evaluated at our center in July 2021 for the complaints of dry cough since 1 month, a single episode of streaky hemoptysis 1 month prior to presentation. There was no history of weight loss. There was no history of dyspnea. There was no postural or diurnal variation of the cough. There was no history of chest pain. There was no history of tuberculosis in the past or tuberculosis contact. On examination, the patient had an ECOG performance status of 0. The pulse was 72 beats per minute, regular with good volume. All peripheral pulses were well felt. The blood pressure was 110 by 70 millimeters of mercury. There was no pallor, icterus, cyanosis, clubbing, or lymphadenopathy. There was no pedal edema. There was no lymphadenopathy, particularly no supraclavicular lymph nodes were palpable. Next slide, please. In the respiratory system examination, on inspection, the chest wall was symmetrical and respiratory movements were equal bilaterally. On palpation, chest wall movements were symmetrical. Tactile vertical phlegmatis was equal in corresponding areas. On percussion, a resonant note was felt in all intercostal spaces. The right heart border was retrosternal, and the cardiac dullness was in the left fifth intercostal space, inframammary region. On auscultation, the air entry was equal bilaterally with no adventitious sounds heard. In other systems salient examination, the jugular venous pressure was 5 centimeters in 45 degrees reclining position. Heart sounds S1, S2 were heard normally, no murmurs were present. Per abdomen, there was no organomegaly. And the central nervous system examination, the patient was conscious, oriented to time, place, and person. Higher mental functions were normal. The pupils were equal and reactive to light. And power was 5 by 5 in all 4 limbs with no focal neurological deficit. I now hand over to my colleague, Dr. Srinivas, to proceed with the further evaluation of the patient.
Good afternoon, everybody.
Shall we wait or continue?
Can we wait for the history?
The young man has really elaborated. What could I see was only no this, no that, no this. Can you, short, tell me in just about 2 or 3 lines if you have to present this case, vis-a-vis, you can say summary. Because I don't think at this age, at your position, they're going to an exam, there are more no's and then plus. So only highlight the plus and that understood that everything else is normal. You can just have one statement. Because examiners are in no time to listen to no's. They have no time to discuss anything except what you are presenting, the way you are presenting. That is one part. How do you go on to manage this patient? That's the second part. So that is what is important. So tell me, let them finish, then I'll, in short, somebody of, or each of you can check.
So this is a 44-year-old gentleman who is hypothyroid and a smoker, presenting with the complaints of cough since 1 month and 1 episode of streaky hemoptysis. The physical examination is non-contributory to the further diagnosis of the patient. So we would require imaging for further evaluation.
What was the profession of the individual? Is that important? What was he doing? Profession?
Profession, sir.
Businessman, sir.
Is it important or not important?
Yes, sir. It could be an occupational history would also be important.
Is there anything else in history that is pertinent but you have missed out? So is there a family history?
There is no family history.
So is it important or not important? How do you correlate that a male of 44 years has hypothyroidism? Does that ring a bell? Something else comes to mind? Anybody?
Okay, you guys now present your summary, each of you.
44-year-old gentleman who was a smoker and is hypothyroid, had a history of 1 month history of cough and hemoptysis, and no other relevant family history or occupational history.
Yes, yours, young man.
Yes,
Still missing. Go ahead, tell me.
he's a 44-year-old gentleman who's a smoker and hypothyroid on medication. And his chief complaints were he had dry cough for 1 month, a single episode of hemoptysis. Apart from this, there was no other positive findings in history. And on examination, the respiratory system was essentially normal and no palpable supraclavicular nodes. So his evaluation will further require imaging and hematological investigations to proceed.
What is the meaning of occasional smoker? How do you define that? Single episode of streaky hemoptysis. How do you define streaky hemoptysis? Was that streaky hemoptysis associated with? It could just be a common cold, for instance, right? So did he have fever, snuffles, a runny nose?
There was no history of fever
No,
or
that is relevant. I'm just saying that whatever you're mentioning in history, you could elaborate rather than going to the no part, right?
Okay. So, young man, or man, let the ladies could say. Okay, now you have a history, and presumably there is something in the lung which is creating the symptoms. How do you proceed? How do you manage this patient vis-a-vis in terms of investigations? First finish the investigate part, then we'll stop, and then we'll go ahead and discuss the management part later. Go ahead, please.
So I would like to do a basic blood investigation and like a CBC and biochemistry.
Can I just interrupt? Your investigation should be based on a provisional list of differential diagnosis. Can we start with that and then move to investigation?
So, in a patient who has had a dry cough and hemoptysis, I would initially be looking at some lung pneumonitis or any those sorts. I would like to do an chest X-ray initially.
That is your only diagnosis, differential diagnosis, pneumonitis.
If I have a lesion on my base tongue and I have cough, one cheeky hemoptysis will come there too.
So laryngeal lesions.
Oropharyngeal lesions, yes. That's what Dr. Parikh wants to know. Or, is he on some kind of blood thinner sometime? Now today these blood thinners are very common. So, people bleed on just nothing, just one small cough and it comes out. So that's what it is. So you need to focus. Just because you are appearing and you know that it is the lung cancer, chapter that you have been discussed, you are dissuading yourself. In exam, you have to be a broader picture of what the patient has had. So that examiner doesn't bother all of that. He knows that you have studied the whole thing, everything is out, is not involved. And that's what it is. Please, go ahead. Sorry.
Sir, I would like to do a chest X-ray initially. And depending on the chest X-ray reports, results, I would go ahead with a cross-sectional imaging.
No blood test? Routine blood test?
Routine blood investigations.
Okay, yeah.
Yes, sir. I agree with that. We'll start with the chest X-ray and complete blood count. Based on the results of those two investigations, then we'll proceed further.
And so, obviously, you'll be looking for something in the examination, initial examination also, the oral cavity, oropharynx as well, right? So you have to complete the phenomena. So I have done that. We will at least primarily just see a little bit throat and anything else there. So that is one point. And then further non-invasive investigations or a major invasive investigation comes into the fore. Yeah, please. Chest X-ray and routine blood test, right? Okay. Do we have chest X-ray?
No, sir.
Anyway, we can continue.
Okay.
Will you present first?
Go back. Go back. So I think we can forward.
Okay. So this was his baseline
PET scan that he done. We got in our institute. His PET CT. Can you go to the next slide for that? So his PET CT shows a right middle lobe FDG avid lesion with a transfissural extension into the lower lobe. And there is also N1 station or a right hilar node, which is possibly infiltrating into the right main PA. The first branch of the right main PA was not clearly visible. Along with it, he had a FDG avid subcarinal node. Next slide. Otherwise, the rest of the lung fields did not show any other changes. There were no other lung nodules and no other significant mediastinal lymphadenopathy apart from the right hilar station and the subcarinal station. And so after this, once the cross-sectional imaging was done.
Can you go back to the report of the PET scan? Yeah. It says SUV max 28.83. What does that tell you?
That the lesion has a high metabolic value, and the glucose uptake of the lesion is very high, and possibility of that could be a malignancy or some high-grade infection is there. So,
is that SUV 28.83 arrived at by comparison to something else?
So sir is asking how you measure the SUV?
The normal tissue has no SUV uptake. So,
which is the normal tissue against which it is compared?
I think liver,
the baseline uptake of
the liver tissue compared to the liver tissue, the number of times it's increased is 28.8.
So, as you all mentioned that the history, this kind of history, you'll go for chest X-ray first, and depending upon the chest X-ray finding, you will be proceeding. So the thing is that examiners like both are my teachers over here, like they'll not be wanting to listen PET CT scan as the next modality, even though they would be doing this in their practice. Because as the students, they haven't taught us, and this is not the way to proceed. So after looking at the chest X-ray, how will you proceed next? For the timing, let's forget that the PET CT scan has been done. How will you proceed? What will be your next imaging modality?
You do a CCT, thorax and abdomen.
Absolutely, that's right. What else?
We would also do a bronchoscopy.
Put in a scope, you might find something. The patient is an hemoptysis.
So would you do only bronchoscopy or would you do some other scopy also?
Based on
he is a smoker. So is there correlation between smoking and site of primary?
There is a field cancer effect, so we should ideally evaluate for another second primary in the entire aortic.
Right.
I'll just ask you now, since you have already done a PET scan in a locally advanced lung cancer, what all information can you get from a PET scan when you do for a patient with the lung? Anyone can take the answer. And is PET scan enough?
So with a PET scan, there are two things. One is that if you are considering the patient for a curative intent therapy, with PET, you may pick up a lesion that was not picked up by other imaging modalities. And in the combined analysis of several studies, it was shown that 20% of unnecessary resections with a curative intent could be avoided because of doing a PET CT. Because you may upstage the lesion by picking up a distant metastasis. At the same time, as per guidelines, if there is a single site of FDG avidity, which is a distant metastasis, it has to be confirmed histologically before we say that the patient is not suitable for a curative intent therapy.
Okay, he's asking for something else.
I was asking for something.
Oh, see, it's for staging purposes. Let's see that you have to stage the disease and you have to treat further. Apart from the PET scan, which gives you a stage, and I'll ask you, come to the pictures later. Come to the picture. Okay. So, I know it's a one film, so you can't really say. What else you need to know about the staging of this patient? There is something else very important, especially in a lung pathology, to be done and seen before you decide what is the final stage. So, T, N, M, all these things has to be defined.
Is there any distant metastasis which we could find on a PET CT?
What else? What else? Which PET may not should correct?
So where the PET is limited, sir, is
Neurological imaging, we would like to go for a MRI brain.
That's correct. So now let's presume, and I know it's only one film. What would be the stage of this patient on TNM? Ultimately, you heard the debate. The debate was only a potentially resectable, a resectable, but still bigger nodes, and then third is unresectable, and then beyond. So we are talking about a disease which here is a locally advanced disease. Presumably the other brain and other things are normal. The bones, everything is normal. So is it an early case or a late case?
It's a locally advanced tumor.
Fair enough. So now this is normal. So what is your stage? And then on the basis of stage that you heard a debate before, what would be, will you proceed for? So I'm just trying to bring it to you that when you're reading a CT scan, you have to define, as you rightly mentioned, but then you have to mention that radiologically, and if there is MRI being normal, my staging would be this.
what is the TNM staging now?
So
That's
technically this would be.
So what would be a locally advanced breast cancer in a bracket? And so will it be 2B or a 3A or a 3B or 3C?
This is 3A, sir. It's T3N2M0 according to the radiology.
I would like to ask anyone can take this question. Here you have an FDG uptake of 28 in the primary, and then you have a FDG uptake in the subkernel. Do you know of any situation where there is some discrepancy between the SUV uptake and the tumor? It may be locally advanced, but not light up on the scan as you see here. So I'm talking about false negatives. So that will give an idea of what you're going to do next for this patient.
In case we do morphologically see a node and it is PET negative, we would still go ahead and do a NEBUS, take a biopsy, and if it is biopsy confirmed, even if it is PET negative, we would still treat. We would still take it as involved.
So do you know of any morphology that is classical for a low FDG uptake on scans, on PET scans?
Tumors.
One.
Ventrally necrotic.
Any other? Carcinoids, yes. So earlier you had this called BAC, bronchoalveolar carcinoma. Now they've changed the terminology to other variants of cancer. So that is classical. Even though you have a locally advanced picture, the FDG uptake will be very low. So sir was mentioning, an MRI brain. How valuable? Why not just do a CT in the PET? How much times will you find that the patient will have an MRI showing METs compared to a PET scan? Because PET scan is going to be whole body, right? Taking from skull to foot. So what is the upstaging of an MRI? What is the value of an MRI?
So the baseline FDG uptake of the brain is very high because that is the highest metabolic activity tissue. So you may miss a small neuroparenchymal lesion which will be better characterized by an MRI.
So the logical next thing in your, sir, I think that is what is the next thing that you will do? You got the PET scan now. You've seen
now
that.
You have to proceed. What do you do?
Non-metastatic. So what is the next step?
You are all presuming that it is malignant.
What is the logical next step?
We'll need a
histological confirmation.
So we'll go for a CT guided biopsy of the lesion in the right middle lobe.
Now in this scenario, again, I'm just telling you what else you will need for that biopsy from the pathologist and from the other pathological departments to help you for management of this patient.
From the pathologist, we would like to know whether it's a small cell or a non-small cell first. And if it is a non-small cell, we would like to know what type is it, adenosquamous or any other subtype. And apart from this, we would also want to know the aggressiveness of the tumor and the mitotic index. And
how will it make a difference in the treatment?
Because this is
mitotic index, how will it differentiate in the line of treatment?
If it is
something more important that you are missing.
The driver mutation status.
Exactly. What do you do in that?
At a basic panel, sir, at least from the most common mutations, we would do EGFR by PCR, ALK-ROS and PDL1 by immunohistochemistry, And if the patient is affording, then we can do a next generation sequencing for all potentially targetable mutations.
But would it be sorry? Would it not be sufficient for you at the moment, whatever drug that you have available for the treatment?
I beg your pardon, sir.
Now you have done 4 and that is relevant investigations. If you have other 3-4 of them are available and one of them is positive, it's not worth doing for other mutations, right? Because you may not have drugs for that. So on paper, you have 300, 400 genes, you can estimate it. But patient cannot afford 4 lakhs, 5 lakhs. Is it necessary? No. So what you mentioned 4 is most important part of it. Okay, right. So now you have in this patient, you can give us a clinical scenario. Let's just give a clinical scenario.
So you mentioned PCR. What does that mean?
It's a polymerase chain reaction, sir.
What is polymerase chain reaction?
So it is a genes.
So tell me what happens in a polymerase chain reaction.
So it is a genetic sequencing, which is done by the use of polymer hybrids, where you check the sequences compared with the polymer which is made previously.
Are you talking about NGS or are you talking about PCR?
You does not say NGS.
Oh, no. So just now what you are describing, sequencing is NGS.
Exactly.
I'm not asking about sequencing. I'm asking about PCR. What is polymerase chain reaction? Okay.
So
that's all.
polymerase is it's a viral based enzyme, usually, which is then it is coded to pick up the particular.
You're getting into more and more trouble in an exam. Okay.
Don't know, say.
The bottom line is answer limited. Otherwise, you're putting your foot into the mouth before you now, then you will not have no place to even speak up further. So don't share knowledge. What is basically necessary for management of the patients, that is important. Fine. So he's saying that, okay, patient has all these 3 are negative except the PET PDL1 positive. Now, what do you do for this patient? So you have done a bronchoscopy. Now, would you like to do in this case, you have already N1, so you have to prove an N2, it is N2 or not, because there is a subcarinal node there. So would you like to do an EBUS or what do you want to do in this? How do you stage properly?
Yes, sir. We will like to stage the mediastinum with the endobronchial ultrasound. It is not only prove N2, we can also have to roll out N3. So because N2 is positive, there's a chance that N3 might also be positive. So
but if you have no node, what do you want to biopsy? At the moment, there is no node there. I'm not saying if you don't have a good CT scan, that's rare. Yeah. There are no. Yeah, that's fine. Okay. Point well taken.
So as Dr. Sanjay Sharma was saying, let's say that this is adenocarcinoma. All the driver mutations are negative and it is stage 3B. Just assume. Now what is your next step?
assuming that we've already staged the mediastinum, then we would like to discuss it in a multidisciplinary tumor board. And when this was discussed, we thought this is upfront not resectable. And because the main PA was involved and the right main bronchus also closely abutting the node, this could require a possible pneumonectomy. And the pneumonectomy with N2 disease is not a desirable thing. So the decision was to go ahead with definitive chemoradiation.
So you pass it on to your colleagues. All right, pass it on then. Use the mic, please.
Yes, sir. So the patient was planned for definitive chemoradiotherapy, and he received 60 grain 30 fractions over 6 weeks of radiotherapy. He received 60 grain 30 fractions of definitive chemoradiotherapy along with concurrent 6 cycles of paclitaxel and carboplatin.
Is there any other way of giving the radiation? Not in this particular case. I'm just asking in general. Is this the only way that radiation is given when you are giving concurrent chemoradiotherapy?
So we can give sequentially as well.
Sequential. You just now said concurrent.
So this patient was treated with concurrent chemoradiotherapy. The other way is to give it sequentially, but with sequential, we've seen concurrent to be.
So if you had listened to the lectures in the morning, so in such a large tumor, which is involving both the upper as well as lower lobes, and you have given a regimen which is known to cause a particular, untoward effect. So giving paclicarbo in a patient who is a patient who's going to receive concurrent chemoradiation, what are the things as a radiation oncologist you would expect and take care?
Esophagitis. You would expect some amount of esophagitis.
Any other drug regimen that is, so the entire session we were all talking about, what is the ideal currently?
Pemetrexed, cisplatin.
Cisplatin, etopo versus paclicarbo versus taxane. So what are the differences? We want to know whether you have understood the rationale behind the chemoradiation part.
So is there a
So there's no head-to-head comparison of cis-eto versus paclicarbo. But in the 3-arm study in which paclitaxel carboplatin was taken, I think the one regimen was in the 3-arm trial was irinotecan and one was cis-irinotecan. And paclicarbo, the tolerance was found to be better and equally effective, so it was considered as an option. So there is no head-to-head comparison. Between pemetrexed cisplatin and pemetrexed etoposide, the trial was actually designed as a superiority study of pemetrexed cisplatin. The superiority endpoint was not met, but numerically they were almost similar, and the tolerance for non-squamous histology was better for pemetrexed cisplatin than it was for etoposide cisplatin. So that is also another acceptable option.
I think sir wants to ask what is the difference between cis-etoposide and the
paclitaxel
carboplatin?
Answer is there is more radiation pneumonitis when you give paclicarbo versus more neutropenia when you give cis-etopo. And that will drive the choice of what treatment you are going to do. And one important aspect when you're planning some patient for chemoradiation is about the fitness. Nowhere else in any other branch of solid tumors, you have insistence on performance status or physical fitness for whatever it may be, surgery or it may be chemoradiation as well. So you need to take that into account, because if the discussion was going towards surgery, so that would have been the next thing that we analyze the fitness, whether each patient is, even for radiation, we see time and time again that many patients, they cannot tolerate concurrent chemoradiation in our scenario. Very difficult to execute a good, it's really difficult for concurrent chemoradiation. So I think in those situations, you should look at the lung, look at the quality of the lung, whether the patient is having emphysema, what are the probability or risk factors which may indicate that the patient might go in for a radiation pneumonitis, etc., and other complications. So we have to look at these things also.
So if a patient is usually taken up for surgery, if you assess lung functions before you take them up for surgery, is there something that you would do similar for a patient taken up for radiation as well? The radiation oncologist can take it. I mean,
Your pulmonary function test, sir.
So is there like a cutoff that beyond which you wouldn't give radiation?
Beg your pardon, sir?
When you do a PFT or a DLCO, is there a cutoff beyond below which you wouldn't offer them radiation because of worries of toxicities later on?
So the DLCO of 75%.
Yeah, I couldn't hear you. What did you say?
So the DLCO and the FEV1, sir.
No, what is your cutoff for not giving radiation? DLC or a PFT cutoff in your institution? Do you have any cutoff like that, or for radiation you don't have anything?
So FEV1 of 70% and above at least.
He's asking for a DLCO.
So 77.
So below 77, you will not give chemoradiation.
Most of us will not have even 77.
So
even if it's non-smoke, I mean, today's modern pollution.
Most trials would have taken it somewhere between 40 to 50.
So 40 is the criteria for both surgery. It applies to radiation as well. 70 is very good performance status, pulmonary function wise.
No. Yeah, go ahead.
You mentioned about skin and toxicities and dysphagia alone. Is that, I mean, what other toxicity will you be really counseling the patient about when someone is undergoing radiotherapy? Which is the one toxicity that you're really worried about? I mean, he did mention about it in terms of choosing chemotherapy.
We will be counseling them for esophagitis and pneumonitis.
Yeah, so pneumonitis. So, I mean, was asking about what are the other ways of giving radiotherapy in terms of sequencing. You have used Rapidac, and is there a specific reason that you would choose Rapidac over other techniques?
So initially we were treating them with 3D CRT, but with the use of IMRT, we were seeing that there is, in spite of there not being a difference in the overall survival or the outcomes, but the rate of pneumonitis is significantly reduced with IMRT as compared to 3D CRT, although there is a higher risk of esophagitis.
Any other toxicity could be reduced by using
Cardiac
IMRT?
toxicities.
Cardiac toxicities. It was mentioned in the morning talk as well.
So you've completed treatment. Now what next?
No, 1 minute. I haven't asked him. Suppose since you've got a large volume, you have a patient with a little borderline function, this patient. You may not be able to give what you need to do in a concurrent setting. And you said you want to give sequentially. So obviously, what will be a sequence? I'm sure it will be chemotherapy first, followed by radiation therapy. In that event, what will be the chemotherapy that today, and you had seen in the previous discussion and a debate, to be used? And I had asked you earlier, as what is EGFR, ALK, ROS, and PD-L1? And Dr. Puri Varik said that all three are negative except PD-L1. Do you have choice? That not going for concurrent CTRT and then going for a sequential treatment of chemotherapy first, followed by radiation therapy, if required. Do we have data for that?
This patient, the radiation oncologist tells the volumes are too much. I can't give it now. What is your option? In this patient, what chemo regimen you will choose? You can give your justification and there are many choices. You can give your justification.
So if the patient is feasible for immunotherapy, we can give neoadjuvant chemoimmunotherapy. Since the patient does not have EGFR or ALK mutation, which was the exclusion criteria for selecting immunotherapy in the first place, PD-L1 cutoff was not mentioned. So affordability would really be the only factor for not giving immunotherapy in the neoadjuvant setting to this patient.
Is there any specific concern of giving immunotherapy in this patient?
Especially when this patient is not going to be operable and is going to be for radiation later on.
You mentioned in the history.
Hypothyroidism because of one would be the autoimmune. And secondly, there may be higher rates of pneumonitis subsequently when we give concurrent chemoradiotherapy.
Let's say you started concurrent chemoradiotherapy, and after 2 weeks, the patient cannot swallow anything. How will you manage the patient?
Patient is unable to swallow food at all. So you would have to
unable to swallow food and liquids.
So you would have to insert a feeding nasogastric tube. Keep the patient on tube feeding till the time that the.
So you will not do any investigation. You will start straight the tube is put.
So we can do an upper GI scoping, insert the tube under vision to see the status of the mucosa. Nutritional support primarily we'll have to initiate as the patient.
Is there any other concern? I mean, you are assuming that the difficulty in swallowing is because of radiation or chemoradiotherapy. Is there anything else that you would look at while you're doing the endoscopy? Is there any other investigation that you would want to do?
Barium swallow.
How will it help? Barium swallow?
Kind of there is a stricture formation.
Sir told that after 2 weeks itself. So 2 weeks are you expecting a stricture?
No, sir. Any second.
So there is inflammation, there is damage to the tissue. Could that be that there is an additional infection that is causing a problem? Would you be worried about that? Would you investigate for that? What are you looking for?
There could be fungal colonization with fungal esophagitis or pharyngitis.
All right, two scenarios. Response is excellent, except the lesion around the right bronchus. Rest all, there is no disease elsewhere. And you do a bronchoscopy and you find the damn lesion is still there.
So,
what option do we have? Anybody?
Pardon, sir, this is a response post neoadjuvant therapy or post definitive chemoradiation?
CTRD. Result after CTRD, if there is residual disease, what option that all through you are in a joint meeting would decide for the patient, which is better for the patient.
So if financially feasible, any
Finance is never issue in exams. So everybody is rich.
adjuvant durvalumab, sir. For any patient who has not progressed on the platinum-based chemotherapy with radiation, we can start adjuvant durvalumab.
So in exam, when you mention adjuvant durvalumab, how much duration? So complete it. So it's
So adjuvant durvalumab 10 milligram per kg every 2 weekly for up to 1 year, 12 months. As per Pacific data.
So this is how you get additional points, no? Just don't mention, okay, what you'll do next, X-ray. Don't tell something which is substantiating what you're going to mention.
Any role for further boost of radiation therapy or surgeon if the patient's condition is good for doing a pneumonectomy? Your vein is free. Land up in pneumonectomy, patient is young.
Sir, because it still requires a pneumonectomy, I wouldn't be too keen, sir, because upfront also it required a pneumonectomy. The nature of surgery hasn't changed, so it makes...
No, nature is not changed, fine. You are obviously given a first line of treatment which has not worked. Now, he has an option now, which new option is available, the durvalumab is there. And hopefully it works. But still, nothing else is there. What else you have left with the patient? If he's excellent from a condition, yes, post-CTRD, but PFT is normal, CO2 is again normal, functions are normal, young, otherwise fit man, except the problem that he has had because of concurrent CTRD, whatever, it's not less toxic. It's so, I'm just saying, durvalumab is definitely an answer, there's no question about it. Madam also, you can't radiate further, am I right? So, last resort, will it be possible for you to do a pneumonectomy? And what is the mortality in this scenario if we are to do it? I'm not saying that you should do it. But in case you are left nothing else, but the hemostasis is still there. And there is no disease elsewhere. Any other option apart from surgery if you have it after durvalumab?
If it comes to surgery, definitely, sir, the mortality with pneumonectomy is, especially in a salvage setting, is quite high. If you consider the Albin trial, which had a mortality of more than 20% for an N2 disease with pneumonectomy, but retrospective series in high volume centers, I think for a salvage pneumonectomy around 5 to 10%. The mortality rate, which is again for a lobectomy, it is around 1%. So considering
in this case
that,
is out of question. You have a lesion higher up.
so the mortality is quite high, and if there is no other option in a high volume center, pneumonectomy would still be a valid option.
Medical oncologist, any other second option?
Persistent disease after completion of durvalumab and its only site.
So if the patient is not symptomatic, we can keep the patient on observation and follow up. At the time of progression, we can consider for a subsequent systemic therapy. Immunotherapy responses are usually durable, so even if it's stable disease, it may remain stable for a prolonged period of time. I mean, need not necessarily go after that lesion.
The typical scenario that you see in centers like Tata Hospital, patient has come from out of town, he is given the concomitant chemoradiotherapy, you started durvalumab. After the first month, the patient says that, doctor, now I want to go back to my native place. I will take the further treatment there. what guidelines you will give to the patient in writing and what advice you will, what precautions you will tell him to follow. Happens all the time, right? Yeah. So why are you hesitating so much?
We would provide we would provide the patient with a detailed therapy protocol for durvalumab, along with the investigations which are to be repeated prior to each cycle. And we'd ask them to take the therapy under the care of an expert oncologist who has some experience in delivering immunotherapy. What we'll particularly be watching for is whether the patient is developing any new respiratory symptoms, because we are worried about pneumonitis developing later on. And also the patient's hormonal profile will have to be monitored regularly along with the cardiac function.
Sir, and what will you tell the patient or the family members when they are going? Whatever you said is correct. But is there anything else that you will tell them? Or what specifically you will mention to them? Okay, never mind. While the patient has finished treatment and is on durvalumab, the patient's hemoglobin is found to be 6. Now what will you do?
So we will have to evaluate starting from a peripheral smear and RBC indices to see the nature of the anemia, whether it is microscopic, hypochromic, or megaloblastic. We'll do a nutritional profile with folic acid, B12, and iron studies. That is ferritin TIBC.
Normochromic, normocytic. Normocytic. Retic count is 1%. B12 and folic acid is normal. Stool for occult blood is negative.
We would consider it as a drug-related toxicity.
Is there any other differential diagnosis? Or is there anything else that you want to do? You've mentioned some tests. I've given you the answer. Is there any other test that you want to do? Anybody? Serum iron, transferrin saturation, erythropoietin levels. Would you do that? Is it relevant?
Iron.
So I'll tell you, the serum iron is not reduced. Okay, erythropoietin level is low. Now what will you do?
Pardon, so what was the iron level?
Iron level is normal. Erythropoietin is low. Now what will you do?
Evaluate the renal status of the patient. See if the kidneys are functioning normally.
Kidneys are normal. Creatinine is 1.
It will be considered as an anemia of chronic disease. We'll see if the disease is progressing, if there is any sign of relapse. Or
not progressing.
Can add erythropoietin supplementation, subcutaneous.
So what is the dose? How long will you give? What will you monitor while giving the erythropoietin?
So 10,000 units per week subcutaneously, erythropoietin, that is darbepoetin recombinant, that will be given for at least 8 weeks. Then subsequently we can monitor and reduce the dose. We have to watch for hypertension, particularly as a side effect.
Why you said 8 weeks? You're right. I'm just asking you why.
That was the value I remembered, sir.
Because it takes time for it to act. So it can begin action between 3 and 8 weeks. Therefore, you're saying 8 weeks. Okay. You given that for 8 weeks, the hemoglobin has increased from 6 to 7.5. Now what will you?
We can de-challenge durvalumab and see if there is any improvement.
What is functional iron deficiency? And how do you treat it?
Functional iron deficiency is when there's inadequate mobilization of the iron stores. It can be treated by giving IV ion infusion. That will be the transferrin saturation will be low, though the ferritin is normal and the serum ion is also normal.
So what is the dose and which particular ion preparation will you give?
So dose will be as per the iron deficit, which will be calculated based on the patient's current hemoglobin and the target hemoglobin. And accordingly, we will give that calculated dose plus 500 milligram of IV iron for again repleting the stores. The preferred preparation is ferric carboxymaltose because it causes the least infusion reactions.
All right.
Okay, now all three of you, and I'll start with the surgeon. You've heard everything. You've heard questions. Now, examiners want to ask, summarize the case in just about 1 minute, including the treatment, or 2 minutes you have. What will you do? Somebody like before the examiners give you marks.
So this is
and
a
that is very
44
relevant. Each of you remember that. Okay.
As a 44-year-old gentleman, smoker, hypothyroid, presented with cough and one episode of streaky hemoptysis. CT scan showed a right mid-lobe tumor extending into the lower lobe with a bulky hilar node and a subcarinal node. EBUS was positive for N2 disease. So the clinical staging was CT3 N2M0, and based on our discussions, we planned for a definitive chemoradiation. He received a definitive chemoradiation.
Should I start all over? Should I start all over, sir?
No.
So the patient received concurrent chemoradiotherapy to a dose of 60 grain 30 fractions over 6 weeks, along with concurrent 6 cycles of weekly paclitaxel and carboplatin. And subsequently, we evaluated the patient after 3 months with response CT scan.
Now in your treatment, as I mentioned, there is a recurrence. Or there is resident disease.
And there was,
what do you do? Send it to him or no? Or you
Yes,
want
sir.
to treat yourself? Give it there. It's a teamwork. Please.
Patient
Not
treated.
summary for the patient has been sent to you.
A 44-year-old gentleman with a
That's
basic.
all done.
Now
He
what
has-
will you
he
do
has
with the
finished treatment
residual?
with local renal disease is still persisting after concurrent CPR. And you discussed that. Summarize it.
Patient who has received post chemoradiotherapy residual stable disease with no progression for consideration of further systemic therapy.
Okay, this patient has completed treatment, went home, and then 6 months later, somebody is calling you from home, saying that the patient has suddenly become unconscious. And they are asking you what they should do. What is your advice to them on phone?
They will have to rush the patient to the nearest medical facility for clinical examination. If they have a home glucose monitoring available to check the sugar level, the easiest reversible cause.
Okay, that is done. What is your differential diagnosis in such a patient?
So it could be related to the disease or unrelated to the disease. If it's unrelated, it could be a sudden cardiovascular event, an acute coronary syndrome, could be hypoglycemia, could be a neurological event, an acute neurological event, could be an arrhythmia. Related to the disease, so there could be an increase in the disease volume with a tumor bleed, which causes a hemorrhagic shock. There could be an airway obstruction due to the tumor causing a sudden respiratory arrest. There could be a superadded infection which was unnoticed, and now the patient is in sepsis with septic shock.
Yes, sir, everything is correct, but there could still be some other possible.
Brain meds.
progression in the brain.
Any questions for us? Because only 1 minute is left.
I think it's not over, sir. No. Same case. So, after his first follow-up, initially his response scan was there was a complete metabolic and morphological response, and then On further follow-up, he was found to have a right paratracheal node. And so we again went ahead, did an EBUS on this, which was positive. And now the next tumor board discussion is to plan for a mediastenoscopic excision of this node. This completes the whole story.
Thank you. No. I think all has been discussed in detail. So, only thing with the last history which I would like to add is in radiotherapy portals. Currently, now we are not treating the full mediastinum. So, we are just treating the involved nodal area. So, that may be the reason there's a right upper paratracheal node would not have been treated in the field during the primary chemoradiation. That is the one thing which comment I can make.
Thank you.
Thank you.
Thank you very much. We really had a wonderful set of examiners. So one more thing in anemia, never forget bone marrow. I think Dr. Purvesh Parikh sir has recently circulated the list, and even I have replied it. No, it is underreported and less given importance. So don't forget bone marrow also, because durvalumab is known to cause pure red cell aplasia, and that should not be forgotten. Okay. So thank you very much. It was a wonderful session, and I think there are a lot of takeaways. Now I would like to invite Professor Dr. Arunara Chaugale, madam, and madam doesn't require any introduction. She is a scientist in charge medical oncology molecular laboratory at Tata Memorial Hospital, and she is going to discuss interpretation of NGS, what a clinician should know. So this is something which is really interesting.
And sorry for the topic given was RT-PCR versus IHC versus NGS, like the significance of. Okay, so I'll try to get to that. So thank you organizers for giving me this opportunity. So coming to the next slide. So as you all know, the overall statistics of lung cancer in India, I won't go much in detail about this, but as you know, among the lung cancer, adenocarcinoma is the predominant one, squamous cell, and then the large cell, and small cell, and others. So in my this 10 minutes talk, I will discuss what is by which method you can detect the EGFR mutations, and as well which ones stands the priority. So as you all know, in IHC, like there are only two antibodies where you can detect the exon 19 and 21. So here is the data where they have compared IHC versus real-time PCR in exon 19 and exon 21. So as you can see, you all know that IHC is a very subjective. It depends upon the scoring system. And here you can see upon that. Is there a point? Okay. Yeah. So here you can see that they have compared IHC versus ARMS PCR, where at the end you can see when IHC was negative, still the exon 19 L858 are exon 19 deletions between E746 and E750 deletions. There were 17% positive, and there was almost so ARMS PCR stands out with a p-value of less than 0.01. And again, you can see for the L858R, again, if you go down, there are around 28 mutations were positive where IHC was negative. So understanding the significance of ARMS PCR, IHC cannot be considered for the targeted therapy in terms of mutation detection. So always here ARMS PCR stands out as compared to IHC. So just this is an overview of the EGFR. So out of nearly 28 exonic regions, we see the mutations concentrated only among the exon 18 and 21. So here you can see the exon 19 is at the C loop, which has been concentrated at the C helix, whereas exon 21 is at the P loop, and you get to see the L858R at the A loop. So as you can see over here, it is divided majoritarily the exon 19 and 21, where you can see the predominantly high mutations as compared to the exon 18 and 21. So the most frequent EGFR mutations, commonly termed as classic or canonical mutations, are in-frame deletions and as the exon 21 L858R as well. So as I mentioned, exon 19, they are the insertions. You get to comprise of insertions and deletions. And when I say insertions, so these are very rare mutations among exon 19, which I will come in the next few minutes. And so what are the rare mutations of exon 18, 19, 20, and 21? As you have seen, apart from in the exon 18, G719X is the commonest one, but also you get to see E709X mutation, which is the exon 18 deletion and not the point mutation. So, in the terms of exon 20, now you can see not only the acquired mutations as T790 mutation, but you also get to see at the baseline of around 2 to 3%. And not only that, you get to see also the point mutations of 768I and exon 20 insertions, where we had missed during by doing the real-time PCR, because there's a lot of importance has been created for this exon 20 insertions, because you are getting to see the lot of targeted therapy coming up. So what are the classification? This is the classification and frequency of EGFR exon 19 deletion subtypes. Now, commonly the canonical is between E746 to A750 deletions, where it is comprised of around 63%. But other than that, also there are some uncommon exon 19 deletions and insertion, which comes to around 37%. The same thing this is another data where they had looked for in the 349 population, where you get to see around 23% of rare mutations. Again, in this another data where they have not only the common mutations of E746 and till A750 deletion, but you also get to see 15N deletion as well. So mutations, there are various types of mutation detection, but each methodology has its own advantages and disadvantages. Like in Sanger sequencing, only at a time, only single gene can be detected. But the disadvantage is that you need to have only at least 25% of tumor cell content in your sample, because it has a very low sensitivity. Yes, allele specific PCR, which is the most sensitive for the single gene detection, but as I said, and it stands over for the Sanger sequencing, it is more reliable, and it can be routinely carried out in the laboratory. But as over a period of time, you must have seen, it is not the single gene EGFR which is important to detect. There is a lot of other driver actionable mutations where you need to detect, like KRAS, BRAF, PIK3CA, which are now driver actionable, and you get to see in the lung cancer various types in adeno and squamous and so on. So single gene detection for the allele specific PCR is again disadvantage only because of they're most designed to detect only one mutation at a time, or one gene at a time. And it enables to detect mutations different from those included in the assay. So you need to only you can depend upon the commercial kits. As we have in our experience, we have missed a lot of exon 20 insertions when we use the commercial kits like Cobas in the system or in the other commercial kits which are available. So you tend to miss the exon 20 insertions on the real-time PCR. Yes, NGS is the answer, But again, if you look only from the single gene point of view, NGS is not feasible. You need to have a multiple genetic alterations, and which allows you not only the point mutations, but insertion, deletions, and copy number variations. And it can be performed either on the FFP or on the fresh frozen collected tissue specimens, and now with the liquid biopsy coming into limelight. But as I said, effective implementation of NGS requires good quality DNA and RNA, which is not always present in the FFP samples because of the formaldehyde degradation of DNA. And of course, you need a lot of validation of panels, which can be expensive and difficult for some laboratories in low or mid-income countries. So here we started EGFR testing in 2011, and up till now we have finished around, it's a decade, we have finished around 8,000 EGFR single gene testing on the real-time PCR. And we came across with some interesting features. Now, the overall, the first published data was in the 2013, where overall frequency rate of in Indian population was around 25%. And you can see, interestingly, as till today, the average has remained the same. It has remained the same as 25%. So from 2011 to 2019, we have done around 8,000 EGFR testing. We have come across some interesting features about EGFR. So it's not only, earlier it was to be done only in the NSCLC, but we have found the mutations in large cell and small cell lung cancers, as you can see over here. And in that, exon 19 deletion was, other than adenocarcinoma, we could see in small cell carcinoma as well, and in the squamous cell carcinoma. Another interesting feature, at the baseline T790 mutation, it is strongly associated with the TTF1 positive, as you can see in as compared with the other markers like Nepsin A and PDL1 or ALK. T790 mutation predominantly is found high with the TTF1 positive. Again, T790 mutation is again strongly associated with the smoking as compared with the other exon 19 or exon 20 insertions and G719X. Coming to the metastatic pattern, which is, we found that it is highly associated with the baseline at T790M mutation with the local and adrenal, and exon 20 insertions was also found to be high in the multiple METs of the mutation. As you can see over here, again, as compared to the METs, multiple adrenal, liver, pleural node, bone, and brain, and METs lung. So it was in the METs lung, the T790 mutation was high as compared to other metastases. So our outcome was that, like the real world evidence, what we have shown in our paper, which has already gone for the publication, that EGFR is mutated at around 25% frequency. 2 to 6% of large cell, small cell, and squamous cell harbors the EGFR mutations. In the middle corridor and a few NER, that Northeast region states, shows elevated EGFR mutation frequency as compared to other states. Within EGFR, exon 19 mutations is the most predominant one, following the L858R. Baseline EGFR T790 mutations were observed in 0.8 mutation and are associated with TTF1. And this mutation also showed association with local and adrenal gland metastasis. And a long-term survival analysis is underway to understand the real world implications of EGFR TKI in NSCLC. So we compared this for the orthogonal testing, EGFR mutations in FFP with the NGS results compared with the RT-PCR. And almost we had around 86% concordance when we compared this with the FFP DNA NGS with the real time as compared to the NGS platform. So approximately we really got a very good concordant rate with the 86%. Similarly, in the EGFR mutations in cfDNA, We also had, when we compared with the orthogonal testing, more than 90% concordance was found with the baseline samples with when there was a 20,000 X coverage, more than 20,000 X coverage. As you all know, for the liquid biopsy, we need to have a higher coverage as compared to the FFP, where only 500 X can be benefited. But yes, if you are doing whole exome or whole genome, then again 10x, 100x is comfortable with it. But as you can see, when there was a less than 20,000 X coverage, the concordant rate was only 55%. So for the liquid biopsy, we need to have a higher coverage when we want to compare it with the FFP samples to get a very good concordance. So when we compared this with the FFP RNA NGS analysis to the IHC FISH-based testing of baseline primary tumors, again, there was a high concordance rate of around 83%. So FFP gene NGS overview and targeted coverage, this we did it in the single gene NGS EGFR testing, like whole exonic regions of EGFR was covered on the NGS platform. Of course, in the routine, it is not feasible to do the single gene testing on NGS. But however, when we compared that, we found that a high coverage overall coverage was around 72x between the amplicon size of 18 and 21. And again, when we compared this with the another orthogonal testing, that there was also the concordance rate was very high with the 91% when we compared with the real-time PCR TAC1 process. So coming to the FISH amplification. So as you all know, there are 3 types, like you can identify large EGFR gene clusters, co-localized clusters of EGFR and CEP7, large and bright EGFR signal. And as you with the literature suggests that the higher amplification, EGFR amplification with the EGFR mutations has a bad prognosis. However, still it is debatable if EGFR is wild type, whether the copy number amplification, what is the response of copy number amplification to the TKI therapy. So the NGS benefits, and these are the benefits and challenges. High throughput method involving massive parallel sequencing, simultaneous screening of several genes, provides broader picture of tumor heterogeneity. As if you consider the challenges, complex data analysis and interpretation is needed. Complicated NGS, it requires complex technical and analytical validation of assay performance. This was the latest paper of how to have a good laboratory practice when you are developing the NGS in your laboratory. And this is very important, as you know that it is like garbage in, garbage out. So this is my last slide. So what the clinicians should understand, how to advise for the NGS test. So these are the several steps we need to take it into mind. Clinical application, NGS assay selection, which panel, sample selection, bioinformatic interpretation, NGS reports, and the patient communication, which is very important. So do I need to inform patient about possible incidental finding outputs? Yes, definitely. So take home message, EGFR by IHC has its own limitations. EGFR gene copy number or amplification detected by FISH could be a good marker for predicting treatment response to EGFR TKIs in patient with NSCLC. NGS is the need of an hour in the clinic. It is gradually being adopted in the clinic. However, because it detects in a single go about the mutations, copy number insertions and deletions, and advanced NSCLC patient with activating EGFR mutation can derive significant benefit for EGFR TKI. Of course, there are a lot of disadvantages because it's not a cost-effective test. But yes, if you want to only concentrate on single gene EGFR testing, then the real-time PCR is appropriate for single gene testing like EGFR. Thank you so much.
Thank you, ma'am, for this wonderful discussion. If you have any questions, ma'am is always interactive. You can ask ma'am at any time. Any questions? Yeah. Thank you, ma'am. I think so. The next session is sponsored by AstraZeneca, and I would like to invite a consultant medical oncologist, Dr. Manasi Sharma from Rajiv Gandhi Cancer Institute, Delhi, and she will be speaking on osimertinib or decomitinib as first-line therapy in EGFR mutated lung cancer. This session is sponsored by AstraZeneca.
Archer now? Yeah, perfect. Okay. So slides are visible? No, not yet. Visible? Okay. All right. Okay. Hi. Good afternoon, everybody. So I'll be talking about the treatment of first line therapy in EGFR mutant advanced lung cancer. And we're looking at either osimertinib or dacomitinib. And this is what we'll be talking about, the efficacy, side effects, and tips for selection of patient. Now, as we know in the previous talk and from before, that in Indian patients, approximately 25% of patients harbor an EGFR mutation. The common mutations being exon 19 and deletion, and exon 21 L858R point mutations. These are also called canonical mutations. Now, these mutations are located in the tyrosine kinase domain and result in increased kinase activity of the EGFR, leading to continued cell proliferation. And we have various drugs inhibiting them. There are notably 3 generations of drugs. The first generation EGFR TKIs, notably erlotinib and gefitinib, which bind reversibly to the wild type as well as the mutant EGFR and don't have any activity with regards to T790M. We then come to second generation EGFR TKIs, afatinib and dacomitinib, which are irreversible EGFR TKIs, and they have a broader spectrum of action. They are active against all 3 members of the ERBB family, that is EGFR, HER1, HER2, and HER4. And they also have activity, maybe some preclinical activity on T790M, but it's only preclinical. We don't know clinically. So there is a potential in these drugs for more complete inhibition of this signaling. Coming to osimertinib, this is a third generation EGFR TKI, and that has it's more selective. So it has less activity against wild type EGFR, hence less side effects, and more activity for exon 19 and L858R, and as well as T790M. So various trials have looked at these drugs in as compared to chemotherapy or against each other. However, and starting from first generation to second to third generation, for us, for today's talk, we will be talking about dacomitinib and the Archer 1050 trial, as well as the FLORA for osimertinib. And as you can see, PFS and OS has been increasing from first generation to third generation drugs. So coming to Archer, this was a multi-center randomized open label phase 3 study, which looked at patients who were treatment naive with advanced NSCLC who harbored EGFR activating mutations with a good performance status. And notably, they did not take patients with any CNS metastasis. And they randomized these patients, stratified them as per their race as well as the EGFR mutation type to either dacomitinib 45 mg/OD or gefitinib 250 mg/OD. The primary endpoint was PFS. The secondary endpoints were PFS by investigator assessment, overall response rate, DOR, TTF, overall survival, safety, and patient-reported outcomes. Sorry. Yeah. So coming to the efficacy, PFS was definitely higher in the dacomitinib group. That was 16.6 months as opposed to 11 months in the gefitinib group. Looking at the response rates were, they were slightly higher, 75% versus 72%. However, this was not statistically significant. So looking at the overall survival, if you look at the survival at 31 months, it was again followed up, and final OS was at 47.9 months. And this was longer in the dacomitinib arm as compared to the gefitinib arm. That was 34 months versus 27 months. Point to be noted is that there was a hierarchical testing, statistical testing, which was done for Archer. So they looked at PFS first. If it was significant, then they looked at ORR. If it was significant, then they looked at OS. Now, because the ORR was not statistically significant, although the OS was, the p-value was good, it was significant on its own, but the gatekeeping procedure stopped the statistical significance testing for OS because of this particular reason. So it wasn't really formally assessed. Coming to different subgroup analysis, most subgroups seem to benefit from dacomitinib over gefitinib. Patients who were more than 65 years of age or equal to 65 years of age didn't seem to do that well with dacomitinib. And however, if you look at the Asian versus non-Asian and the EGFR subtype, they both seem to derive benefit. Coming to the exon 19 deletion mutation, the benefit was not really significant for the HR. However, and it was quite significant for those with exon 21 L858R substitution mutations. There are two
thoughts about this. One, that the del19 mutation anyways is a very sensitive mutation. So, we can't really say much about whether, that's the benefit not being significant with dacomitinib. And secondly, L858R mutations have very poor outcomes with gefitinib. So the overall survival was only 23 months. Coming to, this drug did need dose reductions. That is dacomitinib. I'll come to that later. They looked at those patients where dose reductions were done, and the survival benefit was maintained in those drugs. In fact, numerically, if you look at the second one, those patients who had dose modifications seemed to do even better than those patients who were on the upfront 45 mg dose. But this is a unplanned subset analysis, so we take it with a pinch of salt. Coming to side effects, so dacomitinib is a toxic medication. Most frequent side effects are diarrhea, paronychia, dermatitis, mostly acneiform, and stomatitis. And as compared to gefitinib, which is mostly some bit of diarrhea and AST/ALT elevation. So grade 3 toxicities were definitely higher. There were more rates of dose reductions for dacomitinib, nearly to the tune of 66.5%. And a second dose reduction was seen in almost 27% of these patients. If you look at the permanent discontinuation rates, they were 10% versus 6.7%. So did not really lead to a huge discontinuation rate. Coming to, and this is an important slide, if you look at the next treatment that these patients received, only 10% of the patients in both the arms went on to receive a third generation EGFR TKI. So we'll come to that again in a while. And subsequent therapies were received by around 57% patients in the dacomitinib arm and around 65% patients in the gefitinib arm. So we stopped for dacomitinib. Coming to the FLORA trial, which was a double-blinded phase 3 trial looking at osimertinib. Again, similar subset of patients with one notable difference. That is, they included stable patients with CNS metastasis. They were again stratified by mutation status and race to osimertinib 80 mg OD for the first generation TKIs. And coming to the efficacy, so there was a PFS benefit, 18.9 months for osimertinib versus 10.2 months for the comparator arm, with a very good hazard ratio of 0.46. Seemed to do well in mostly for osimertinib in most subgroups. Coming to overall survival, there was again an overall survival benefit for osimertinib, 38.6 months versus 31.8 months. This was statistically significant with a 20% lower risk of death. Notably, there was a crossover in this trial. So in spite of crossover, there was a statistically significant survival benefit. At around 3 years of treatment, around 28% of patients were still continuing to receive the drug, as opposed to 9% of patients who were receiving first generation TKIs. So this is the subset analysis from the FLORA trial for the overall survival. So CNS metastasis, patients did well, whether they had CNS mets versus no CNS mets. Coming to the mutational status, so those patients who had L858R mutation did not seem to derive so much of benefit. There's been a lot of debate going on about it. The data is quite, it seems to be compelling. But if you look at the overall PFS in all the three trials for second and third generation EGFR TKIs, numerically the PFS for osimertinib is still higher. Also, there was some subset analysis which looked at Asian patients not really deriving so much of benefit. As a secondary endpoint, this trial was not really powered for that, so we can't really say much. And subsequently, there was a Chinese FLORA trial, which you would be aware of, where again they looked at the OS in patients, Chinese patients, mainland China patients, and then there again seemed to be a benefit for osimertinib over the first generation TKI. So almost 50%, again, similar to the previous trial, patients received subsequent therapy. For osimertinib, 70% of them received chemotherapy. And for first generation TKIs, 65% received subsequent therapy and around 47% received osimertinib. Approximately overall, only 30% received osimertinib. And we know that T790M mutation can come up to 50% in these patients. Half of these patients also went on to receive further subsequent therapy. Coming to adverse events. So again, most common reported adverse events are rash or acne or diarrhea and dry skin. Mostly grade 3 adverse events were similar between the two arms, the rates as well as the rates of treatment discontinuation. If you look at the grade 3 adverse events for diarrhea, rash, nail changes and dry skin, they're not very high in the osimertinib arm. 1 point QT interval, 10% prolongation in osimertinib as compared to around 4% in gefitinib or erlotinib. So what do the guidelines say? The guidelines recommend you can give either osimertinib or any of the other TKIs as a first line. Dacomitinib and osimertinib are both category 1, but osimertinib is preferred. So the big question, how do we select our patients? What approach? Do we go for a sequential approach? Do we go for an upfront third generation TKI approach? Which drug do we use first? So honestly, more questions than answers. There's no one right answer. We don't have a randomized trial which has compared these two drugs together. So we'll wait for more data to come in, especially longer follow-up or maybe data for, what happens beyond osimertinib, which is the topic of the talk today that we're going to be hearing. And so what it eventually boils down to is we look at the personalized approach for each patient. We look at multiple factors, that is the systemic anti-tumor activity, impact on use of subsequent anti-cancer therapies, the CNS activity, which is very important, as well as the tolerability, I can't pronounce that, of the drug. So it's important to look at your patient. It's important to look at the performance status of the patient, to look at the age of the patient, look at comorbidities, look at drug interactions. And more importantly, cost is also a factor because osimertinib is expensive. So I'll skip this slide. I'll just mention that overall response rates are mostly the same in both. Anti-tumor activity in terms of survival seems to be better. We don't have a randomized trial. The sequential approach is also good, but we don't know much about it in terms of dacomitinib because only 10% of these patients went on to receive subsequently osimertinib. So let's see. Coming to CNS activity, there is definitely a CNS activity seen with osimertinib. There is activity with leptomeningeal disease also. In fact, we published a paper where we looked at 16 patients with leptomeningeal disease, either first line osimertinib or a second line osimertinib. Response rates of almost 80% in the first line and 60% in the second line were seen. Bloom trial was also there with good response rates, as well as the AURA trials also looked at leptomeningeal disease in certain patients. If you look at the CNS activity, so median PFS of those patients who had CNS metastasis was similar, around 15.2 versus 9.6 months. Coming to toxicity, again, I've put them all together. So out of the 3 or the 2 drugs that we're talking about, osimertinib seems to be better tolerated with less dose reductions, only 4% as opposed to the other. And however, if you look at the treatment discontinuation rate, it's not really very different. So eventually coming to the tips and tricks and the clinical things that we look at when we're working with our patients, we look at various other things also. We look at whether there's a PPI interaction or a pantoprazole interaction. So osimertinib, there's no interaction. Dacomitinib, you have to avoid concomitant use. You can still give ranitidine and H2 receptor antagonist, but you have to give a break between the drug and the two drugs. Notably, hydroxychloroquine, the protocol says you avoid osimertinib for 4 months if the patient is on hydroxychloroquine. In fact, for a couple of our patients, we did not give them because there's a very high risk of QT prolongation. Dacomitinib has no such interaction. If you look at ATT, again, more interactions with osimertinib. So you can give, but use with caution. And dacomitinib, there's no significant interaction that we can find. So you can, probably be a little more less worried that there'll be drug interactions. There's no specific relation to food with either of the two drugs. Osimertinib is known to cause QT prolongation and cardiac dysfunction. So needs frequent monitoring. Dacomitinib, not so much. Coming to, yes, the uncommon mutations. So the most data is for afatinib, which is the only EGFR TKI which is approved by the FDA currently. However, there was a phase 2 trial of around, I think, 37 patients with osimertinib, and the drug seems to have activity against these mutations and can be considered as an alternative treatment. Just a couple more slides. And this is endorsed by the ESMO guidelines. For dacomitinib, there is some data. It's coming in, seems to be active, but we need more data right now. Coming to toxicity management, so I'll keep this short now. So you look at what the drug inserts say. Notably for diarrhea and for skin reactions, you hold at grade 2. So that's important to know, and then you resume as per how the patient tolerates. For other things, these become important. How do you do? What do you tell the patient who's in the reproductive age group? So for you need to use contraception for at least 17 days after the final dose for decomitinib. There is more risk associated in the geriatric population. You have to monitor better. For renal and liver, the data is very sparse for both with for severe dysfunction. Coming to osimertinib, you basically dose reduce if it's a grade 3 reaction or higher. And as I mentioned about the cardiac points, one last thing, with some of these patients, you need to give the drugs through Ryle's tube or through, they're on a liquid diet. So you need to know how to administer both these drugs. My last or second last slide is that it's very important to educate the patient regarding these toxicities. So information sheets are, you can do that. This is what we do in our OPD. We give this out with each prescription of decomitinib, osimertinib or afatinib. In the end, osimertinib seems to be a better choice in a lot of aspects. Decomitinib is one place where, say there's a young fit patient with an L858R mutation with, say, no CNS metastasis. That is one place where we would definitely maybe consider it more over osimertinib. And it's an individualized choice. So thank you.
Thank you, Dr. Mansi, for that unbiased presentations, neither towards any of the TK. Okay, so next I would like to invite Dr. Akhil Kapoor. Dr. Akhil Kapoor is Assistant Professor Medical Oncology at Tata Memorial Hospital in Varanasi. And now, as we have seen, EGFR has made a breakthrough, but definitely all patients do not respond the same. So what we can add? So in the first line, EGFR TKI plus Dr. Akhil Kapoor, sir, will be discussing about it.
Thank you, Us. So I will be directly starting the aspects. We all love to give osimertinib in EGFR mutant patients, but why? As already discussed, it is well tolerated, oral treatment, very good outcomes, bracket usually. Issue, affordability. Generic not going to come, patent till 2035. So that is an issue for us. How many patients of us are actually able to receive this drug, though we all as a medical oncologist love this drug, giving this drug. So what are the alternative strategies available? JEF plus chemo. Yes, it is our own trial and this is very close to our heart and we'll talk in detail about the same. TKI plus metformin. Yes, we have some data from our institute as well. And also there is a lot of data, multiple phase 2 studies from various parts of the world. TKI plus BEV. Yes, TKI plus BEV and TKI plus ramucirumab. For both there is data. We'll see that as well. So this is the content of my slides. So let's start with the star presentation. Professor Vanita Noronha, this has been most talked about presentation. Now OMCT plus low dose immuno is being talked about. Similarly, in 2018, this was the most talked about presentation in the ASCO. So this is all as medical oncologists, we are aware of these slides and this aware of how this trial was designed. The key highlight points which I wanted to show here, the PS2 patients were also included in it. And this is very, very near to actually what we practice in our settings. Asymptomatic CNS meds were also allowed. Again, we'd like to highlight PS2 were also allowed in this study. So this is very, very likely a real world status of patients. JEF plus chemo versus Jeftinib alone. Treatment continued until progressive disease. Primary endpoint of PFS, secondary endpoint of overall survival and toxicity. So again, I would like to highlight rare mutations are also included, but caveat, these were very small numbers. Rare mutations were not allowed in many other studies, but in this study it was allowed. So this is the slide which we all like to see, a wide separation of the curve, which is starting from the baseline. You can see that separation in the curves are starting as early as 3 months. That is the time of usually first analysis which we are doing, first assessment we are doing. And the curves remain separated through a long time and continue to remain separate. That is what we like to see as an oncologist. Similar data is also for oral survival as well. In actually, if we see the PFS difference, it is 8 months versus 16 months. What better we can get with Gefitinib combined with chemotherapy, 8 versus 16. Similarly, OS, if it has not reached overall survival endpoint. So at 18 months, OS was 48% versus 75%. To remember it correctly, I need to counsel my patients. So I need to give some numbers, especially the patients who are well aware, well read. 48%, 18 months PFS, 18 months OS versus 75%. This is the ballpark figure which I try to remember in my practice. This is the overall response differences. Waterfall plots we like to see. You can see only one patient had progression, while all patients had response in JEF plus chemo. While in JEF alone, we know, yes, some patients progress on it. So this is the curve which we have already taken. There's a concept of PFS2 as well, because this is when this paper was submitted in the JCO, there was first comment by the reviewer which we got was, how would you assess the PFS2? Because the patient has already consumed both chemotherapy, which is the first line chemotherapy, pemetrexed plus carboplatin, and also a TKI. Is PFS2 different? So PFS2 is still in favor of JEF plus chemo arm. So we remain assured that it is not due to the problem with utilization of chemotherapy, and we can rest assured. And the difference is not stemming due to utilization of all the drugs, but it is due to delay in appearance of resistant mutations, which is basically driving this. And all the subgroups are getting benefit. You can clearly see whether the gender, exon 19 versus others. This is an important slide because this was previously taught that some TKIs work well on exon 19, while others do not work. But with utilization of JEF plus chemo, you can clearly see both exon 19 and others are getting benefit. Also, PS0 to 1, yes, it is very well separated. Even PS2, it is not crossing confidence interval 1, it is 0.98. So even well-selected PS2 patient, this can be considered. However, I would like to be cautious about the same. I will come to that, the toxicity part. So any improvement in the benefit comes at the risk of the toxicities. So what are the toxicities? It is doubling of the serious clinically relevant toxicities from 25% to 50%. What are these toxicities mainly? Chemotherapy-induced myelosuppression, yes. Around 11% patients had febrile neutropenia. You should be ready to manage that, and you should explain the patient that this is going to happen. And also some amount of nephrotoxicity is seen. This is very common because when we utilize even pemetrexed, we know some patients will develop toxicities, nephrotoxicity. Fatigue was not statistically different in the trial, but in my clinical experience, I found patients to be having significantly more fatigue in patients who are receiving JEF plus chemo, especially till the time patients are receiving carboplatin as well. When the patient shift to gefitinib plus pemetrexed maintenance, I find fatigue to be acceptable. So this is what the clinical data suggests. This is what clinical experience suggests. So there have been multiple other studies. NEJ009 study was there. This has also been very talked about. It included only PS0 to 1. This is a difference from our own trial, which should be taken important. And also this study had very detailed exclusion criteria. That happens very well planned randomized trials of the West and the East. This is what happens. But in our trial, it was more of real life scenarios. So again, similar curves. Gefitinib versus JEF plus chemo, a significantly improved overall responses. PFS, PFS2, OS, all are seeming to getting benefit. So NEJ009 also stamped that JEF plus chemo is a good option. So this again, PD1 and PD2, which I wanted to highlight here. This is the tumor burden, which is coming down with the combination of JEF plus chemo. And if you're JEF alone, this is first progression, then utilize second line chemotherapy with platinum agent. Again, there is some decrease, but again, there is progression. But still, the difference is that even utilizing chemotherapy in the second line, you are not able to reach the survivals which JEF plus chemo is able to give in the first line. So that is how I see this trial and our own trial in our real practice. Now, there's data for erlo plus bevacizumab as well. There is some improvement in survival PFS from 13.3 to 16.9 months. Some improvement at the cost of toxicity, at the cost of extra expenses. There is a relay trial. It is ramucirumab plus erlotinib data. You can see a wide separation in the curve, 12 months versus 19 months. Yes, this seems to be interesting. And where it is working well, I would like to highlight here. So exon 19 deletion and exon 21. These two are very different subgroups. This need to be understood. On exon 19, every drug is working well. it is inherently a good prognostic group. But what is happening to exon 21? All drugs are not working well on exon 21. And here this data is clearly suggesting that exon 21 patients are also having good response to this regimen. So this is important to understand why this is happening. Exon 21 mutation patients have multiple co-occurring concomitant mutations, and co-mutation rate is 65 to 70% with L858R. With exon 19, it is only 40%. So definitely, occurrence of co-mutations is the main problem with exon 21 that needs to be taken care of. Sometimes TKI alone cannot tackle it. You need to either add chemotherapy or you need to add some treatment like ramucirumab. So TKI plus chemotherapy or TKI plus ramucirumab is the preferred treatment for us when high-end molecules which are usually not affordable in our setting. So the preferred combination remains the same. There are some now coming to some data for bevacizumab addition to chemotherapy. There is some improvement, but we are not convinced this data. We usually do not use in our routine practice in our settings. Let's come to metformin. This seemed to be a very intriguing studies. There were 2 phase 2 studies which showed very, very good data. So this is one of the phase 2 study published in JAMA Oncology. You can clearly see there is some separation in the curves and it is starting again very early. The problem is that the study was comparatively small with 70 patients in each arm, and but still it was worth considering. So there were further studies. This is the another study, larger study with 224 patients. Yes, it was a large number. There was PFS difference was not significant. OS difference was numerically, in fact, lower in the metformin group. That was a problem, and overall response rate was similar. So this study sealed that addition of metformin doesn't benefit the patients. So to conclude in brief, choosing wisely remains the key. It is not a single regimen which you can tell that this is the best for any group of the patient. You need to individualize the treatment for your patient, see the various co-mutations if possible. So even doing NGS is useful in some patients. As I talked in the molecular tumor board in a few hours back, even exon 19 deletion is different. If you think exon 19 deletion is a same thing, no. Exon 19 deletion can be from 745 to 759. Usually 745 to 749 is the exons which are involved, but exon 751 to 759 which are involved in exon 19 deletion have different outcomes. Utilizing different TKIs is important in those patients, and there is enough data for the same as well. So with this, greetings from Team H Varanasi. Hopefully we will be calling all of you to Team H Varanasi for a next meeting. Thank you.
Thank you, Dr. Akhil, for giving that wonderful landscape of EGFR+. Now, I would like to invite Dr. Chakor Vora. He's a consultant medical oncologist from Pune. He'll be speaking about the mechanism of resistance in osimertinib.
Thank you, Ashay sir. After these 2 wonderful talks by Dr. Mansi and Akhil, where we saw a lot of clinical work and what we do regularly in clinical practice, I'll be discussing a bit of topic where most of the data or most of the studies are in still phase 1 or early phases of their progress. So I'll be discussing the resistance mechanisms to osimertinib. As has been already discussed, osimertinib is irreversible inhibitor of the EGFR sensitizing and T790M resistant mutations. Osimertinib binds irreversibly to the cysteine 797 located on the ATP binding site of TKD of the EGFR. And Aura and Flora have set the ground for approval of osimertinib in the second and first line study settings respectively. But with this, what has happened is we are using more and more of osimertinib. Akhil rightly pointed out that yes, in India, we use it less commonly in first line setting, or even in second line setting. But yes, there are a good number of patients out there who are on osimertinib even in first line now. And what next comes the question, what do we have in our store for all these patients who may progress on osimertinib one day, sooner or later? So just this one picture shows that we, as of now, whatever data we have from the patients who had progression in Flora as well as Aura studies and in few other studies, almost in 60 to 70% of the patients, in whether we have used osimertinib in first line or in second line, we have definite driver mutations or oncogenic fusions or amplifications, genetic alterations, which can be detected if we do a liquid biopsy or a biopsy from the progressing site. And these are the mutations, alterations that I'll be just discussing very briefly in this presentation. But yeah, as this slide shows, that almost 30 to 40% of the patients, we still do not know what is the exact driver for this resistance to osimertinib. This is a very basic diagram showing the cell surface receptors of EGFR, AL, cross, RET, MET, and HER2. And the key to understand the resistance mechanism lies in this simple image, that the resistance is driven by EGFR TKD domain mutations or by EGFR dependent mutations and alterations that happen which cause resistance to osimertinib, or it can be driven by other alterations which may be happening in either HER2, MET, RET, RAS, RAF, or PIK3 sites. Coming to the first group, the EGFR dependent mechanisms of resistance. The most common is the mutation happening at the C797 site, the osimertinib binding site. This accounts for around 7% of the patients who have received osimertinib in first line, and around 20% of the patients in second line. The strategies to overcome this particular resistance mechanism include giving either osimertinib plus erlotinib or geftinib a first generation TKI, because the binding of these or the effect of these drugs is not dependent on C797. So there are case reports showing a PFS of 3 to 5 months with this particular combination of third generation plus first generation TKI. Adding bevacizumab has added another few months, increasing the PFS to 8 months. There is a retrospective analysis of use of brigatinib plus cetuximab in this setting. And here again, we have seen an overall response rate of 60% with a good PFS of 14 months. Patritumumab deruxtecan is another drug in the pipeline. It's in development. It is a HER3 targeted antibody drug conjugate with an overall response rate seen in about 39% of the patients and a PFS of 8.2 months. There are studies being done to try to prevent such kind of a situation from happening, and one of the studies is a phase 1/2 study undergoing, which is combining osimertinib and geftinib from day one. And the tolerance has been fair till now, what has been reported recently. And fourth generation TKIs are also in development, but most of these still do not have any names. They are just in letters and numbers, and most of them are or 5 of them are in phase 1 studies. Coming to the less common EGFR dependent alterations, G796, L792 mutations, the exact mechanism or the exact evidence of functional effect is not yet clear, but most probable mechanism is thought to be that they interfere with the interaction of osimertinib with its binding site, which is the 797 residue. The third group amongst this EGFR dependent mechanisms is EGFR amplification. Almost 30% of patients in this subgroup will be having EGFR amplifications, and there is an ongoing study which is combining osimertinib with necitumumab, which is an IgG1 monoclonal antibody with an EGFR antagonistic action, and the results of this are also awaited. The next so these were all the mechanisms which were EGFR dependent. Coming to the next group of patients who have osimertinib progression, so that is histologic or phenotypic transformation. And so the two types are either small cell transformation, which we have known about, and some of the patients may also have squamous cell transformation. Small cell transformation is seen in around 6 to 15% in second line settings, while it's seen in only around 4% of the patients who receive osimertinib in the first line. Most of these patients are known to continue to have EGFR mutation expression on their even after transformation, but the expression levels drop, and this explains why osimertinib or EGFR TKIs are not much useful once there is transformation to small cell. The common mutations associated with this particular transformation are mutations in the TP53, RB1, and PIK3CA genes. there are retrospective analysis showing that the most useful protocol or most useful treatment is, as we all know, etoposide and platinum combination, with response rates near about 54% and a PFS of 3.4 months, with a median OS of around 10.9 months after transformation. To be noted is that none of these patients had response to immunotherapy or to combination of nivolumab or nivo-EP. And an ongoing study is looking at the combination of osimertinib with etoposide and platinum. The next subgroup amongst this will be the squamous cell transformation seen in around 6 to 7% of the patient who are receiving osimertinib in first line. And here there is no particular clear molecular pattern which has been evolved till now or detected till now. And currently the treatment will be based on histology. The third subgroup after EGFR dependent and histologic transformation, the third subgroup is MET amplification. MET amplification incident, it is the second most common alteration after C797. And it is seen in around 9 to 24% of the patients in second line, 7 to 15% of the patients in first line. There are multiple studies which are ongoing. The TATON study has combined savolitinib with osimertinib and has shown an overall response rate of 30%, PFS of 5.4 months. Lazertinib, which is another EGFR TKI, third generation TKI, just like osimertinib, it has been combined with amivantamab and has shown an overall response rate of 50%. Tepotinib, another MET inhibitor, in combination or just by itself, is being studied in INSIGHT 2. And we have case reports of osimertinib with crizotinib showing a PFS of 2 to 7 months. HER2 alterations form the next subgroup of such patients with osimertinib resistance, seen in around 2 to 3% of the patients. Again, the studies, the drugs or the trials here are involving patritumumab deruxtecan, the HER3 targeted antibody drug conjugate, osimertinib plus lapatinib or neratinib, osimertinib plus patritumumab, and trastuzumab deruxtecan. RET alterations make the fifth subgroup. RET alterations can be either substitutions or fusion proteins, and they are seen in around 2% of patients with EGFR osimertinib resistance. There are case reports of combining osimertinib with selpercatinib. BRAF alterations, BRAF V600E is seen in around 3% of such patients, and 1 to 2% patients will have BRAF fusions. Combinations of osimertinib with BRAF and MEK inhibitors have been shown to give some success in the terms of response rates or survivals. KRAS mutations, G12C mutation inhibitors, sotorasib, adagrasib are already there, and combinations of osimertinib with these drugs are being tried in similar patients. And these particular mutations are responsible for around 5 to 6% of patients who progress on osimertinib. PIK3 alterations is another subgroup, and it is seen in around 6% of patients who receive osimertinib in the first line, and around 15% of patients who have been on EGFR TKIs, whether first line or second generation TKIs, the show PIK3 CA mutations or PIK3 plus P10 and AKT mutations. And there have been attempts to combine everolimus, the mTOR inhibitor, with EGFR TKIs, showing like out of 6 patients who were studied in this, who were reported in this case series, 5 showed a stable disease or partial response for 4 to 5 months, while 1 had a progressive disease. The ninth subgroup of, or ninth cause of mechanism or ninth cause of resistance is the cell cycle gene alterations. CDK4 and 6, as we know, are major oncogenic drivers, and the genes associated with these CDKs are the CCND, CCNE, and CDKN. The mutations in these particular genes have been documented in 12% of patients who had progression in the AURA trial and around 11% of the patients in the FLORA study. And these genetic alterations, as we know, are associated with poor outcomes. Osimertinib in combination with CDK4/6 inhibitors, palbociclib and abemaciclib, is being studied. Well, but this study is not actually in patients who have received osimertinib in the first line, but let us see what it comes out with. AXL overexpression, something new which I learned while reviewing the data. AXL is an receptor tyrosine kinase, which is again related to cell growth and proliferation, motility and invasion and epithelial mesenchymal transition. AXL overexpression has been associated or has been reported as an acquired mechanism of resistance to first and second generation TKIs as well as to second line osimertinib. Its presence has been associated with decreased response to first-line osimertinib if it is present in the baseline itself. And a drug named enaputamab vedotin, which is an antibody-drug conjugate targeting AXL, which is specific to AXL, is being studied in a phase 1-2 trial presently in different tumors. It's a basket trial. Insulin-like growth factor 1 receptor activation. This activation has been reported in vitro studies, not actually in human studies or like that. And again, an in vitro study showed that a combination of lincitinib, which is an IGF-1 receptor antagonist, combining it with osimertinib has sensitized the cells to osimertinib. So this may be something which we may see in future. Epithelial mesenchymal transition, again, something which is more documented in cell lines and in vitro studies, showing downregulation of E-cadherin while upregulation of N-cadherin and Vimentin, depending on the TGF-beta, SMAD and MAP kinase pathways and EGF-1 receptor induction. This has been known to cause increase the invasive capacity and as well as known to cause resistance to different treatments. It has been documented in vitro studies that EMT is an additional mechanism of resistance to osimertinib. And probably these last 2-3 mechanisms which I discussed are responsible for those 30 or at least a few of those in whom we do not understand or we do not know the exact cause of resistance to osimertinib. With this, I'll just say that resistance to osimertinib, or I'll summarize saying that resistance to osimertinib can happen due to kinase domain mutations, or it can happen with activation of bypassing signaling or phenotypic transformation. So 3 major subgroups or 3 major groups of resistance mechanisms. And all these novel approaches are at various stages of clinical investigations. These include antibody-drug conjugates, combining different various TKIs, 4th-generation TKIs, and immune-directed approaches. What is of most importance is that, yes, every time there is a progression, we should ideally try to get a rebiopsy. And if that's not feasible, go for a liquid biopsy if that's affording, if the patient is affording. And one of the challenges over here will remain for some more time with us. It will be multiple alterations are found, and it is difficult to elucidate which is the exact driving mechanism of this resistance. And only when we know that we'll be able to understand which treatment we should choose for our patient. This is a summary showing, this is a table showing different incidences of different mutations and alterations causing resistance to osimertinib, and their treatment strategies are over here. With this, I thank you for your attention. Thank you.
So I think join for lunch now. I think we have already finished the previous sessions. So everyone please join for lunch, and we meet again at a sharp at 2:30 for the next sessions. After the wonderful sessions of EGFR TKI, now we are going to have a next session, which is by Dr. Shrikant Nani. He's assistant professor in Tata Memorial Hospital, Mumbai. He will be speaking about post-osimertinib treatment options. Over to Dr. Shrikant.
Good afternoon. Thank you, organizers, for inviting me to this talk. Today, I will be talking about post-osimertinib treatment options. First-line osimertinib is the standard option for EGFR mutated patients. Either liquid biopsy or in rebiopsy, if patients were tested on T790M, then osimertinib is the standard therapy. After failure of a EGFR TKI, mainly the standard is platinum-based chemotherapy, and it has a PFS of 4 to 6 months. Subsequent salvage therapies are there after EGFR TKI failure and platinum chemotherapy, but they have PFS of around 2 to 3 months only. As my previous speaker has elucidated these resistant mechanisms both to first-line usage of osimertinib and second-line usage of osimertinib, majority of the mechanisms are unknown, and main resistant mechanisms to osimertinib are divided as on-target resistant mechanisms and off-target. Coming to on-target mechanisms, it will be on EGFR receptor. These most common mechanism is C797S. The off-target mechanisms are bypass mechanisms where you with MET amplification, HER2 amplification, insulin growth factor receptor based, and ALK, and also AXL. The other modalities of resistant mechanisms are epithelial-mesenchymal transition and small cell transformation. Coming to the treatment regimens are in various undergoing trials. Main treatment regimen was amivantamab plus lazertinib. It is a phase 1b study in patients who has progressed on osimertinib. Lazertinib is a third generation EGFR TKI, and amivantamab is a bispecific molecule, and patritumab deruxtecan and other agents. I'll be discussing about them in further slides. Coming to amivantamab. Amivantamab is a fully human bispecific antibody which targets both EGFR and MET. FC portion has an immune cell directing activity, and it has granted an breakthrough therapy designation from FDA. And lazertinib is also a potent third generation TKI. These combination of these two agents is most studied and well used in osimertinib resistant patients. Coming to the Chrysalis 2 cohort update in this ASCO 2022, where 39 patients who were progressed on osimertinib prior therapy has a blinded independent review overall response rate of 21%, and seeing the water flow plot, majority of the patients had some or other response post osimertinib with this amivantamab and lazertinib. And coming to the most common side effects in this population was by usage of this amivantamab and lazertinib were infusion-related reactions, that was 78%, and rash, followed by paranoia, which is due to the TKI. More than grade 3 events were 16%, resulting in 4% discontinuation and 18% in dose reductions. Mariposa 2 is an ongoing trial which is assessing amivantamab plus lazertinib as first-line therapy following progression on osimertinib. Coming to patritumab deruxtecan, it's a fully human anti-HER3 IgG1 monoclonal antibody, which is linked to a topoisomerase 1 payload, topoisomerase 1 inhibitor payload, and HER3, coming to patritumab deruxtecan, HER3 is expressed in 80% of all the patients who are having EGFR activated mutations in NSCLC. In a phase 1 dose expansion study, patritumab was given as 5.6 milligram per kg every 3 weeks in cohort 1, which showed an improvement of overall response rate in 39% in 44 patients who progressed on osimertinib and platinum-based chemotherapy. Based on this study, FDA has granted again a breakthrough designation approval for this drug in this December 2021. Coming to the treatment-related adverse events, 94% of these patients has any grade of toxicities, out of which grade 3 toxicities were higher, which is up to the tune of 54%. But majority of the toxicities are hematological toxicities such as thrombocytopenia, decreased ANC counts, febrile neutropenia, fatigue, anemia, dyspnea, and hypokalemia. Coming to the other options, a phase 1 trial, which is again updated in the ASCO this year, presented its final results of osimertinib plus necitumumab, which showed partial response in dose expansion cohort in more than 3 out of 18 patients, which has met its primary endpoint with a median PFS of 2.3 months. Another phase 1b study using Teliso-V, which is an antibody drug conjugate, telisotuzumab vedotin, is an antibody drug conjugate that is again targeting MET overexpression after failure on prior osimertinib. The overall response rate with Teliso-V is 58% in 19 patients, and major treatment adverse events were sensory neuropathy, nausea, fatigue, and cough. Coming to other options, as previously discussed, in TATTOON phase 1 trial, phase 1b TATTOON trial, osimertinib is combined with savolitinib in a cohort of 18 patients and yielded an overall response rate of 67%. Most common grade 3 side effects were grade 3 transaminitis, and also pneumothorax and anaphylaxis was noted in 4% of patients, and other common side effects were a decrease in ANC counts. There were 2 deaths reported due to acute renal failure, and this combination is further being prospectively evaluated in Savannah trial. And again in phase 1b TATTOON trial, there is another cohort where osimertinib plus selumetinib was used as an intermittent schedule. In a cohort of 18 patients who had progressed on prior osimertinib, it yielded a partial response rate of 23%. The most common side effects were diarrhea, rash, and nausea. Coming to the other options, in C797S mutations, we can combine first and third generation TKIs like erlotinib plus osimertinib. When someone is having an oligoprogression, we can continue osimertinib plus local ablative therapy. When someone is having a small cell transformation, then we can use a platinum doublet with platinum and etoposide. Another coming to PD-1 antibodies, then findings from exploratory analysis of IMpower 150 trial is the only one which showed atezolizumab with combination of chemotherapy and bevacizumab has median OS of 13.9 months when compared to 10 months in chemotherapy alone arm post progression of osimertinib. When someone is having a CNS progression, we can use double dose of osimertinib plus local CNS directed therapy. Coming to other ongoing trials, osimertinib plus TDM1 combination is used in TREMEO study. It is a phase 1 and / phase 2 bar study. And other combinations which were employed were osimertinib with BCL2 inhibitors or PARP inhibitors. There is another third generation TKI, nazartinib, is used in combination with trametinib. Thank you.
Hello. She's going to moderate the sessions, which is again a Viva case based. So I request Dr. Anu to invite all the examiners and please introduce them.
Thank you, sir. Thank you, organizing team, for giving me this opportunity. So I'll be moderating the second examination-based session. So for this, I would like to invite my presenters. First, Dr. Venkatesh K. He is DM medical student at Tata. Dr. Harsh Shahu. He is also medical oncologist at doing his DM medical oncology at Tata. Arnav is coming. Okay. So in place of Dr. Harsh, Dr. Arnav is coming. And third is Dr. Gargi. She is radiation oncologist at Tata. And our examiners are Dr. Nikhil, his consultant medical oncologist at Yashoda Cancer Institute, Hyderabad. Dr. Asim Samar, consultant medical oncologist at Bhagwan Mahavir Cancer Research Center. Dr. Ashish Bakshi, he is a consultant medical oncologist at Hiranandani Hospital, Mumbai. Dr. B.K. Smriti, ma'am, she is also consultant medical oncologist at Lilavati and Bombay Hospital. Dr. Tarachand Gupta, he is consultant medical oncologist at Bhagwan Mahavir Cancer Center, Jaipur. Okay. And Dr. Bhavin Visaria, he is radiation oncologist at SCG Cancer Center, Mumbai. And Dr. Siddharth Turkar is also consultant medical oncologist at Raipur. So let's begin with the case. Okay. So we'll start with the history part. Dr. Gargi is presenting the history.
Dr. Anu, one second. Dr. Siddharth Turkar is there instead of Dr. Ashish Bakshi. Yeah. Okay.
Hello. Yeah. So here we had a 65-year-old lady from West Bengal who presented with the chief complaint of left-sided weakness since a duration of 20 days. The weakness was gradual in onset, starting with the upper limb and then progressing to the lower limb. It was realized when she noticed difficulty in raising her arm overhead, followed a few days later by difficulty in climbing stairs. So there was no associated decreased sensation, no decreased vision, only difficulty in facial movements, speaking or swallowing. There were no involuntary movements and no bladder or bowel complaints. So the patient did not have any history of similar complaints in the past. There was no previous history of hypertension or diabetes mellitus, no history of tuberculosis, and the patient sleep and appetite was normal, and she had no habits. Coming to the general examination, the patient was conscious, well-oriented to time, place, person. Febrile, pulse was 88 beats per minute regular, BP was 110/70 millimeters of mercury, respiratory rate was 18 per minute, and there was no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. BMI was 23 and ECOG was 2. Coming to the systemic examination, let's start with the CNS examination. The patient's higher mental functions were intact, cranial nerves were intact. There was no lymph atrophy, no sensory deficit. There was loss of power in the left upper limb, 3/5, and left lower limb, 4/5. The respiratory system, as I said, respiratory rate was 18 per minute with no structural deviation. Air entry was bilaterally equal with no adventitious sounds. Cardiovascular system was also normal, and on abdominal examination, there was no free fluid or organomegaly. Bowel sounds were normal. Yeah, that's it for history and exam.
Okay. So, Dr. Gargi, can you please summarize regarding the organ involvement and your summary, patient summary?
Okay.
So, in 50 words, you please summarize.
This was a 55-year-old lady with no comorbidities who presented with gradual onset left hemiparesis of a duration of 20 days.
Okay. So, have you taken the history, family history, or some other illnesses with the lady in previous?
Yeah, so she did not have any history of hypertension, diabetes, or TB.
Okay,
And
no
not on
family
any
history for
medication.
Cancer.
Yes, sir.
No family history, suggestive of cancer in the family history.
No, sir, but at this point in history, there was nothing to suggest she has any malignancy. So,
Okay.
So she had only one symptom, which is suggesting the upper limb weakness,
Yes.
and the power is gradually decreasing. It is 3/5 now. So to this point, what is your DD for this kind of the symptom?
The most
It
likely,
is a motor weakness.
most likely DD would be a cerebrovascular accident or another
Yeah.
at this point in time.
And there was no history of smoking also, right?
Sorry,
No
sir.
history of habits or addiction?
No habit.
Okay. So, madam, you want to ask something?
Yeah, so now how would you go about investigating this patient?
I would like to do blood investigations in the form of CBC and biochemistry to see if any abnormalities. And after that, I would like to image the brain with MRI.
And okay, so do you have the MRI findings?
Yes, sir. Yeah. So on MRI, we had a ring enhancing lesion, 1.5 into 1 centimeter in the right frontoparietal lobe with perilesional edema. Also, there was a small hemorrhagic metastatic lesion in the left cerebral hemisphere.
So how would you now go about trying to diagnose what these lesions are?
So the lesion on the MRI was reported as metastatic. So we would like to look for the primary. So I would initially like to further examine the patient. Since she is a female, I would like to do a breast examination, followed by per vaginal and a per rectal examination. If nothing, after that, depending upon the findings, I would like to further image the patient to locate the primary.
So, Dr. Gargi, you have mentioned in your physical findings and examination, there was nothing suggestive of any abnormality in the physical exam, right?
No.
Okay. And whenever you were asked in the exam, like which investigation you will do, you just go by the target organ. Like here is the MRI, and MRI is better said like contrast enhanced MRI.
Yes.
You said perilesional edema is there, but your images projected the images, and there is not much of the perilesional edema. So was it very significant in your finding or what?
I have put the contrast enhanced images, but yeah, the edema would be better seen on the T2 weighted images. So I have not actually put those.
For us, all the 6 images are almost same. See, the section is same from the one level. The only the right side hemisphere has one ring enhancing lesion.
Yes.
So you can project in one slide 2-3 images, T1, T2, and the contrast, right?
Yes.
So we'll ask to Dr. Hirsch. We'll switch to that. He's the student in the medical oncology. So which investigation you want to do further? She has said like the patient had 1 or 2 metastatic lesion in the brain. So how you will proceed further?
I'll go by doing a systemic imaging, maybe a PET scan, whole body PET scan to look for the primary site.
You will do PET scan. Any other investigation which you want to do?
Based on the primary, then we'll go ahead for tissue diagnosis with biopsy from the primary site. We can find out the primary site. We can go ahead with a MR spectroscopy to look for whether it's a primary CNS.
Before doing PET scan, would you like to do anything for the brain with respect to intervention, a biopsy or excision? Because she has presented with a hemiplegia.
First investigation, when she presented to casualty, I do an HGT to rule out hypoglycemia, then I do an HGT brain, and followed by if there is nothing there, I go ahead with an MRI. Apart from that, brain biopsy is itself a risky procedure. If I can find an alternate source for tissue diagnosis, I'll try to find out.
So Dr. Venkatesh, is it okay to do first NCCT brain and then MRI and then other investigation, or directly if it is available, you go for the brain MRI?
So in this case scenario, because the patient is having 20 days history, so NCCT brain, I wouldn't have gone, sir. I would have gone for MRI. And if they're being showing a lesion, I would have gone for MR spectroscopy. At least you'll tentatively you can get it's a metastatic or any TB or something tentatively. Then I would go for the imaging, at least CCT, TAP, I mean thorax, abdomen, pelvis, even if not, or PET scan preferably.
Okay, so have you done PET scan?
Yes.
Okay, what are the images?
So in PET, there was a lesion in the right upper lobe of the lung measuring about 6.9 into 3.6 centimeter with a SUV max of 38 round. And also there was a sub-centimeter non-FPG avid paratracheal node. And also the lesion which was seen on MRI was corroborated on the PET CT. So these are the images of the PET.
So now the impression is the primary is in the lung.
Yes, sir.
Right. So Venkatesh, how you will proceed? So
Now we'll go for CT gate biopsies.
CT guided biopsy. Any instruction which you want to give to your intervention radiologist?
To get that more tissue diagnosis, more biopsy, more samples, more cuts.
How many cores of the biopsy? At least you want
10 to 12.
10 to 12. It is very. It is not prostate. It is not other solid tumor. It is lung, which is situated in the hollow cavity, and is a very vital organ. So maybe 3 or 4 cores are suffice, but the length should be optimal, like 1 or 1.5 centimeter. So it is okay to have this much of tissue. So why do you want many cores or more tissue?
One is from proper diagnosis, histological diagnosis. Sometimes if there is discrepancy, then one is for driver molecular testing, which is now the more era towards molecular testing.
So in which solution you will take the biopsy tissue? Suppose they have done the biopsy, tissue is in their hand on the gun biopsy, and now they want to order some solution to preserve that. So which is that solution?
Formalin.
So your molecular test can't be done on the formalin preserved material. So if you want to do molecular testing, you need to put the tissue in the saline. And if you want to do histopathology, then you should do it in the formalin solution, buffered solution.
So apart from histology, what other tests would you order in this patient? What are the molecular tests and which is the whole panel that you would order?
So first I would order for EGFR, AL cross and PDL1. The first test which I would like to order. And it being metastatic in infertile, I'll go for NGS also. Being metastatic setting, NGS.
So would you go sequentially or you would order NGS right away?
Preferably I'll go for NGS if you have sources to get a rare report. Right? Because patient is stable, not symptomatic much, not symptomatic for the primary point of view. So maybe I can wait. So he has time, so I will go for NGS. Finance on not issue. Otherwise, I will go for a tier staging wise. First, at least these 4 things, then followed by later.
But what is your opinion? We should go sequentially or directly we should order the NGS?
If patient is affordable, we can directly go for NGS and PDL1 because EGFR, L cross, everything will be covered in that. No need to spend twice.
What is the benefit of NGS or over IHC in the sequential tests?
NGS is more sensitive. Second is it will cover wider panel of mutation. It will involve RET, MET, and other targeted mutation will also be covered. That may not be seen in by targeted IHC or EGFR PSR.
Apart from the EGFR, L cross and PDL1, what are the other mutations you're looking for in this patient?
We are looking for MET, KRAS, NRAS, BRAF, and
What is the lung panel usually constituted?
EGFR, L cross, and then
Venkatesh, you will add this?
I mean HER2, sir. In addition to MET, RET.
Yeah, this is a 12 gene panel, RET, MET, KRAS, EGFR, ALCROS, and HER2. There, and PDL1 is by ISC usually. That is NGS. So actually, NGS preserves the tissue over the ISC. It consumes the less tissue. So it is easily we can do the test. And if we do the sequentially, these tests, it takes the time more than the NGS. Usually NGS report nowadays is available within 5 working days only.
So you have done the histology and your institute report says it is the NSCLC.
Yes, sir.
What is your report? So please tell us.
So the patient had a EGFR mutation and exon 19 deletion.
So what are the other types of the EGFR mutation you know for the clinical practice?
Exon 21 point mutation, exon 18 deletion.
Which are clinically relevant? Is 3-4 mutation testing. What are the targets for the EGFR directed therapies? Exon 19, exon 21, and other?
Yeah,
What about exon 18 and 20?
So exon 20 T790M, so exon 90, exon 21 L858R, then EGFR 20 insertions, and even some other 3 rare mutations like S768I, G712Q, and
Exon 18 also there.
exon 18. So based on that.
So what is the complete diagnosis of this patient now?
Oh, metastatic adenocarcinoma of lung with metastasis in the sites of brain with EGFR exon 19 deletion.
So this is a single lesion in brain. How will you proceed with this patient?
First, he is symptomatic for the brain lesions. So first, I'll ask my radiotherapy doctor to go for opinion about an SRS, role of an SRS. Because it's a single lesion, not multiple lesions. Single lesion, so can be targeted.
2 lesions actually.
2 lesions.
No, but less than 3. They are less than 3. So
Oligometastatic.
local therapy can be given. Okay. So Harsh, what is your opinion about the not to give RT or to start the therapies?
Patient is symptomatic for brain mets. First, I'll try to start, go ahead with RT, and then continuously start work up for systemic therapy and start systemic therapy on patients.
Give SBRT.
Yes, sir, as well.
So suppose patient after the 5 days of the SBRT, patient came to in the emergency with some seizures. So how you will address that?
So the seizures most likely will be of due to post RT edema. So I'll start hemodexamethasone, mannitol, and just to document, I'll do a imaging, brain imaging, MRI available, and start him on anti-epileptics.
Actually, brain imaging is not required at that point of time because it is just because of the RT-induced edema. SBRT has a high fraction of the radiation, so it causes difficult edema, and sometimes the seizures are there. So we need to address with the decongestive measures and further continue with your systemic therapy. So, Raghu, which kind of systemic therapy you are advising to the patient?
So we would start the patient preferably on TKIs, and this patient, since she has brain mets, we would prefer osimertinib if she's affording, since it has CNS penetration.
So how many TKI against EGFR do you know, Dr. Venkatesh? In total.
First generation, second generation, third generation. First generation erlotinib, geftinib. Then we have dacomitinib in the second generation.
Second generation is not dacomitinib.
So
Afatinib?
Afatinib is.
Yeah, then
the third generation osimertinib. Then EGFR 20 exon insertions, which acts few drugs, monoclonal antibody, amivantanib, mobocertinib.
So you want to start with osimertinib, right? So what instruction you will give to the patient? What is the dose of the osimertinib, and from where they will procure the drug?
80 mg OD. What is I'll start, sir. Before that, I'll work up. I'll go for ECG, 2D echo, ECG. I'll just check for prolonged QTC interval, baseline QTC. procuring, if they're affordable, we'll go for, otherwise on patient compassionate, patient assisted program.
Any drug which you want to avoid with the osimertinib or instruct the patient not to have the drug?
PPA drugs.
PPA drugs doesn't have any interaction with the osimertinib, but as Dr. Mansi had presented in her presentation, this hydroxychloroquine, which has a QT prolongation if given with the osimertinib. So this is to be remembered. It was learning for us also. And you will give osimertinib 80 mg. So which kind of the food instruction you will give?
No relation with food, sir.
No. Like it can be taken any hour of the day or with or without the food. So earliest when the response will become, or you are expecting the response with the osimertinib? At what time frame there will be a response with the osimertinib? So sometimes patient relative may ask you कि क्या होने वाला है, patient कब ठीक होगा या कब improvement होगा, so you need to know that. Harsh, any insight about this?
It can generally take comparatively more time than chemotherapy, so it will take around 1 to 2 months for.
We are not discussing chemotherapy right now. You tell us about the osimertinib, when the first response will come. It might come.
First response may come within 1 or 2 months. We'll assess the response generally after 3 months.
Yeah, 4 to 8 weeks are 8 weeks is the cutoff for the response maximally patient get. Till the time you need to support the brain mets or their symptoms with your decongestive measures, sometimes anti-epileptics or some other measures, metabolically correction of the calcium, magnesium, whatever is there. So that is there.
Yeah. Now, suppose what are the other options apart from TKIs? I mean, what are the combinations also which are approved? This first thing.
We can give chemotherapy plus gefitinib if the patient is not affordable. We can give pembrolizumab carboplatin plus gefitinib.
Sorry?
Pem carbo plus Jef combination we can start. It has shown to be equally efficacious to osimertinib.
And what about if it is an L858R? What type of response do you expect from osimertinib if that was the mutation?
So even for L85R, osimertinib is a drug of choice. It is proven superior to single-agent gefitinib.
Yeah, but are there some other options which have shown slightly better results, though not in a head-to-head comparison with osimertinib, but in their studies, so which have been spoken about?
And also afatinib has been compared to, I'm not sure about that. Ramucirumab with erlotinib combination or bevacizumab combination also is shown somewhat.
Yeah, and what about decomatinib? It has decomatinib.
Decomatinib also is not as good as osimertinib, but decomatinib is also shown.
What about if you have uncommon mutations?
Afatinib is, of course, osimertinib also works, but 3 uncommon mutations like S768I is 3 mutations which afatinib is recommended. If not, then osimertinib also works on.
Okay.
Though erlotinib also works a few, but not good response as afatinib. Afatinib is approved.
So any instruction about the side effect of the drug, which the patient needs to observe or have an idea before starting the therapy, you want to instruct the patient family members with osimertinib?
So osimertinib mainly rash or diarrhea could be not so common, but rash is one thing, sir. And regularly we have to monitor the ECG for QTc prolongation and sometimes bradycardia. Thrombocytopenia.
Rash is the commonest side effect. Skin dryness and rash is the commonest side effect. And sometimes patient may have diarrhea also, but it's very rare with osimertinib. So how we should deal with the rash problem or the skin dryness and all that? Any advice you want to give?
Anything more than grade 3 or 4, we have to hold temporal. Grade 2, we can observe once it is improved, either go for dose reduction or at the same level as per the tolerance. Grade 3 or 4, we have to discontinue. Not.
For time being, you can say like withhold the drug, but generally grade 3, grade 4 skin rashes are uncommon with the osimertinib. Grade 2, there are very high number of the patient will have. So emollients and the other preventive measures they can have. Okay. So regarding the PMJF and carboplatin, which component of this protocol is giving the equal results to control the brain mets? Amitriptyline, carboplatin, and gefitinib. This is a very good protocol, and so we are saying like it is equivalent, almost equivalent to the osimertinib to controlling the brain mets. So amongst the, what is the component which is controlling brain mets? So, this is the carboplatin which is penetrating into the brain and controlling the mets. If gefitinib is the case, then why the osimertinib is superior than the gefitinib? So go ahead. Which kind of treatment you have given to your patient?
This patient received fractionated SRS to both the regions, 27 grade 3 fractions, and then following that was started on osimertinib.
Okay, so what is the follow-up of the patient? Is she doing well?
So she's due for first follow-up now. Not yet.
Okay.
So what is the timeline that you would following up this patient, and what are the investigation of choice? You would do MRI separately at every single follow-up, or you would do MRI only at 1 month, 3 month? When will you do PET-CT? So what is your follow-up protocol for this patient?
We could do MRI initially at 3 months, and in the first 2 years, we would do an MRI 3 to 4 monthly, followed by 6 months after 2 years. At CT, maybe at 3 months, and then CT imaging every 3 to 4 months.
So what is your idea, Harsh? When you will follow this patient, which investigation you will advise at a minimum?
I'll ask the patient to come back after 3 months and do a routine CBC biochem and ECG, lipid profile and HbA1c. And then I'll do a response scan with CECT.
Why HbA1c?
Yes, sir.
HbA1c, why do you want to do this? HbA1c? Osimertinib, is there any risk for the metabolic syndrome or diabetes? No,
it does not.
So examiner always asks in the exam why you have done this investigation. So before speaking, you just think about, suppose sometimes you say like we do the calcium, magnesium, and as an investigation. So the pertinent to the drug, we should do the investigation. So HbA1c is not required.
And do a response scan with CCT thorax and abdomen and MRI brain to look for the brain.
She had done the PET-CT in the investigation while she was working up. So will you compare with the PET-CT or will you do the CT scan?
We can compare with PET-CT also, or we can do we can go ahead with CT scan also. PET-CT in every visit is not required.
Not every visit, but in the first visit. You want to see the response of the drug also. CT scan is a morphological scan, is a black and white. So you don't know what is the activity going on in the tumor tissue. So PET-CT will be advisable in this patient because we are targeting the lesion. And if there is a response, we can see further do or not to do. Right? What about the scanning of brain?
At 3 months, I'll do an contrast enhanced MRI.
So for first visit is okay to do the MRI. Otherwise, you will do when the symptom will appear or any problem or anything happens to the patient regarding the higher mental function or some symptomatology is there to indicate to do the brain imaging. Otherwise, not. And what you will see in the brain MRI if you have done the MRI? Because question is post SBRT.
So we'll see this necrosis around the lesion with no primary regional edema.
They will ask how the necrosis appear in the MRI. On the which scan you will see, T1 or T2?
I'm not sure about MRI.
On the T2 images, they will see like the hypointense lesion if the necrosis happened, and we will see is there any new lesion which appeared in the duration of course. Otherwise, we will not do the MRI again. Do once the patient has symptoms, right? So suppose you have given the osimertinib for 18 months or maybe 12 months, and now the patient has started having the symptoms of progression, and how you will look at the case in this scenario?
So I'll repeat the biopsy from the lesion that has increased in size and send it for NGS. If the patient is symptomatic, I'll start him on chemotherapy. If patient is not symptomatic, I'll wait for NGS report, and based on that, I'll decide my further treatment plan.
Dr. Venkatesh, what you will do if there are some suggestion of progression clinically?
Clinically, if he's symptomatic, I'll go for chemotherapy. But I'll do a biopsy and I'll send for molecular testing.
First, you will do some scans to confirm the problem.
Response scan. I mean, I'll first go for scan, sir.
Which scan?
PET CT. Then if he's symptomatic for brain, again MRI brain. Then I'll go for, if you have feasible biopsy, if there's a new lesion, I'll try to target the new lesion if it's feasible for biopsy. Any new lesion.
So suppose patient is controlled in the brain, centrally controlled disease. Lung is also controlled. Patient has developed the new lesion in the liver. What you will do then?
I'll go for liver biopsy.
What you will do with the biopsy?
I'll send for NGS.
What region you will do that? Why you will do the NGS on this liver biopsy tissue?
So probably any new mutation or any other resistant mutations which have come, new mutations which could be targetable.
How the osimertinib resistance appears?
By tentacle pathways, multiple pathways. One is
the resistance. Second reason why you will do the biopsies. What?
Whether it's not a new primary or
maybe new primary, or maybe the adenocarcinoma has changed its histology, and sometimes there are 5 to 15% chances that patient may convert it into the non-small cell, so small cell. Right? So you will do the biopsy. Right?
What are the types of progression that you see? I mean, you're doing a PET scan. So what is important? Like, what type of progressions do you see when a patient is on TKI?
Normal progression, one is hyper progression.
So no, is it, so you want to know whether it's one side progression or there are multiple sides of progression. So does that affect your decision on how you would manage this patient? Whether it's just one side progression or it is multiple sides of progression?
Yes. If it is single site, we can target that with a local treatment, followed actually, we can continue treated. Till then, meanwhile, we can continue the osimertinib with local therapy. If it's liver, targeting liver, that lesion with either TACE or some interventional treatment, followed by continuation of same thing, or totally change the treatment management. And single lesion or multiple lesion depends on whether it's feasible for any local therapy.
Okay. Do you have the other case?
One more case.
Okay. So we were thinking like it's one case.
So we have second case. Yeah.
Next case, please. On progression, you just look at whether we can handle this progression locally or we need to give the systemic therapy or change the drug. So suppose patient was, I'm just trying to patch up the flying leg. So if it is a CNS controlled disease and controlling the primary side, we may address with some local therapies also. Suppose there was some bone mats, we can give local RT. Here we can do the local ablative procedures or sometimes test and tear, and then see what happens to the patient. then we might continue or we should continue the osimertinib because centrally it is controlled disease, and we may add the further things like Dr. Akhil has presented earlier. We can add the bevacizumab type protocol, or sometimes we can use the other chemotherapy also. Second.
Yes, sir. Finished. So 51-year-old male from Madhya Pradesh, present with chief complaints of cough since 2 to 3 months and exertional shortness of breath since 1 month. That's the chief complaints. So coming to the present illness, cough since 2 to 3 months, predominantly dry cough and no postural variation or nocturnal variation and no aggravating or relieving factors. And also complaints of loss of appetite with weight loss about 3 to 4 kgs in past 3 to 4 months, non-significant. And exertional dyspnea, non-progressive since 1 month, it's not progressive. It's MMRC 1 grade. And no PND or wheeze, paroxysmal nocturnal dyspnea or wheeze, no chest pain or fever, and no hemoptysis. So past history, no history of any tuberculosis, and known diabetic since 8 years on OHS, oral hypoglycemia, and no hypertensive bronchial asthma, and no previous surgeries or procedures in the past. So is a tobacco chewer since 20 years, and bowel and bladder habits are normal, and sleep is normal. And treatment history, only OHS for diabetes mellitus, and apart from that, no previous treatment histories or any interventional procedures under. So coming to the summary, 52-year-old male, diabetic, present with chronic dry cough and loss of appetite with exertional breathlessness of grade 1 since 2 to 3 months.
So you tell us what is the meaning of diurnal variation in the cough? What does it indicate?
Some nocturnal cough, sometimes patient is on lying on some GERD, some dry coughs because it's predominantly dry cough, GERD, or sometimes more than bronchial asthma. Or something.
Yeah, bronchial asthma. And bronchial asthma. So if the cough is very late in the night, patient was sleeping and suddenly gets up from the bed. So it is a cardiac. Early morning, like 3 or 4 o'clock, when the patient just get up and has the wheezing and all that, that is the respiratory illness. And which type of the cough is more in the daytime? So usually they are the infective sort of cough, and in night it is because of the systemic involvement of the organs, they appears in the night. So you have mentioned, so I asked, so what is your differential diagnosis for this case?
So because it's a 2 to 3 months long standing and no others with exertional shortness of breath, no others probably first have become malignancy. Sir. Next remote possibility, COX in our scenario.
But you said dry cough was there.
Dry cough.
So dry cough is more in favor of the malignancy rather than some infection. Okay, go ahead. The workup part.
So coming to examination, patient is conscious oriented, febrile and pulse is regular 86 per minute, and all peripheral pulses are felt, and blood pressure is normal 120 by 80 millimeter, right arm supine position, respiratory 24, saturation 98%, and no pallor, icterus, edema, clubbing or cyanosis. But there is left supraclavicular lymph node palpable about 2 centimeter, which is non-tender, and skin over the node is normal. And JVP is not elevated. Nicotine stains are present on lips and teeth. ECOG 1. And on systemic examination, respiratory, upper respiratory tract systemic examination normal, and inspection, chest is symmetrical, cylindrical shape, trachea is in midline, and respiratory movements are equal. No sense of volume loss, and apical impulse is not seen on inspection. Palpation, all inspiratory findings are confirmed. In inspection, no dilated veins or scars, and no usage of any accessory muscle. Percussion, resonant note is heard in all areas, and no cardiac dullness is present. So, on auscultation, bilateral air entry is present and equal, and no wheeze. And other systemic examination is within normal limits, cardiac and abdominal and CNS. So coming to the final summary, 52-year-old male with chronic cough and exertional dyspnea, and on examination, supraclavicular lymph node is palpable and normal other examination findings. So my first possibility now will be malignancy.
Then proceed for the workup part.
So these are, before coming to data, these were the investigations which are done outside, sir. So just CT thorax is done, and it showed a left lower lobe mass with mediastinal nodes, ipsilateral paratracheal, prevascular subcarinal, and contralateral paratracheal nodes, and widespread infective changes, but no obvious other meds. And bronchoscopy is also done outside, which cytology is from endobronchial growth, suspect adenocarcinoma. With these reports, he has presented to TAPTA. And in TMH, hemoglobin is 15, total count of 12,500, platelets of 4,15,000, creatinine 0.9, sodium 139, albumin is 4.3, and other LFT is normal, 2D echo is normal, and calcium is also normal. So imaging was done, PET CT. So it showed a peripherally enhancing central necrotic soft tissue mass noted involving the lower lobe of left lung about 5 centimeter, and also metabolically active ill-defined interseptal thickening noted in the both lobes of left lung associated with one lung nodule in upper lobe, likely disease reroute. And also metabolically active left pleural deposit and pleural thickening, and hypermetabolic mediastinal, supraclavicular, and retroperitoneal nodes are also seen. So this is the histopathology report, supraclavicular lymph node biopsy, which is the adenocarcinoma of primary pulmonary origin, and the molecular markers, ALK is positive, EGFR negative, PDL1 is negative, and ROS is negative. So my final diagnosis is metastatic adenocarcinoma of lung with nodal pleural deposits, ALK positive, diabetes mellitus.
Okay, so you have done the supraclavicular node biopsy, right? And sent for ISC by ALK by ISC.
Yes.
Okay. And you have started on the alectinib.
Yes.
Okay. Very good. Then.
So then response scan done after 3 months. So mild decrease in the size of primary, but in the March scan which was done, small GGOs, new onset ground glass opacities are seen. Then again the repeat scan is done in June, which showed increasing ground glass opacities, which is the lower scan, which showed increasing ground glass opacities compared to previous. And apart from that, on regular follow-up, patient had few issues. Indirect hyperbilirubinemia is increased. Bilirubin has gone up to 2.6 and indirect 2.2, and AST-LT are normal. Baseline bilirubin was 0.83. And grade 2 rash, skin rash of the legs, which has improved with antihistaminic drugs, and drug-induced lung injury. Suspected what could be the drug-induced lung injury with the new onset GGOs. And USG was done, which is normal, grade 2 fatty liver, and core antigen is negative. LDH is normal. Bronchoalveolar lavage analysis was done, which showed cytology epithelial cells, few pulmonary macrophages, and culture gene Nielsen staining, galactomannan fungal culture, and gene expert are negative.
So what is the attributable feature for GGOs in the lung?
Sorry,
what are the attributable features or causes for the GGOs in the lung?
One thing is a drug induced, the other thing could be the disease progression, the other thing could be the infective etiology.
Yeah, so if the malignant disease is progressing, they will not give the GGOs, ground glass opacity. It is because of some infection or some toxicity which is affecting the you can see the parenchymal things, interalveolar receptors. They are just broadened up and then they are looked at the GGOs. So infection you have ruled out.
Yes.
Fungal infection was not there, TB was not there, and bacterial infection was not there. So it is most common cause of this is TKI, which we have used alectinib. So you tell us what are the chances of having the patient ALK positivity in the lung cancer?
About 5% NSCLC could be possibly positive for NS ALK.
5 to 8%. Okay, and you have chosen alectinib. Any specific reason for that?
Actually, not necessary, but as per the prior trials which we have.
No, the trial came out for the ALK positivity was crizotinib. So you have left the crizotinib, chosen the alectinib. What is the specific reason for that?
I think as I said, just
in other words, what is the big difference between the crizotinib and the alectinib?
About 35.
Harsh, you please help the Venkatesh. Is there any big difference between the alectinib and the crizotinib?
Yes, sir. So 50% PFS with alectinib and 30%. Sorry, 34 months with the alectinib and 11 months PFS with the crizotinib.
No, for the simple reason, alectinib has a higher age because it controls CNS very well, and this crizotinib doesn't control much. So this is the reason why we have chosen this. And what are the basic side effects which can bother you while treating this patient with alectinib?
Common side effects are hyperbilirubinemia, metabolic features are one possibility, sir. Then even bradycardia.
Do you like to do any other imaging in the baseline evaluation apart from the PET scan, especially in case of ALK positive lung cancer? Same thing actually, the sir has
Brain imaging.
brain imaging. So right now it is in guideline for any metastatic lung cancer, you do it in baseline. At least for ALK inhibitor, I think it should be done. What are the other drugs that are there that can be given in first line? What are the indicated recommended drugs?
Alectinib, brigatinib, lorlatinib.
And what about ceritinib and crizotinib?
The crizotinib in some specific reasons, but not like first line. Sir. So, ceritinib also.
Ceritinib is also there. Crizotinib doesn't have any brain penetration, so that's why you want to.
So, what are the common side effects you were telling? The liver dysfunction,
hyperbilirubinemia, sir. That Alex also, which
and transaminitis also it was.
transaminitis, sir.
Yeah.
Hyperbilirubinemia, transaminitis.
So, what you will do for that?
So, as per the, if transaminitis is about more than 5 or bilirubinemia and bilirubin is normal, we'll hold the drug till it comes below 3 times, and then we can restart with the dosing level of one level reducer. So, usually what is recommended is 600 mg BD. So, we can start with 450 with one dose level already. But if there is both transaminitis and bilirubinemia, hyperbilirubinemia about 3 to 5 times, we have to change the drugs. That's not. Then that is one indication about transaminitis and bilirubin. Then if there is any pneumonitis of anything grade, severe grade, we have to stop the drug. The pneumonitis or ILD, interstitial lung disease.
So, suppose patient came to you after 2 months and they are complaining a very specific complaint that doctor, I have the bilateral lower limb edema and it is not going up. And in morning it is okay, but in the daytime or in the evening it is very much troubling to us, troubling to me. What should I do? So alectinib has a very special side effect, or for that matter, crizotinib also. They have a tendency to damage the venous walls. So blood will not pump up properly and patient will have the edema. And once your legs are up from the gravitational force, it will reduce. So you need to reassure the patient that it will happen, but it is of not worrisome problem. So, okay, then go ahead. What you have done with this patient?
Suspected elective lung injury with this patient started on oral steroids. Sir. Then response scan post 1 month of stopping of alectinib was done, which showed a near stable liver lesion, primary, and reduction of GGOs. The ground glass opacities have been reduced. So the final diagnosis would be metastatic adenocarcinoma of lung with node and pleural deposits, ALK positive, post-alectinib induced toxicity symptoms of hyperbilirubinemia, skin rash and lung injury, and presently recovered, and disease status under stable condition. So for the plan, we have to go for stopping the drug and go for next generation.
Hey, why you are stopping the drug?
Lung injury.
Okay, because of the
lung injury,
ILD.
not for the disease
Okay.
status, just because of the toxicities, plan to change the drug.
So which drug you will now call for?
Next is lorlatinib. Because patient is disease under stable control, so no need of emergency chemo till we procure the drug. So we can go for lorlatinib procurement and then observe till then and control the skin toxicity and all resolved, sir, as of now. And now the parameters, bilirubin latest 3 days ago, bilirubin is 0.83, sir. Latest.
Out of all the first line therapies which are in use for ALK positive, which is the one which is notorious for lung injury? You have lorlatinib, brigatinib, alectinib, ceritinib, and crizotinib. So which one is the one known? And that is why, it was almost given up, but it's still in use. And you have to be very careful when you start the patient on that drug, especially from the point of view of lung injury. Yes. And what about now? There are some patients who still have to go on crizotinib for, financial reasons. So, what sort of complaints can they come up with? One of the complaints that you have to actually educate the patient about. Do they, do they sometimes need to go to the ophthalmologist? You know that it can cause some visual side effects. Color blindness. So, you have to educate the patient on that, because even till today, there are some patients who are on the crizotinib because of various reasons.
What investigation will you do in the follow-up of lorlatinib, especially?
Lorlatinib, metabolic disorders, so triglycerides, lipid cholesterol profile is one important measure. One more next common in the ground study which we got is cognitive defects are one thing. So neurological examination is one thing we have to do, clinically important. Cognitive defects are one more dangerous side effect which could observe with lorlatinib.
And how do you manage the hypertriglyceridemia?
Either simvastatin, pravastatin, or rosuvastatin, because it doesn't have much interactions or not severe interactions with lorlatinib. So either what we have with our setting, rosuvastatin can be tried.
Okay. We have one more case.
I just want to know, what are these non-metastatic manifestations in lung cancer? Are you aware of them? Like, the patient has hypercalcemia, has cerebellar ataxia, but you don't find anything, no bone mets, no brain mets. So what are they?
Paraneoplasty.
So this was a very good interaction with you all people, and you did very well. And this was a nice session and for the EGFR ALK.
Thank you.
Thank you, examiners, and thank you, presenters. It was wonderful session. We discussed 2 cases. Thank you. Thank you.
Thank you to the students, all the examiners, and thank you, Anu, for moderating. We move on with the next session, which is on ALK. And for the first talk, I would like to invite Dr. Pratik Chandrani, scientist from the Department of Medical Oncology and TMH and the Computational Biology Center at ACTREC on the interpretation of the various ALK tests. Thank you.
Good afternoon, everyone. So today I will be talking about ALK detection using NGS and the comparison of NGS-based approach with IHC and FISH standards. So first of all, we all know ALK is a major driver oncogene, and fusion of ALK most significantly detected along with EML4 is one of the driver alteration, perhaps one of the earliest driver alteration in lung cancer, which has been very well targeted. So in this fusion, what exactly happens is there is a So there is a chromosome 2 location for EML4 going in the left side direction, and ALK is going on the right hand side direction. During the translocation event, this internal part is inverted, which results into fusion of EML4 ALK together. And because of this fusion, the outer domain of ALK is lost, and instead of that, EML4 comes into the picture, which results into cytoplasmic cytoplasmic protein of the fused protein, and this is losing all of its control, which is driven by the ligand in a biological reaction, because of which it is constitutively active and it is oncogenic in nature. Now, to detect this fusion, there have been several approaches which are the current standard practice. One is by using fluorescent in situ hybridization. Sorry, in which either fusion signal specific probes are designed for gene A and B, and if they both are coming together into a particular location, that indicates gene fusion. Or we use break apart probes, in which on a single gene we design two different colored probes, and if they are falling far apart compared to each other, then that indicates the presence of fusion. This technique requires specific designing of the probes at a particular location, and how that becomes a limitation and how that is different from NGS, that we'll discuss further in the slides. But we need to remember that these probes are specifically designed for the sequence available to us. Now, there is another technique called immunohistochemistry, IHC, wherein antibodies specific to ALK C-terminal has been designed, and equivocal presence of this unequivocal presence of this IHC positivity in the tissue is has been observed to be very strongly associated with ALK inhibitor response, and that is one of the standard technique being used as of now. So again, this is antibody specifically designed to ALK C-terminal, and it doesn't tell us what is the fusion partner, what are the variants involved in the fusion partner, and how that can help in therapeutic decision making. In NGS, what we do is we take the genomic DNA or RNA of a patient sample, and we chop them up into smaller fragments, as can be seen here in these orange lines. And the smaller fragments are sequenced by a next generation sequencing machine. And after the sequencing, we align all the data to the reference genome, which is a standard human genome sequence. After the alignment, we find out the point mutations, insertion deletions, large deletions, as well as gene fusions. So the logic to identify gene fusion particularly is to identify gene read pairs which are aligning to one gene at one part, and another part is aligning to second gene or second chromosome altogether. This kind of signal clearly indicates that in the patient sample, whether it is DNA based or RNA based, these two different distinct genomic locations are coming together, and that's the only reason why we are able to detect a single read in part mapping to either of the location. So by using this logic, we identify gene fusions using NGS dataset. Now here we are not designing any specific probe for this location or this location or any other fusion location for that matter. So this is totally unknown specimen. If you obtain, this is totally sensitive technique to pick out any gene fusion which is present in that particular location. So now considering these three different technical scenario, why we need to discuss about it, and I mean it could have been a much more simpler approach. Why exactly ALK fusion detection requires such kind of complicated technical knowledge, and why do we need to go through it? So here I'm showing you NGS data published in Journal of Pathology in 2017, which shows EML4 ALK fusion variants, as can be seen here, with each of them having a relatively shorter length of the fused protein. There are some long variants of EML4 ALK as well, in which a longer fragment of EML4 is fused with ALK, and they all again create different kind of variants. Apart from EML4, there are several other genes which are known to fuse with ALK, and they all are also found to be sensitive in their respective manner. So these are only the fusion variants shown by the pictorial diagram. If you look at the actual genomic break point in this EML4 ALK variant, you get to see that so many different locations of EML4 have been found to be fused with so many different locations of ALK. So each of the line indicates presence of one fusion event in a one particular patient sample. So even within a same fusion partner, the breaking point of EML4 and ALK has been distributed across several different exons, and this plurality, this heterogeneity creates a lot of complication in interpretation of results and therapeutic decision making. So these are the major points which limits the piece-based detection of this fusion event, because piece probes, if they are by chance falling in this any of the fusion location, then a piece will fail to detect signal. However, IHC being independent of fusion partner, it is not having the same limitations. So that's why in the clinical practice, we have observed more sensitivity by IHC. Furthermore, in these fused patients, when they are treated with ALK positive patients, when they are treated with ALK therapy, we have observed development of resistance, and majority of these resistance mechanisms have been again a secondary mutation in ALK gene itself. Apart from that, we have observed some resistance mechanisms in ALK amplification as well as activation of alternative bypass pathway, but the majority of them have been ALK mutation driven. So this is another aspect where NGS can be useful. A comprehensive NGS panel will be able to detect the exact breakpoint fusion partner of ALK, irrespective of any of the gene, as well as it will able to detect any presence of resistance mutation which can be present at the de novo stage even without the treatment, or it can be acquired mutation which happens after we start therapy. So NGS will be the only technique which will be able to pick up all of these alterations. So to summarize the findings, IHC is highly sensitive and specific. It is current clinical standard, and it is no doubt highly reliable. However, it has limitations of detecting the fusion partner and resistance mutation. PIS is very good in sensitivity and specificity, and it could be useful for confirmation of equivocal findings from any other technique, and but it will have the same limitation of not able to find the exact partner of the fusion and resistance mutation. NGS is sensitive and specific, and it will take less tissue if we compare it with the sequential and serial molecular profiling of single gene based test. Then we are on an average for lung cancer, we are wasting about 20 to 30 different sections of the FFPE tissue. If we go right away to the NGS, then we are able to do the entire assay, the whole spectrum of therapeutic alteration just by using 5 sections of the same tissue, and it is able to find out the resistance mutation in the single assay without doing any other technique. However, NGS is at present still expensive and not reachable for many of the patients. So that is something that we all need to work upon and find out more solutions to bring down the cost. And it will also have limitations with respect to expertise and availability of machine at various different locations, which I believe will be again not a problem if we are able to bring down the cost. So this is the suggested flow chart for IHC. We know for equivocal results, PIS and NGS can be useful. For PIS, if results are less than 15% positive, then again alternative approach by IHC or NGS can be useful to confirm the positivity. And if we go for NGS, when it is positive, it is positive. When it is negative, it is negative. But there is one parameter we need to pay attention to, and that is coverage. If coverage of NGS reaction is low, then a negative result wouldn't be reliable. As I showed earlier in the chart, that multiple risks aligning to a single location gives us high confidence of finding. So in a typical clinical setting, if coverage is less than 500x, then only NGS negative result should be doubtful, and we need to go for any alternative approach, or we can repeat the NGS assay itself with better coverage. So that's all about comparative techniques which can be useful for ALK fusion detection. I'll be happy to take any questions. Thank you.
Thank you for the excellent lecture, sir. I have one small doubt. So in ALK, IHC, we can use as a definitive diagnostic test and can start the treatment. But in other, like ROS, for the NTRK, IHC is used as only screening.
Yes.
This is because of the possible false positives that protein. So why in ROS and NTRK, IHC is still a screening, while in ALK, it is a definitive diagnostic test?
So that's a good question. It has two aspects to it. One is that ALK being a classical gene fusion and driver, we have several different TKI in practice already, and several different resistance mechanisms have been detected, for which we know that we need something more than IHC to pick up all of those variants, ALK fusion variants, as well as ALK resistance mutation. In NTRK and all, it is still immature field. It is upcoming, and right now several of the drugs are in practice. So I believe over the time we will also get to learn about various kind of resistance mechanisms and fusion partner heterogeneity in NTRK, which will again raise the same question that we are facing today in ALK. Second thing is that some of the fusions surprisingly have good consistency in terms of their fusion partners, and we still don't know the exact mechanism why some fusions have much more heterogeneity compared to the others. So NTRK is one of the such gene which has relatively much lesser heterogeneity as of now, but it is too early to comment on that with high confidence.
Yes, sir. So my question is regarding the clinical applicability, sir, because NTRK, definitely it's very rare, but ALK and ROS, as far as ROS and ALK is concerned, there is more than 60% homology between the TK domains, and so same molecules are also used for the targeted therapy. So if as a clinician, I will not be much interested in knowing the partner, but if IHC, because it is easily done test, can be done in the periphery, easily available kits. So while for ALK, IHC, it is acceptable to start the treatment, but we know that in ROS, which is very much similar, I cannot start treatment even if it is IHC positive. I have to send for the molecular test. Is there any molecular basis for that, or is due to the retrospective validation of IHC versus FISH in the ALK, which is not done in ROS yet? Is there any such?
So specifically about ROS, the IHC is again better antibodies needs to be developed for more sensitive and reliable detection. For ALK, we have, as I said, ALK is one of the classical oncogene, and several different resistance mechanisms and several different lines of therapies have been already identified. The same thing is still going on for other oncogenes, including ROS and NTRK. So over the time, the same question will come over there, and over the time we will come to learn that NGS is perhaps the better option if we want to capture the whole spectrum of sensitivity, whole spectrum of gene fusion partners, as well as the spectrum of resistance mechanism altogether.
Thank you, sir.
Thank you all.
Thank you, sir. For the next talk, which is on the selection of first-line therapy in ALK-positive metastatic small cell cancer, I would like to invite Dr. Naresh Somani, who is the Director Oncology and Head of Medical Oncology at HCG Cancer Center and Somani Hospital, Jaipur.
Good afternoon, everyone. My slide is visible. Is my slide clear to everyone? Can anyone confirm me? Am I audible and visible?
Yes, sir, audible and visible.
Yeah, thank you. So, good evening, everyone. And I am here to discuss a few of the points, the pros and cons, that how we select the first line treatment in the ALK positive metastatic NSCLC patient what are the pros and cons as far as the first generation or the second generation are confirmed. And the previous speaker has clearly told us about the various ways of the IHC, FIS, RT-PCR, and the newer techniques of the broad comprehensive panel like NGS, that how ELK is being done, how it is being interpreted, and what are the ways when there is the IHC positive and the further like FIS, NGS sometimes are negative. So coming to the treatment for those patients who are in the stage 3C or stage 4, where no local treatment is applicable. Be very clear that for stage 2 or 3 patient, even if the biopsy is showing EGFR and ELK positive, they are not for the TKI. They are for sort of the local treatment, which may be curative for these patients. So ELK positive patient, ELK TKI are basically for the metastatic disease, those who are not suitable for the local treatment. Now, more the choice we have, more the problems we have, that what to choose, when to choose, how to sequence them, and what should be the preferred choice. Now, we have the first, second, and the third generation drugs available. Crizotinib, alectinib, and ceritinib are the drugs. The ceritinib and alectinib are the second generation. The first drug came the crizotinib, and now we have the third generation drugs also available with us, that is the lorlatinib. So obviously we are puzzled. Now we will see that with the availability of the crizotinib parallel to the EGFR TKI, this also changed the landscape of the treatment of the ELK positive patient, and then the newer drugs came which were improving the PFS, overall survival, response rate, as well as the intracranial response rate, which is a big concern in the driver mutation positive patient. And then we have the third generation drug also. And the present ongoing trials in the ELK positive scenario are how to see the outcomes of the TKI plus immuno-oncology drug upfront in combination. Now, how we decide in the first line, whether it's based on the classical clinical trial outcome based on the progression-free survival or the overall survival, or we choose the CNS efficacy as the main parameter, what is the toxicity profile for the given patient, long-term efficacy data if they are available, especially for the older drug, second line strategy, mechanism of the resistance to make the sequential treatment, and then obviously the availability or the logistic. And these all points sometimes become difficult, irrelevant when the cost becomes a big concern for our patient. So if we rate the various drugs on these various parameters, how we scale them, the individual drug, where the crizotinib lies, where the alectinib or ceritinib lies, where the lorlatinib lies, so that we need to judge for our individual patient. Looking at the various landmark registration trials available with us for the first and second generation drugs, that is the Profile 1014 for the crizotinib, Ascent-4 for the ceritinib versus chemotherapy, ALEX, JLX, Alecia trials for the alectinib versus crizotinib, and the brigatinib, the drug which is not available with us in India. If we look at here, the TKI drug, the crizotinib, gives the classical PFS outcome of something like 10 to 11 months. The second generation drugs like the ceritinib further improved it to the tune of the 16 months, and alectinib gave the very impressive results of to the tune of 34 months. Now, then we had the newer molecule lorlatinib, which is a third generation drug. It was studied in the CROWN study design, and the criteria of the study remains the same: ELK positive, advanced cancer, no prior systemic treatment, good general condition, asymptomatic treated or untreated CNS metastasis in this particular trial were taken, and the target lesion should be there, and it was compared with the crizotinib. Now, if we look at the PFS by the independent review, we see that the graph starts separating quite early. There is a wide gap between the two drugs curves. So it looks that the lorlatinib is quite better compared to the first generation drug. Now, comparing these various available drugs in the first line, this is a cross trial comparison, not to be taken as the directly, because these second and third generation drugs are not being compared with each other. So if you look at especially the results of the LX trial, alectinib versus the lorlatinib, we see that roughly the response rate, the PFS remains quite impressive and quite similar to each other. So again, the question comes how to choose which one, my drug is better or your drug is better, company A drug is better or company B drug is better. So various pros and cons. If you look at the crizotinib, most commonly available, the first mover advantage it has, the cost effectiveness is there, good clinical experience, everyone has it, the PFS is the 10 to 12 months, and the toxicity profile is again manageable. But yes, PFS is only 10 to 12 months. It doesn't cross much blood-brain barrier. So the CNS relapse is a quite common problem. And after 10 to 11 months of the crizotinib, we may achieve by the sequential second generation drugs application another 6 to 8 months, maybe a few more months of the chemotherapy plus minus chemotherapy, giving a real world experience of something like 30 to 32 months. And hepatotoxicity is always a concern. Now, if we look at the meta-analysis which is being done, the sequential treatment which we may apply after the crizotinib, it has shown that yes, this sequence is doable. We can achieve not exactly the same result, but yes, quite impressive results can be achieved out of the crizotinib also. Now, coming to the ceritinib, the classical dose is the 750 milligram, but yes, in a different way, it can be given 450 milligram also, cutting down the cost and probably the toxicity also without losing much its benefit. So the pros are that it gives the PFS of 16 months. It has a reasonable blood-brain barrier activity. And in our scenario, and especially when the generics are also available, it looks that it's a quite cheaper. Now the cons are there are no head-to-head comparison, and toxicity profile sometimes is difficult, especially the dyslipidemia, hyperglycemia, and what after ceritinib, how to choose. And if we give the third generation drug like lorlatinib, we achieve probably another 6 months, and then chemo. All patients in a sequential approach may not be suitable for the doublet chemotherapy, and that percentage goes to the tune of the 50%. Now coming to the alectinib, the pros are that it's an impressive PFS outcome, impressive overall survival outcome. It has a favorable toxicity profile relatively, and it has the impressive crossover through the blood-brain barrier. The various studies are there like the LX, JLX, Elysia trials, but there are some differences in the outcome as well as the toxicity, and the ideal dose still we don't know about this drug. Lot of the pills burden is there, and maybe that very soon the CROWN trial-based data of the lorlatinib will cross over the alectinib also. So definitely it is superior to crizotinib. In the first line treatment, the data available shows that 34 months versus just 11 months of the crizotinib. LX overall survival data are again improving, and it is quite impressive, and definitely it has improved the outcome of the patient in the first line. So the pros and cons of the lorlatinib is there, single pill is there, impressive hazard ratio for the PFS as well as for the overall survival. It has the good blood-brain barrier activity, and the latest data which has been presenting is something like mouth-watering, but yes, it has its own toxicity profile, unique toxicity. And another question is what after lorlatinib, if you have given the third generation drug in the first line, the mechanism of resistance remains a big concern. It remains resistant to almost all available drugs after lorlatinib, and final overall survival data are still to be seen. But yes, as far as the various parameters of the clinical trials are concerned, like PFS, overall survival, response rate, duration of the response, brain activity, with or without brain mets, are quite impressive as far as the lorlatinib is concerned. And at 36 months, we see the graph widening, how wide they remain. And if you look at the graph of the lorlatinib, it looks that it is something like the plateau. It is something like what we achieve the tail of the immuno-oncology drug. Like 20-30% of the patient, they remain in the plateau for a long time. So Same sort of the graph or the curve can be achieved with the lorlatinib. So do you agree that yes, lorlatinib is the final answer for the for the first line ALK positive patient? Do you agree? That's again the matter of the discussion. If you look at the various subgroup analysis of the lorlatinib, again, almost all parameters wise subgroup analysis, it is being favored by the lorlatinib compared to the crizotinib. Again, the cross-trial comparison of the tabulation as far as the PFS outcome is concerned, alectinib and lorlatinib scores over the other as well as the brigatinib. But I'm not discussing the brigatinib because it's not available in India and they look quite each other. But yes, people have tried to study across the cross-trial comparison, meta-work analysis and so on. And they are trying to predict and project that which drug is going to have the better outcome, alectinib or lorlatinib in the first line, and it looks that probably the lorlatinib will be giving the better result in the first line compared to the alectinib. So that's again the summary of the overall and the intracranial response, which is very, very important as far as the ALK or the EGFR positive patients are concerned. And alectinib again has given, as well as the lorlatinib has given the very, very impressive results compared to the first generation drugs. So if you look at the patient with baseline brain mets or without baseline brain mets, obviously there is a difference, but compared to the crizotinib, lorlatinib surpasses in almost all the parameters as far as the brain mets are also concerned. So the verdict is very clear. The one who wins the CNS activity probably will win the game. So is it so? If you look at the hazard ratio of the alectinib versus lorlatinib, it looks that probably the lorlatinib will be a better drug as far as the CNS parameters are concerned. And the comparison of the various ways, cross-trial comparison people have done based on the network meta-analysis, and they try to conclude that in terms of the PFS, the results indicate that the lorlatinib probably is the better drug for patients with the ALK inhibitor treatment naive or untreated patients advanced lung cancer. So what ISMO says, various ways to study the drug, to choose the drug, which are based on the disease characteristics, patient's characteristics, as well as the comorbidities and the various parameters. Based on these parameters, for the individual patient, you have to choose the drug. So for every patient, every drug may not be the first line treatment. Our NCCN guidelines also say that if you detect the ALK before starting the treatment, the TKI remains the preferred choice, and alectinib, brigatinib, and lorlatinib are the category 1 evidence. Maybe ceritinib in certain recommended situations, and if yes, you cannot give it logically, then crizotinib is the choice. If the ALK is being detected later on, the patient has been given the chemotherapy, the options of the both choosing the TKI, switching to the TKI, versus completing the planned treatment in a responding patient followed by TKI remains the valid option. But most of the time we switch the patient to the ALK because of the impressive results, because of the less toxicity and the tablet treatment. So the various adverse events are also important for the individual patient to select the choice in a given situation. And the toxicities of these are the different, which are not class effect of the drugs. Now, another important point is we need to remember, which will be discussed in the further lectures after my talk, that with the more and more exposure, sequential exposure of the TKI drugs in the ALK situation, that diminishing PFS is there with the every subsequent treatment. So all patients do not have the equal results. And the big concern is after the first line lorlatinib, so what is the resistance mechanism? What we can offer to our patients, and are they really being benefited by second line or subsequent line of the treatment? And if you look at the resistance mechanism, which will be discussed subsequently by next speaker, the most important mutation mechanism is the G1202R or L1196N mutation. And we all know today that G1202R is probably the resistant to each and every molecule except the lorlatinib. So that becomes a big concern, though mechanism of resistance to the TKI drugs in the ALK situation are not equivalent to the TKI situation in the EGFR, where the T790M is the major concern and which is positive in more than 50% of the patients and which can be effectively covered by the osimertinib. The situation here doesn't remain the same. There are the plethora of the mutations which are basically the kinase domain mutation, especially when we use the second generation or the third generation drugs, is a big concern, and effective treatments remains always a challenge. So if we look at the scenario, there are the two ways to think of sequential treatment in the first line with the help of the first generation drugs versus second or third generation drugs in the first line. So as per the guidelines, as per the available various scientific literature, the alectinib or lorlatinib are potentially the preferred choice in Indian context, and followed by we talk about the lorlatinib if it is not given in the first line, or if it is the lorlatinib is being given, then the options are doublet chemotherapy if the patient is suitable, or the chemo plus IO plus bevacizumab. Be very clear, it has to be ABCP protocol. The chemo plus IO doesn't work, and the sensitivity of the ALK positive patients to the immunotherapy is even lesser compared to the EGFR positive patient. So I would like to summarize that there are now multiple treatment options in the first line, but yes, second generation drug like alectinib or lorlatinib are the preferred choice, and next generation LTKI are the standard of care in this particular situation. So whenever I make the slide, this is the message I get from my wife, but her actual meaning is keep it short, stupid. And I think I could justify it. Thank you. Any question?
Thank you so much, sir. Now, I would like to invite Dr. Nandini Menon. She is an assistant professor, medical oncologist, Tata Memorial Hospital, Mumbai. Ma'am, please.
Okay, I'll start. Thank you. So today, this next talk is going to be on mechanism of resistance to ALK inhibitors. So the previous two talks already covered mechanism, methods of testing, and okay, so we go back to mechanism of resistance to ALK inhibitors. So the previous talks are discussed on the various drugs which are used in the first line setting for treating ALK mutation positive non-small cell lung cancer. And sir had also discussed about the resistant mutations. And I'll be discussing in the next 15 minutes a bit about the resistance to ALK inhibitors in lung cancer. So we know, like sir had discussed in the previous talk, that the limitation of first line or ALK TKIs, including the next generation ALK TKIs, is the development of resistance, which again leads to limits the benefit with the TKI. So there can be two types of resistance. One is primary resistance, which is the less common resistance we encounter in clinical practice. It's actually very rare, where the patient does not get any kind of response within the first 3 months of using a TKI, and it's defined as primary resistance. So there is an intrinsic lack of response to the TKI. And the more common of what we encounter in our clinical practice is usually the acquired secondary resistance. And this is not just for the ALK mutations, it's commonly seen in the most of the driver mutations, including EGFR. So what are the types of ALK resistance? One we saw was the primary and secondary, depending on the initiation of treatment or not. That is, those who receive TKI and do not benefit within 3 months are primary, and secondary are those who progress after some benefit to a TKI. There are other way of looking at the resistance mechanism is on the molecular pathway that they basically have the resistance in. So one are the on target or the ALK dependent mutations, which like the other driver mutations, for example, EGFR, where there are mutations in the tyrosine kinase domain of the ALK protein, fusion protein, and these lead to resistance. And the other types of mutations are the ALK independent mutations, where the ALK protein is not involved and it's not a target mutation. They develop in other pathways. There may be alternative driver mutation pathways that get activated. There might be downstream pathways beyond ALK, which might get activated and again lead to resistance. Some transformations like the epithelial to mesenchymal transition and transformation to small cell lung cancer. So this diagram shows the same. So you can look at the protein, that is the ALK protein seen in blue and green, and then the on target mutations in this protein on due to change of point mutations or other structural changes. And then the alternative pathways, that these are the bypass pathways, get activated. These are the independent mutations, ALK independent mutations, and the downstream pathways that can get activated and lead to mutation. So going to ALK dependent resistance or the on target resistance. So the main question is, does our prior treatment impact the resistance that we develop? Like we know that patients who are treated with first generation EGFR TKIs typically develop the T790M mutation in 60% of the patients. So does the scenario replicate in ALK positive lung cancer? So it is slightly similar, where resistance mutations after first generation ALK TKIs like crizotinib, they have a particular pattern, and resistance mutations after the newer generation of TKIs are slightly different. So the most common mutation is the gatekeeper mutation, that is L1196M, which is seen in patients who have received prior crizotinib. Basically, it is a mutation in the part of the tyrosine kinase domain of the protein where the ATP binding pocket. Similarly, the next most common mutation which is seen in patients who have progressed on crizotinib is the G1269A mutation. And the other mutations which are seen at these various residues at these positions are seen after progression on crizotinib. Now, this mutation, that is a G1202R, will be discussed a lot. The importance of this mutation is it not only confers resistance to the first generation TKIs, but all the other second generation TKIs are resistant and only sensitive to lorlatinib. So these are the common mutations in the tyrosine kinase domain in patients who have received prior crizotinib. There are some other pathways. One is amplification of the ALK fusion gene. So this is a rarer type of resistant mechanism, but it can be seen in patients who have received prior crizotinib. And again, alternative pathway activation. So approximately 1/3 of patients who have received crizotinib get ALK resistant mutations in the tyrosine kinase domain. And these are the alternative oncogenes, that is the alternative pathways, which is approximately another third. And about 18% get these ALK copy number gains because of the amplification of the gene. So what is the difference again in the pattern of mutations within the first and second generation TKI? So this is from one of the early papers published in 2016, where they had done a comprehensive genomic profiling of patients who progressed after all the various TKIs, crizotinib, ceritinib, alectinib, lorlatinib, and they looked at the type of mutations that were seen. So if you look at the pie charts, they show the proportion of various mutations in different settings. So these are patients who were resistant to crizotinib, these were to ceritinib, and these were to alectinib. And if you look at the pattern, this is all the ALK wild type. This dark blue is ALK amplification, which is one of the pathways for the resistance to crizotinib. And here is the most common mutation that you see with crizotinib resistance, that is the L1196 in the gatekeeper site. But if you look at the higher generation of TKIs, you can see that again, ALK gene amplification is not a common mechanism of resistance. If you look at this part of the pie here, which is maximum in alectinib, that is the G1202R. So looking at this pie chart, we know that the profile of resistance also varies. So the G1202R is seen more frequently in patients who receive ceritinib, brigatinib, or alectinib, that is the second generation ALK TKIs, rather than the first generation crizotinib. So this is the paper which again did the initial comprehensive analysis of all the mutations in biopsy specimens after progression. And like the similar pie chart I showed you, this bar graph also shows that patients who have received a second generation ALK TKI have a much higher frequency of getting this G1202R, and that has a significant impact on our treatment decision, because we know that these patients are not going to respond to the other second generation TKIs, and we need to use lorlatinib. Also, this shows all the various mutations and the frequencies. So this is crizotinib, ceritinib, alectinib, and brigatinib. We can see the most common mutation in the first generation is L1196M, but that is not the case in the second generation drugs, where G1202R is common. It's up from 21% to 43% with brigatinib, as we noted. And again, ALK mutations in general, that is having a mutation in the ALK protein, are in general higher in patients who have received second generation TKIs in the first line than just receiving crizotinib. So this study showed that these ALK resistant mutations were there in 56% of patients overall, and only in 20% of those who had received crizotinib. The spectrum was different, and like I mentioned, G1202R was the main mutation that was seen. And the reason they propose for this mutation being common in second generation ALK inhibitors is because of the binding site. The second generation ALK inhibitors are more effective, and they have it because of the structure of the compound, which binds to the solvent front region on the protein, where this G1202 site is located. And this increases the activity, and that's why these drugs are more effective. But because of this potential of this drug binding, this also induces resistance mutations in this region and makes it difficult to target. So this again is from the same paper where they did genetic alterations and the various ALK mutations and other non-ALK pathways which were analyzed in patients receiving these drugs. So this shows the efficacy of all the 5 ALK inhibitors in various ALK mutations. The ones, basically it shows the IC50. So if you have a green block, means your IC50 is less than 50 nanomoles per liter, which means your drug is very efficacious. The red indicates resistance. And like you can see, G1202R is resistant to crizotinib, alectinib, and even has a very high IC50 for the other 2 drugs, that is ceritinib and brigatinib. And only lorlatinib has an IC50 of less than 50 nanomoles. So let's come to double and complex mutations, that is having more than one ALK tyrosine kinase domain mutation in a patient. And this is also seen in EGFR. So what does it indicate, or what does it mean if you have a complex mutation in ALK? So these are some reports where they have reported complex mutations, that is at 2 different sites on the protein. And this usually, if you look at the drugs used, this comes after sequential treatment, after sequencing one ALK TKI after another. And they have tried other TKIs, including crizotinib in this particular ALK mutation, which basically resensitized it to the action of crizotinib. So one thing to remember is that usually these complex mutations might be resistant to the early generation TKIs, but not all complex mutations increase the resistance. So some of them will resensitize. So this was the mutation which is shown in the table as an example. And this was published by Alice Shaw as a case report in NEJM way back in 2016, where they reported a patient who had developed a resistant mutation to crizotinib, that was C1156Y in the tyrosine kinase domain. And it was resistant to ALK. And subsequently, when they developed a second mutation, which made it resistant to lorlatinib, that is L1198F, this mutation basically made it sensitive to crizotinib again, and the patient was shifted back to crizotinib. So this is another paper which has shown the clonal evolution actually of the various mutations over a long period of time, from 0 to 60 months in a patient who received different drugs, erlotinib, chemo, then ALK was identified, crizotinib and brigatinib, and how the ALK mutations progressed over time. They had done a genomic profiling. So the rare mechanism of ALK resistance is epithelial to mesenchymal transition. And I will discuss this slide later. So basically, it is a change in the epithelial cell property. They lose certain molecules like E-cadherin on the surface, and they lose the polarity, and they become more invasive, and they circulate throughout the body, and they migrate and invade. And there are some signaling pathways which are affected in this, and it contributes to resistance. Sometimes you might get the common gatekeeper mutation along with the epithelial to mesenchymal transformation. And how did they identify this? So what did they look at? Pre-crizotinib, H&E staining, and they did a E-cadherin staining, and you can see it is lost here. And some of the mesenchymal IHC markers appear. So this is vimentin, which is a mesenchymal marker, and it was seen after this transformation. Then what about resistance to next generation ALK inhibitors? So these are some papers which have been published, resistance to lorlatinib. So basically they have seen that a lot of patients obviously who receive lorlatinib do not receive it in the past, did not receive it in the first line setting, and they were received it sequentially. So a lot of mutation resistance was because of complex mutations or multiple mutations, and the detection of more than 2 ALK mutations was significantly higher in patients who relapsed on lorlatinib. So lorlatinib is active against G1202R because that, and it is a primary resistant mutation to the other ALK TKIs. So only lorlatinib is active against this. And also, like I mentioned earlier, that if you do a whole exome sequencing in patients who have received lorlatinib, you can see a stepwise accumulation of the various ALK mutations over various sequential treatments. So how do we detect these ALK mutations? You need to do a comprehensive genomic profiling. Usually ALK mutations are detected using NGS. You can rebiopsy, or including, there have been studies with liquid biopsy. I will not go into detail with it because the methods have already been discussed. But then a question comes is, what happens if we encounter resistance mutations? How do we treat the patient? So this is what we commonly encounter in our clinics, where the newer generation TKIs are cannot be afforded by a lot of patients. And once you relapse on crizotinib, you usually move on to a second generation ALK inhibitor. And if you progress on that, and then we usually prefer, if the patient is fit, to do a biopsy, if possible. If there is a resistance mutation, you would offer a third generation ALK TKI depending on the mutation. If there's no resistant mutation, it depends on if any alternative pathway is there, and that can be targeted. If there are no targets, then we have to resort to chemotherapy. So these drugs can be used after the progression of on crizotinib. Now all of these drugs are used in the first line, including lorlatinib has data for use in the first line setting. So in the future, there could be more resistance mechanisms, and the resistance mechanisms post lorlatinib might be complex and might be challenging to manage in the future. So generally, if you have used any of these new drugs, that is the second or third generation TKIs in the first line setting, you would prefer to do a biopsy to identify if there are any ALK resistant mutations, and you can appropriately target them. And with that, if you have a TKI, you see the IC50 and you treat. If you don't have an on-target mutation, you have an off-target bypass pathway, you treat accordingly. And if there are other mechanisms for which there are no actionable or new targetable drugs available, then you go to chemotherapy. So this is just a figure which shows, and just shown in the previous talk, the various ways you can sequence the drugs available and get maximum benefit. So with this, I'll end my talk, and thank you for patient listening. If there are no questions, I think we'll move to the next talk. I would like to invite Dr. Bharat Bhosle to give his talk on treatment in ALK positive lung cancers beyond the second and third generation TKIs.
Thank you, Nandini. Thank you, Vijay and Dr. Vanita Kumar for inviting me and for this wonderful talk, which has already been covered in first two talks. Most of the things which I need to talk, which is second line and third line TKI resistance. Now, what are the options? I think the most important option is what we have been practicing since years is chemotherapy, what we left. But what is important in ALK, there are two things. One thing is the brain metastasis, and second thing is the lot of resistance which is happening after exposure to first generation, second generation. Now we have the best agent, which is lorlatinib, which takes care of the brain but causes side effect, which is most importantly happens in the brain. So in what I decided to do, rather than talking on those agents which are still in the labs to talk about their efficacy and dose, I wanted to show you one of my case where this patient had been exposed to first generation, second generation, and developed resistance. So I will not go into the detail of discovery. When I was resident, then the discovery of ALK happened. When I was completing my DM, then the crizotinib, we were discussing the first data profile, and we were very amazed to look at the data and now see After more than a decade, I'm standing here and discussing so many options. The truth fact is, most of our patients, we should be talking what our patients can afford. Most of our patients don't have access to all these drugs except those compassionate access. So then the best decision a person can take when he or she is seeing the patients in the clinic is their best clinical judgment. So I will start with the clinical history. This 44-year young, fit, non-smoker guy, came to my clinic before the starts of COVID. It was February. I distinctly remember he was diagnosed in some of other hospital, came with the biopsy. I just wrote. That time we did not have too much of access to local labs of NGS. So we did the routine panel and the ALK came positive. In Mumbai happens, one person goes to 3 more people. And then he jumped to another oncologist, started, and I also forgot, he also forgot, and then COVID started. So everyone forgot. So there was a lung mass with some effusion. Biopsy was ALK positive, started on crizotinib. In June 2020, so this is a retrospective thing, when he again came back to me. In June 2020, after starting the crizotinib, there was a partial response. But November, he started coughing, so there was a PET happening every 3 monthly, and there was a slight progressive disease. So the treating oncologist shifted him from crizotinib to alectinib because that was the best option probably. And that was we used to do. Crizotinib, I had done it, couple of patients, crizotinib, then triceritinib. This is 2014-15 I'm talking. And then I went to alectinib and I had actually exposed one of my patients to lorlatinib, wonderful drug. CNS nets disappears completely. The only problem is the patient becomes cognitive decline. So they will not remember who is treating them like that. So, but the longest PFS I have actually seen, which is translated into overall survival, is sequencing. So this particular patient initially responded 3 months for alectinib, nice response. And remember that crizotinib response was 6 months to 9 months. So somewhere around February, there was a partial response, which was 3 months after alectinib. And then again, patient started developing cough. Then he remembered me, he came back to me again. So I decided, though you have a response, looks clinically progressing, we should get a biopsy. I'm very big fan of doing repeated biopsy. That's why patients, sometimes I spend a lot of time in counseling. And from the first 2 talk, you remember, you must come to the conclusion that this is what is required when you are treating a patient on ALK inhibitors. So then his cough become deteriorating, and then we decided, let's do a biopsy. So before that, one thing that alectinib dose was the half of the dose. Maybe, my colleague must have thought something and he was giving the half of the dose. So I actually increased the dose and he responded. So 3 more months with a full dose of alectinib. And then again, he started developing cough. So I said, let's get a biopsy done. I'll discuss this biopsy and everything afterwards once we finished this. So this is the background we now have since 2007 when I mentioned that I was registered, and now it is 2022. We have lot many agents, and lorlatinib looks the best agent. This flowchart, this diagram was shown before. You look at the 3 years of progression-free survival, it is 64% with lorlatinib and 19% with crizotinib. And there are a good effective second generations TKI like alectinib, brigatinib, and entrectinib. They are also showing good PFS as compared to everything is compared to crizotinib because it has the least CNS activity. And this is the PFS graph of lorlatinib. So if somebody has lorlatinib available with free of cost, one should put the patient on lorlatinib. Only problem is CNS side effects. And there are a couple of other side effects. You have to look after what drug the patient is on. Although patients with ALK positive NSCLC, all the patients do respond. I haven't seen the patient, any of ALK positive patient has not responded initially, but they do develop resistance. That is one thing, which is up to the tune of 71%. This particular mutation G120R, which is does not happen with crizotinib, but second generation TKI. If the patient is exposed to the second generation TKI, this is the most common mutation, and most of the second generation TKI shows resistance to this particular mutation. This mutation is resistant, quite resistant for second generation TKI also. Now the second problem, as I mentioned, is the brain metastasis. To begin with, almost 30 to 40% of the patients ALK positive are going to have brain metastasis if you screen the brain. I do MRI for all the patients. If I don't get a mutation on basic tests like PCR and IHC, I do the brain metastasis, brain MRI. Now I do it for everyone. But if you have brain metastasis and if your mutation is negative, please do NGS if it is not done. You will pick up some mutation. And that is all. And this is when you expose this patient to second generation or third generation, your second generation TKI, your probability of developing the brain metastasis is going up to the tune of 60%. So you need to have a ideal agent which has a best CNS activity and effective against all the possible mutations. So I will not go into the details of resistant mechanism because first two speakers have so these all graphs have been discussed. So this is again, no, you see post crizotinib, you don't have a lot many mutations, but when you expose your patient to second generation, be it alectinib, brigatinib, and ceritinib and alectinib are more accessible as compared to the other two. And G1202R is the most important culprit. This graph was shown by Dr. Somani also. If you subject your patient to first generation, second generation, third generation, the accumulation of mutation also increases. As we see, the most common again here is G1202R. So now we need to have one agent which has activity across all these mutations, including the most common mutation with the best penetration in the brain. This is the most common mutation chart always you see. From this chart, we conclude that lorlatinib is the best agent which is effective against whatever best possible known mutations are discovered so far. So we'll come to those mutations post lorlatinib. So this G1202R is inhibited. This mutation is sensitive to lorlatinib also. Now I'll not go into the detail of this design and mechanism of the trial. So as Dr. Nandini has showed and Dr. Somani also showed, where this drug binds to the receptor site, that decides, the mutations happening over there decides the fate of that particular drug. So this is the phase 1 trial where multiple cohorts have been concluded and lorlatinib has been placed in the first line post crizotinib chemotherapy, then lorlatinib, then second generation TKI followed by chemotherapy followed by lorlatinib, and first line, second generation TKI, then chemotherapy and then lorlatinib. So they try to look where the lorlatinib fits well. So you see lorlatinib in this phase 2 study, out of 190 plasma samples. So this is pre-treated patients. 24% had more than one detectable ALK kinase domain mutation. Total of 75 mutations were detected, and the most common is, I will not name it again. Now you must have know by heart, G1202R. For those students for the exam, just remember this. I just don't look at this. I just read the report and decide what mutation and what drug to use. So those patients who did not have any mutation, still the lorlatinib works. So you see most of the mutation lorlatinib is working beyond second line. Now this graph, few years back, we used to discuss about alectinib and ceritinib. Now there is one more lorlatinib. I am not going to explain it because the last line you see, if you use lorlatinib upfront, the best PFS you get, the longest PFS is not reached yet. And I showed 3 years PFS is 64%. So the best is to use the best drug upfront. Only thing is the cost is the issue. But what I feel sequencing is the right way. I would like to mention one of my patients which got detected with upfront brain metastasis in 2014. The only option available and accessible was crizotinib. With brain metastasis, excellent response. Maybe the radiation guys has given radiation and the already broken the brain barrier. She took crizotinib almost for 3.5 years or 4 years. What I did with limited progression, that time I added chemotherapy also, but I continued the TKI. Patient again responded after 2 years, so 2 + 2 4 years. So one must remember this option also. Then in the second line, the ceritinib came. That time we used ceritinib. For some period we used alectinib, and lorlatinib was not available in India. So we got a compassionate access access, and she took almost for 2.5 years. The brain was completely clear of metastasis. There were miliary metastasis, but the only problem was cognitive decline and the quality of life went down because of the CNS side effects. Maybe it is because of the radiation plus this drug. But she, with the upfront brain metastasis, she survived for 7.5 years, and we lost her in the second wave of the COVID. So it's a long journey. So with upfront brain metastasis, people are living beyond 5 years and 6 years. So it is how you put these drugs. So now, as I mentioned in my case, there is a small cohort. They tried about 67 patients. Those patients progressed beyond second line TKI, and they tried adding chemotherapy. So if you only do chemotherapy versus you continue the TKI and add the chemotherapy, you see those graphs are different. So it is suggested, though it is a very small data, you better know if you have limited progression, continue the TKI with chemotherapy. You are not going to have large randomized trials. So there will be some case reports, and this is what happens beyond lorlatinib. There is not much of data is coming. All things are case-based reports or lab-based analysis. So is lorlatinib is free from acquired resistance? So we have discussed a lot about second generation and first generation. So answer is no. Dr. Nandini mentioned about single mutations and compound mutations. So there is something called as a compound mutation. I will not go into these figures. You can go and read. I will provide the slides. These mutations, when happens, they lead to resistance to lorlatinib, but they resensitize to crizotinib and alectinib. So one must remember the repeat biopsy for those patients who are in good general condition. And nowadays we have there is a validated data that even the circulating free tumor DNA is also giving you a good number of mutations. One must try and counsel the patients to get these repeat biopsies done, get those mutations, because who knows, even crizotinib works in those patients, alectinib works in patients, those patients who are resistant to lorlatinib. So there's again one more mutation, I1171N plus 1198F mutants are more sensitive to crizotinib. So first generation TKI. And the resistance to 1171 and 1196 can be overcome by ceritinib and brigatinib. So this shows that you need to do a biopsy and see what mutations are ongoing. So this is last line. No, there is one more mutation which is pan-TKI resistant. So whatever mutations and whatever drugs available, it is not sensitive to that. So the ultimate answer is chemotherapy, or if there is a limited progression, use radiation. Now I call my friend, whether you are doing some research on your molecules, Vijay Patil. So he said there is one more drug is coming up. So this name is giltertinib. Okay, no fancy name. So you see that green graph. So this is about the compound mutations. So they have tried looking at this particular compound mutation, that EML4-ALK 1171N and 1174I, and the other one is 1198LH. So these are compound mutations which are not inhibited by any of the previous TKIs, and this giltertinib is showing reducing the number of relative cell viability. So this is again the lab-based assay. The only drug which is working over here is this new drug, giltertinib. So now this drug is not active against our famous mutation, which is G1202R. So if you detect G1202R, the effective drug is your lorlatinib. So there is one case they reported where the patient has been subjected to crizotinib, alectinib, and lorlatinib, the biopsy done, and this mutation was detected. And this drug was sensitive to brigatinib, ceritinib, and this new molecule, which is yet to be made available. So this already I have spoken that this drug is not effective against G1202R. And so this is my patients whom I did requested him to undergo the biopsy because patient was very young. And in this particular patient, the mutation detected was T1171M and G1269A. So this particular mutation got detected, and you see the sensitivity. So this patient was not sensitive to lorlatinib. This patient was subjected to crizotinib, 6 months progression. Patient given alectinib, which was the best available TKI at that particular time point, was resistant to alectinib. And this patient is also resistant to lorlatinib. So crizo, alectinib, and lorlatinib. And this patient, as per this report, was sensitive to brigatinib and ceritinib and entrectinib. So this is the NCCN guideline with limited CNS metastasis. You should give radiation and you should continue the TKI. And I feel the best answer to this thing is to do a biopsy and look at the mutations. So treating ALK positive lung cancer is challenging task even after we have many options. CNS relapse mutations causing resistance to available TKI is the reason. Best agent first versus sequencing. It is up to the accessibility and feasibility. Lorlatinib seems best option up front, but the side effect profile. So treating lorlatinib resistance is at present is unmet need. Few TKI are coming up. Repeat biopsy should always be tried wherever feasible. Liquid biopsy and chemotherapy is always an option for those fit patients. Don't forget that you have this chemotherapy also can breach in between the two different TKI. If who knows, next best TKI post lorlatinib will be 100% effective. Thank you.
Thank you, sir. So this brings us to the end of the session on ALK, and our next session is going to be on MET. The first talk is going to be on the testing for CMET, that is interpretation of CMET amplification exon 14 skipping in non-small cell lung cancer. So I would like to invite Dr. Vidya Veldore. She is the clinical director of 4Base Care Onco Solutions Private Limited, and she will give the next talk on testing of MET.
Good evening, everyone. At the outset, I would like to thank the organizers, Dr. Kumar Prabhash sir and Dr. Anuradha madam for giving us this opportunity here. And without much delay, we all know MET is a kinase and it's a proto-oncogene. And when it gets mutated in cancer, it becomes an oncogene. And what type of alterations are known in cancer for MET? MET primarily has 3 different types of genomic alterations: exon 14 skipping mutations, amplifications, and fusions. In all the 3 types of DNA level alterations, MET overexpression has been a common phenomena. However, MET overexpression by IHC unfortunately does not seem to be a very strong biomarker. Even NCCN guidelines have said that we are not in a position to consider IHC as a robust methodology to look for MET gene expression. So what we know about skipping mutations in MET exon 14 constitutes about 5%, and these are oncogenic driver mutations. And then amplifications de novo is about 1 to 5%. And when it comes in the context of EGFR TKI resistance, these MET amplifications constitute somewhere between 5 to 22%. And in most of the EGFR TKI resistant, MET overexpression is seen, but not always a MET overexpression is underlying by an amplification. The take-home message is that even though a strong MET IHC is observed, that does not necessarily indicate that there is a copy number amplification in MET gene. So this is a very important take-home message for all of us. So basically, what is MET? MET is a kinase, as I said. If you look at it carefully, this exon 14, when it gets deleted, essentially skipping leads to deletion. It leads to constitutive activation of the kinase, and that is how it becomes oncogenic. And so moving on, since today's topic for me was primarily to discuss on exon 14 skipping mutations and MET amplifications, how do we do it and what technology is approved and what are the other technologies available and how we can kind of use as a alternative when one technology is not available. So before moving into exon 14 skipping, I wanted to quickly finish on amplification because it is pretty straightforward. And as we all know, it is a mechanism of resistance, as I said. FISH remains the gold standard like HER2 amplification, where people have looked at it in detail and they have said that a copy number less than 2.2 is considered to be low, greater than 1.8. Intermediate is 2.2 to 5 and greater than 5 is considered amplified. However, from the recent literature, what we understand based on clinical outcome and prognostication of these non-small cell lung cancer patients, a MET amplification, if you could read here below, yes, I can see this now. A high-level MET amplification, this is the jargon or the technical word that's being used. High-level MET amplification essentially means a copy number greater than 10 as given by NCCN, is where you would significantly see some kind of a response to a MET TKI. Otherwise, this MET amplification is essentially not translating to oncogenic driver as a significant driver there. So this is one of the important take-home messages, and we know tepotinib is being well studied in the context of MET amplification in non-small cell lung cancer. So moving to exon 14 skipping. So as I mentioned earlier, what is essentially happening is when the MET gene loses this particular green color region, it becomes short. When it becomes short, it does not get degraded. So every cell, the protein gets degraded, right? The life of this MET protein increases. And not only that, it also takes another advantage of survival by becoming oncogenic. So this is the one of the fundamental molecular events that happens in non-small cell lung cancer patients in a small subset of 1 to 5%, wherein you see this kind of an oncogenic transformation from a normal protein or a normal gene. And this is what leads to the activation, proliferation, and subsequently malignancy. So therefore, now we understand the biology. How can we address the targets? So the kinase domain, since this phosphorylation remains constitutively on, it can be targeted with drugs. And that is where it becomes a potential therapeutic therapy drug. And who is often known to be associated? Patients over the age of 70 with smoking history, and some histological correlation in terms of pleomorphic carcinoma or adenosquamous are often candidates who could carry MET exon 14 skipping mutations. So this is the story or the evolution of MET exon 14 skipping, or for that matter, any MET alterations. It all started with the discovery in 1994, and then slowly there were different preclinical, clinical studies where people started using MET-specific inhibitors, and Geometry phase 2 trial was one of the landmark trials where capmatinib was used. Followed by that, we have Vision phase 2 trial, and then we recently got approval for capmatinib and tepotinib in MET exon 14 skipping. It's already part of the NCCN guidelines. So how much it is MET exon 14 skipping? We all know EGFR alterations, there are 19 different deletions in exon 19. Put together, there are about 23 alterations, which was known as a textbook information for EGFR for a very long time. Subsequently, different case studies came up, and then now we have something like 42 alterations in EGFR, which are known to be oncogenic. Now, what is known in MET to call it a hotspot region, and or rather, what are the mutations in MET which are documented in literature to show that this particular mutation definitely leads to a oncogenic phenotype? Since this is one of the landmark studies where they looked at 298 cases for non-small cell lung cancer, where they identified 165 different variants in MET exon 14 in and around. It was a hybrid capture-based approach. I would come back to that on technology later. Basically, this is one of the largest studies which shows the spectrum of mutations. So looking at 165, this study is also not recent. It's probably about 2018 or so. So as and when we come across new patients, I'm sure we're going to see more and more exon 14, new varieties. So the take-home message is, this is exon 14, this is exon 13. Mutations that happen in this entire region and little on the other side are responsible to create a kinase where exon 14 gets completely deleted. Therefore, a hotspot panel or a targeted panel which only looks at these specific set of mutations will never completely cover the scope of testing. So therefore, one needs to completely sequence exon 13, intron 13, exon 14, and intron 14 in order to confidently say that I have not missed out any exon 14 mutation, skipping mutation in this particular patient. This take-home message is very, very important because when you look at hotspot targeted panels, you have a very high tendency not covering a few regions in the intron, particularly because of poor coverage and several other factors, and you miss the variant. And moving on, even with RNA, the story is again different. So the topic of discussion was IHC versus NGS. Sorry, IHC was not part of it. Either you look at FISH and NGS and PCR. I brought in IHC because it's a protein expression for MET. Do we have any role for IHC? Because ubiquitously, as I said in my first slide, 50% of non-small cell lung cancers do have MET expression, but that MET expression does not have an underlying biology very well documented. So this is one study where people tried to prove, can I see a MET exon 14 skipping mutation or a MET amplification correlating to IHC? The correlation was very, very poor. So beyond that, it was considered that IHC cannot be a robust marker, and NCCN guidelines are clearly indicated no IHC as a testing methodology. What is the most effective approach? qPCR based approach. It is a very simple and easy to understand approach. Basically, what one can do is, if at all your mutation is to understand whether exon 14 is lost or not, take the mRNA, put your probes on 13 and 15 and see whether 14 is getting sequenced or not. It's a simple PCR approach. However, in this process, the challenge here is with FFP, the RNA is highly degraded. There are many times you have an assay failure or part like necrotic material comes in, fixation artifacts would be there. All these contribute to the quality of the qPCR assay, and you have very high chances of missing. That's why the sensitivity is not so great, but it is very decent, greater than 90% to pick up exon 14 mutations by RNA. So there are disadvantages like any other technology, but we have to live with it till we find a good technology. Now, moving on to NGS. In NGS, there is so much which has been discussed in this 2-day session. There are several speakers who spoke about exon 14 skipping. I wouldn't go into many details. As I told you earlier, amplicon means you target a specific mutation on either side locally and try to amplify that DNA and look for the mutation. When you do this, you are predetermining your mutations. You are only focusing on those 165 which were referred in that article to screen for it. Maybe the patient has a mutation which is beyond 165. If it could go up to 165, it could be beyond that also. So nature can make mutations that can lead to oncogenic activation beyond what is being documented, because as we are treating, we are constantly learning the landscape. And therefore, amplicon-based approach, although it becomes cost-effective because you're only looking at small regions, it is not going to completely cover the scope of testing. There is your disadvantage. However, when you take hybrid capture-based approach, you are not only sequencing the exons, but also the introns. That is, again, a design perspective. Some labs might just do a little bit on the intron by hybrid capture and still say we are using hybrid capture. So essentially, as a clinician, or as a laboratory scientist who takes the onus to say that I have completely screened for exon 14 skipping mutation, we have to ensure that intron 13 and intron 14 are completely covered with the splice junctions on exon 13 and 15 to confirm that we are not missing any exon 14 skipping mutations. I think I am running out of time, right? Am I running out of time, Suruchi? Yes, I'm quickly finished. Pretty much the same thing what I discussed earlier. This is DNA versus RNA based approach. Again, here hybrid capture. Most important take home message here is the tumor content should be greater than 20% in order to look at it at the DNA level. But DNA has an advantage because between DNA and RNA in FFP, DNA stands out to be slightly better in quality as compared to RNA because it's not as labile as RNA. Therefore, your diagnostic yield is going to be slightly better off. So this is one such assay which we developed in-house. I'm just showing the screenshot of only the MET exon 14 skipping. We all talk about 100x, 200x depth of coverage in NGS, right? And not only that, the coverage. So if you see the label here, this is exon 13, exon 14, exon 15. The way the sequencing is done or the way the probes are being designed is such that the entire region is adequately sequenced multiple times from different cells. This is what is evident here, that if you get a coverage like this is what we call it as coverage. If we get a coverage like this with very good depth, horizontal as well as vertical, this gives us the confidence that we are not missing anything in terms of screening for mutations. And we are confidently saying whatever we are saying, whether it is positive or negative, we do get a good confidence because seeing is believing. So there are multiple assays, and Foundation One works on DNA based, Oncomine works on RNA based approach, and Snapshot assay is a hotspot panel. And I just described about our assay. Just a last note here. Although we know that our RNA-based approach is good with NGS panels, there is a recent evidence from India, from Dr. Maushmi and Dr. Anurag Mehta's group. They have raised a red flag that they could see a few false positive reports in exon 14 skipping using Oncomine assay. Although recommendations are RNA-based approach, I think there is a chance of false positivity, non-specific binding with RNA, because RNA gets heavily degraded. When the size of DNA becomes smaller and smaller, there are very high chances that non-specific primers will bind and amplify the DNA, and you tend to get a non-specific signal. So size of template is very, very important in NGS, minimum 150 to 100 bases. That is what FFP DNA gives us, and even cell-free DNA gives us. So this is the study where they looked at capmatinib in both 14 skipping and amplified, and they have shown that there is a good anti-tumor activity. The take-home message is, when selecting the most appropriate assay for broad molecular, we have to consider the assay limitations. Very, very important. And at the same time, we need to also look into what is available with us in terms of patient material, and then take a call what is best which we can do for the patient. So one needs to take a careful call for each case based on different factors: tissue availability, FFP, RNA quality, tumor cell percentage, and technology. And your choice of technology might change from patient to patient. For some patient, maybe you got a fresh tumor available. You might want to look at it in an RNA-based approach. Where some others, maybe you don't have anything left. You may want to look into it in cell-free DNA-based approach. So guidelines and recommendations are there, but tailor-made treatment will be the heart of treatment landscape, treatment modality in oncology. And so that's where I would like to stop, and thank you so much once again, and would like to take any questions.
There are no questions. We'll move to the next talk of this session. So I would like to invite Dr. Siddharth Turkar, Director, Radiant Super Speciality Cancer Hospital, Raipur, and he will be speaking on selection of first-line therapy for MET amplification and MET exon skip mutations in non-small cell lung cancer.
Okay. Good evening, everyone. So I would be presenting the first line treatment for MET
exon mutation, non-small cell lung cancer. So MET mutation is reported to be mutually exclusive of other established molecular drivers like EGFR and ALK translocation. MET mutation in splice slide leading to exon 14 skipping result in MET14 juxtamembrane gain of function alteration, and it is originally discovered in small cell lung cancer and later in non-small cell lung cancer adenocarcinoma. It occurs in 3% of non-small cell lung cancer adenocarcinoma and 5 to 22% of other non-small cell lung carcinoma subsets like sarcomatoid variant. MET exon 14 mutations are linked to early stage diagnosis and older age. So this is the wild type MET signaling. So it is the ligand for the receptor is hepatocyte growth factor. As you can see, there is a transmembrane and juxtamembrane domain. In the juxtamembrane domain, there is a protein encoded by exon 14 region. And whenever this receptor dimerizes because of ligand binding, then there is phosphorylation and recruitment of signaling proteins, which leads to survival, decrease apoptosis, regulation of cytoskeletal function, growth differentiation, and stemness. So basically, it activates multiple signal transaction pathways like MAPK, PI3K, STAT, and NF-kappa beta. So as Madam has already told that there is a MET exon 14 splicing mutation. So when in normal splicing, DNA leads to pre-RNA and pre-mRNA, then mRNA. So in that exon of sometimes there is an abnormal splicing which leads to exon 14 being skipped, and the resultant protein is being encoded only by exon 13 and exon 15. So this leads basically this exon 14 protein is required for binding of a protein called CBL, which leads to internalization of the receptor followed by degradation by ubiquitination. But because of the absence of this protein, there is no degradation, which leads to constitutive activation of this protein and decreased degradation, leading to continuous signaling. So it has been seen that MET exon 14 is associated with worse survival and was found to be an independent prognostic factor that predict worse survival compared to those without this mutation. You can see the overall survival and disease-specific survival both are less. It has also seen that MET exon 14 had poor response to immunotherapy drug also. The median PFS seen on those patients with MET exon mutation with PD-L1 positive was just 1.9 months. It has also been seen in retrospective series that MET inhibition prolongs survival in MET mutated stage 4 non-small cell lung cancer. Those who have not received had median OS of just 8.1 months, and those who have received has median OS of up to 24.6 months. So there are three types of MET TKIs: type 1, type 2, and type 3. The drug that is currently in use belongs to the type 1 category, ATP competitors that bind to ATP binding pocket of active form. Type 1A constitutes crizotinib, and type 1B constitutes the other drugs, capamatinib, tepotinib, and savolitinib. Then this is the current treatment paradigm for molecular biomarker positive advanced non-small cell cancer. Apart from the established driver mutations like EGFR, ALK, ROS, BRAF, NTRK, and RET, now MET exon 14 is also being recommended to be tested and to be targeted for treatment. So as Madam has already told that as per the recommendation right now, RNA-based NGS is the most sensitive test, although it has some flaws that Madam has already told that the RNA is not that stable. So there can be false reporting because of that. But it is right now the most sensitive and recommended test for MET exon 14 testing. Now, MET inhibitors that are being approved and in use are crizotinib, tepotinib, and capamatinib. So, crizotinib, all these tepotinib and capamatinib have been FDA approved for this indication. Now, capamatinib is a selective MET inhibitor, and it is the most potent among the other drugs, considering its the concentration needed for activity. Now, this drug was tested in phase 2 a multi-center open label trial where there was 7 cohorts. Out of this, cohort 4, which constituted pre-treated patients with MET exon 14 regardless of MET gene copy number, and cohort 5B, which constitutes treatment naive patient with MET exon 14. The primary objective of this study was to demonstrate the anti-tumor activity of capmatinib and overall response rate assessed by blind independent committee. The key secondary objective was duration of response. The other objectives were overall survival, anti-tumor efficacies, other efficacies like overall response rate, duration of response, time to tumor response, disease control rate were also there. When coming to the baseline characteristics of this study, so you can see the median age of the patients were 70 years, around approximately 70 years. There was more of male patient with female patients constituting only 40% in cohort 4, and treatment naive patient only 18%. ECOG performance status of 0 and 1 were there. Brain metastasis was there in 15.9%. In cohort 4 and 10.7 in the treatment naive group. Concurrent MET amplification was also seen in this study, which I am going to talk later on. In cohort 4, as they were pre-treated, either patient where most of the patients were either post 1 line or second line of treatment, but few patients were also post 3 lines of treatment. The treatment line constituted of platinum-based chemotherapy mostly. Then these are the results for pre-treated cohort 4, where they have seen the partial response rate was around 40% in both investigator and blind review committee. The stable disease was 36.2 and 30.4%. The disease control rate achieved was up to 80%, and overall response rate was around 40%. The clinically there in cohort 5B patients, there was one CR by seen in a treatment naive patient. The overall response rate here was 67.9%, and disease control rate was around more than 95%. You can see from the waterfall plot that many of the patient has achieved a significant decline responses from the drug. The median duration of response was 9.7 months in the cohort 4, that is pre-treated, and 12.6 months in the cohort 5B, that is treatment naive patients. The progression-free survival was 5.42 months in pre-treated, and those with treatment naive was 12.42 months. It has also seen that it has confirmed activity against brain metastasis. There is the 4 patient had complete resolution of all brain lesions, and around 7 out of 13 patient had an intracranial response. And all 7 responders in the brain had an intracranial response at first evaluation itself. Now, there are other MET alteration also, and it has been seen that deep responses, irrespective of the type of mutation, were also seen with this drug, and co-occurrence of MET amplification has not too much of bearing on the results. Then the updated results, which included the expansion cohort 6 and 7, considering pre-treated in cohort 6 and treatment naive in cohort 7. It confirmed the result that overall response rate was around 67% for treatment naive patient, and disease control rate was more than 95% in treatment naive patient. In those who are pre-treated, the response rate, overall response rate were around 51.6%, and disease control rate was 90.3%. The majority of patients experienced a tumor response at first evaluation itself. The median duration of response to capmatinib was 12.6 months. It was 8.4 months in the second line and 9.7 months in the second or third line. The median PFS was 12.3 months in the first line, 6.9 in the second line, and 5.4 months in the third line setting. Then regarding the safety, as you can see, the main toxicity, the grade 3 and grade 4 toxicity was seen in 35% of the patient. The most common toxicity was peripheral edema. It was 41.6 in any grade and 7.5% as grade 3-4 peripheral edema. Nausea and vomiting was also there because initially it was given in fasting condition and later on the food restrictions were removed. It was otherwise very well tolerated drug and there was very limited grade 3 or grade 4 toxicity. So the peripheral edema, gastrointestinal symptoms, and increased blood creatinine was also seen, which was there was not any grade 3, grade 4 creatinine increase. It was just less than grade 2 creatinine increased. So preliminary efficacy result of expansion has shown, has confirmed the result that this drug has activity and shown to have good overall response rate and disease control rate. And the median overall survival was up to 20.8 months in the treatment naive patient and 13.6 months in those who was pre-treated. The safety profile was okay, found to be okay. Now regarding the MET amplification, so there was one cohort where they have seen that those patients who have MET amplification, that is gene copy number more than 10 and no exon 14 mutation. In this cohort, there was some improvement in response rate. The response rate was around 29% for the pre-treated cohort and 40% in the treatment naive patient. The duration of response was 8.31 months and 7.54 in treatment naive patient. So basically, in those patients who have high MET amplification, this drug can still act, but the major indication for this drug is for MET exon 14 mutation. The updated analysis has just confirmed the result of the activity of this drug with those who have MET amplification. The response rate around 27%. Those who have received it as a first line for MET amplification, it is 40%, and second line it was around 48.4%. Now there is the other drug, that is tepotinib. And this drug was also tested. And the primary endpoint of the study was overall response rate. The secondary endpoint was duration of response, progression-free survival, overall survival, and safety. It constituted patients with MET exon 14 alteration, either on liquid or tissue biopsy, and they have given the drug in first line, second line, or third line setting. So as you can see from this waterfall plot, over 90% of the treatment naive patient treated with tepotinib experienced the tumor shrinkage. The overall response rate was 54.7%. The median duration of response was 32.7%. The median progression free survival was 15.3%, and median overall survival was highest, that is 29.7 months. It has a manageable safety profile. The toxicity seen with this drug was almost similar to capmatinib, with peripheral edema being the major side effect apart from nausea and vomiting. The more than grade 3 toxicity was seen in 14.1% of the patient. Dose reduction has to be done in 15.6% of the patient, and temporary interruption was in 21.9%, and leading to permanent discontinuation in 6.3% of the patients. Then the conclusions from this study was there was fewer discontinuation, and the grade 3 toxicity was comparatively less, with peripheral edema being the major in more than grade 3 in majority of the patient, and only 4 to 5% of the patient had a permanent discontinuation of the drugs. But overall, this drug was very well tolerated. These are the key trials evaluating the MET inhibitors for MET exon 14 altered non-small cell lung cancer. First is crizotinib, which has shown overall response rate of 32%, median duration of response 9.1 months, and median progression-free survival of 7.3 months. Capmatinib, already I have told, overall response rate of 40.6 in pre-treated, 67.9 in treatment naive. median duration, median progression-free survival 5.4 and 9.7 months respectively. Tepotinib has the best overall response rate 50% and median duration of response of 12.4 months. The median PFS was 9.5 months, which was comparable to capmatinib. The other drug that is there is savolitinib, and it has overall response rate of 47.5 months and median PFS of 6.8 months. So this is the NCCN guideline. It shows that those who have met exon 14 skipping mutation should, if they have not started on any first-line chemotherapy, they can go ahead with preferred one are capmatinib and tepotinib. The useful in certain circumstances is also crizotinib, or they can go ahead with systemic therapy also. Those who have already started, they can wait for their progression and later on to be started on capmatinib or tepotinib. These are the emerging biomarker, the high level MET amplification, and they have here they have defined it as gene copy number of more than 10. In few studies, more than 5 or 6 is also taken as cutoff, so it is still not very much defined. In those, there is, based on these preliminary results, these drug can act, crizotinib, capmatinib, and tepotinib. Although MET amplification is many times co-occurrence with other kinds of mutation, and it has been seen that those patients who have MET exon 14 mutation, they respond to capmatinib irrespective of the MET amplification status. These are the ongoing trials with many drugs in the pipeline of phase 2 and phase 3. So thank you.
Thank you, sir. For the next talk at this session is going to be on mechanisms of resistance to MET TKIs and treatment post-resistance in non-small cell lung cancer. I would like to invite Dr. Sudeep Das, who is a consultant medical oncologist at Medica Super Speciality Hospital, Kolkata, to give the talk.
At the outset, I want to thank Kumar sir, Bijay sir, Akshay sir, and all the organizing committee members for inviting me here. So I'll be talking on a mechanism of resistance to MET TKI and therapy post-resistance in non-small cell lung cancer. So my previous speakers, they have elaborated all the salient features of MET mutations in non-small cell lung cancer. I am not going into detail of that. So we all know that MET dysregulations are broadly classified in two types. One is exon 14 skip mutations and MET amplification. So MET amplification patients, they do worse than MET exon 14 skip mutations. And both the type of dysregulations, they express a lot of PD-L1, but they are inherently immunotherapy resistant. So they are poor responder to chemotherapy, poor responder to immunotherapy, and so the solutions were different MET TKI, as told by my previous speaker, Dr. Siddharth sir. So to understand the mechanism of resistance development in MET TKI, we need to understand the different configurations of types of MET inhibitors. So there are broadly 3 types of MET inhibitors: type 1A, type 1B, and type 2. So crizotinib is type 1A MET inhibitors. Our well-known capmatinib, tepotinib, and savolitinib, these are type 1B MET TKI, and they are type 1B are more specific. And we also have type 2 TKIs, which are cabozantinib, merestinib, and glesatinib. Now, what is the difference? The difference is the type 1A and 1B TKIs, they bind the ATP binding site of tyrosine kinase domain of MET receptor when this receptor is in active conformation. And type 2 TKIs, they bind when the receptor is in inactive conformation. So that leads to different kinds of mutations altogether. And if we see the success story of different MET inhibitors, it is not as impressive as we witnessed in second or third generations EGFR inhibitor or ALK inhibitor. So the overall response rate somewhere close to 40 to 60%, and the PFS somewhere close to 6 to 8 months. So the limitation is development of resistance very soon with these TKIs. And we all know that even the efficacy of these TKIs is much lower when we see the MET amplifications compared to exon 14 skip mutations. So what are the resistance mechanism? One is inherent resistance, that is de novo upfront resistance, which can be because of presence of concurrent mutations, other concurrent mutations, gene amplifications of MDM2, CDK4 and EGFR. There can be amplification of or mutations in KRAS and PIK3CA or loss of PTEN protein expressions. So the philosophy was, the understanding was that probably these other genetic dysregulations were already present in the primary resistance where these clones were very less in number, and there are some other acquired resistance also. We'll mainly focus on acquired resistance. So when patients they are exposed to MET TKI, there are some acquired resistance, either can be on target resistance mechanism or off target resistance mechanism. So on target resistance mechanism means that the genetic abnormality is inside the somewhere in the MET receptor. It can be at the ligand level. It can be at the ligand level when there can be a hepatocyte growth factor amplification. It can be amplification of MET receptor itself, or it can be a secondary mutations, point mutations of the tyrosine kinase domain of MET receptor. And off-target resistance mechanism means that there are bypass activations of different genetic pathways, which can be other tyrosine kinase pathways like activation of EGFR or HER3 or KIT amplification, or it can be activation of genetic signaling steps which are at downstream like KRAS amplification or KRAS mutation or BRAF mutation or BRAF amplification. So altogether it's a very heterogeneous and very complex mechanism of resistance, and whenever we encounter such situations, we don't have any single answer for such situations. So acquired resistance is inevitable in MET targeted therapy, and multiple secondary mutations could occur simultaneously in one patient. So please note that which indicates that the possibility of heterogeneous resistance mechanism can be there. So that's why it's very difficult to treat a patient based on the resistance mechanism identified on the rebiopsy NGS data. We may not get the optimal result because maybe there are some other lesions in body which can harbor some different clone. So it is always advised to take both tissue biopsy at the time of progression as well as liquid biopsy NGS, because they too are complementary. As seen in this series of 18 patients, this is 18 patients who progressed on crizotinib, capmatinib and glesatinib. The different secondary mutations were identified on both tissue as well as liquid biopsy NGS. And when if we do only one biopsy, and we can miss some of the mutations. So multiple mutations can coexist. That is the actually understanding. So how to overcome this resistance? So this is actually evolving. This science is evolving, and this will include the optimal sequencing of different MET TKIs, development of new MET TKIs which are sensitive to resistant mutations, and combination therapies as well. So the pattern of secondary mutations, on-target mutations, are different from type 1 TKI and type 2 TKI. when we use type 1 TKI like crizotinib, capmatinib or tepotinib, we see mostly two mutations very frequently. One is Y1230 and another is D1228. And for type 2 mutations, the most frequent hotspots are actually F1200 and L1195. So these are the frequent mutations in type 2 TKI. So the very interesting observation was that D1228 and Y1230 mutations, which are commonly occurred in type 1 TKIs, they are actually sensitive to type 2 MET TKIs, and that is vice versa. The L1195 and 51200 mutations, which commonly occurs in type 2 TKIs, they have high resistance to all type 2 inhibitors, but they are still sensitive to type 1 MET TKIs. So that is very important finding. Now coming to this is so far the largest clinical data of MET resistance mechanism of 20 patients, of which 15 paired samples of analyzed. Paired sample means both solid biopsy as well as liquid, and on target mutations, secondary hotspots were noted in 35% patients, and off target resistance mechanism were present in 45% patients. So please note, in on target 35% secondary mutations, some of the cases they had multiple mutations altogether. So in this clinical data also, as I already mentioned, that the type of pattern of resistance mutations are very specific and very type specific. Like I previously mentioned that D1228, Y1230, these mutations are phenomenal for type 1A, and L1195, this is for type 2. Now, crizotinib has a specific mutations, which is G1163R mutations. So that is because the solvent front mutations G1163R mediates resistance only to crizotinib, but not to type 1B or type 2 MET inhibitors. So this data was also validated in clinical scenario where a patient who progressed on crizotinib, then on progression he was exposed to merestinib and he showed some response. And when a patient who was first treated with a type 2 MET TKI, gelatinib is a type 2 TKI, when on progression he was exposed to crizotinib and there was some at least some response. So the complementary activities against these mutations, that is type 2 MET TKIs, can overcome acquired resistance due to secondary mutations caused by type 1 and the vice versa. It is very important. And however, there are some typical mutations like D1228AY confers resistance to both type 1 and type 2, both kind of MET TKIs. So for this, in this lab experiment, 4 type 2 MET TKIs were tested, and among these 4 type 2 MET TKIs, only Foretinib, this Foretinib that showed sensitiveness to this D1228A and 1228Y. So only Foretinib has some sensitiveness to all these mutations. So another very lucrative strategy is to combine both type 1 and type 2 MET tyrosine kinase inhibitors at the beginning. And this data shows that if we use type 1 and type 2 both at the beginning, there will be less emergence of the clonal resistant clones, and also there was better tumor shrinkage. Not only this, even in a EGFR mutated patients who had the progression was because of emergence of MET amplification, when the patient was treated with osimertinib and savolitinib combination, savolitinib is a type 1 MET inhibitor, there was a resistance to savolitinib, and then the patient was successfully treated with erlotinib and cabozantinib. Cabozantinib was actually type 2 MET inhibitors. So this holds true even in EGFR mutations scenario also. So my previous speaker already mentioned that most common adverse effects, class specific adverse effects of these TKIs are nausea, vomiting, peripheral edema, and AKI, and some fatigue. So is immunotherapy an option when patient is progressing on MET TKI? The answer is no, because this is the data showing the response of immunotherapy in MET mutated patients. The overall response rate was only 17% with a median PFS of very poor 1.9 months. This was also validated by a big retrospective data of 551 patients who all were driver mutations positive, and they were treated with immunotherapy, in which 32 patients were MET positive. Hardly the response rate was 15%. The median PFS in MET mutations with immunotherapy was merely 3.4 months. So immunotherapy is not an answer. There are other TKIs under development which are in different stages of development. I am not going into detail. And very interestingly, there are also some monoclonal antibodies developed against MET receptor, which are also in pipeline and being tested. So in future, the strategies can be divided in two ways. Either you do a broad comprehensive NGS panel, and if any hotspot is noted, then secondary mutation, you choose some different MET TKI, or there can be some activity of monoclonal antibodies which can be specific against MET, bispecific antibody, or antibody drug conjugate. So to conclude, the take-home message is that one of the inevitable problem of MET TKI is that the drug resistance, and due to the presence of gene amplification, second site mutation, bypass activation, or pathological type transformation. So if type 1 MET inhibitors like crizotinib, capmatinib, tepotinib, or savolitinib were used in the first line, then drug resistance is developed. Maybe type 2 MET inhibitors can be considered, but please do a NGS, both solid as well as liquid biopsy together in that setting. Thank you for listening patiently.
Thank you, Dr. Sudeep. We come to the end of the session on MET. We now move to the next session on ROS of rearrangements in non-small cell lung cancer. And for the first talk, I would like to invite Dr. Sunil Parishcha, who is a senior consultant oncopathologist at Rajiv Gandhi Cancer Institute and Research Center, New Delhi. And sir will be speaking on the interpretation of ROS rearrangements, FISH, IHC, and NGS. Just an announcement, the statistics workshop will start at 6 p.m. On the first floor. So those who are interested can join.
So can I start? Yeah, good evening, everyone. First of all, I would like to thank the organizer for giving me this opportunity, and it's really a pleasure to be here with all of you. So I'll be talking about the interpretation of ROS1 rearrangement in NSCLC. So as we all know that 90% of the lung cancer are NSCLC, and the role of pathologists in the current era is not only just to diagnose a lung cancer, but also to find out the predictive biomarkers so that the patient can be put on the targeted therapies. And this is the survival of the patient with the drivers in lung cancer mutation consortium. And we can see that there is a good prognostic separation of the curves when the patients are put on the targeted therapy, as shown in the orange curve, as compared to when no targeted therapy was given or when no driver was identified. So the consortium demonstrate that the best outcomes are seen in the patient with identified drivers placed on targeted therapy with a median survival of 3.5 years. So although EGFR and ALK make the bulk of the targeted mutations, but there is a potential application in uncommon mutation, and ROS1 gene rearrangement is important. So the proto-oncogene role of ROS1 was first identified in brain tumors 2 decades back. However, the role in lung cancer was first reported in 2007 by Rykova et al., who identified 2 other protein fusion transcripts, CD74 and SLC34A2. And improved sequencing techniques have enabled the discovery of increasing number of fusion partners. So this is actually a bird's eye view of the main ROS1 fusion partners in ROS1 positive NSCLC, and we can see that approximately 85% are comprising of this partners, predominantly CD74, followed by EZR, SDC4, SLC34A2, TPM3, FIG or GOPC. So the fusion proteins are the robust oncogenic drivers that leads to tumorigenesis by the activation of these pathways: JAK-STAT, RAS, RAF, MEK, ERK, PI3K, AKT, mTOR pathway. So ROS1 rearrangements are frequently associated with young patients, women, never smokers. Predominantly, they show a lipidic, solid or acinar pattern. They are frequently TTF1 positive, frequently diagnosed at advanced stage, and higher frequency of brain metastasis. Regarding the incidence and implications, the rearrangement occurs in 1 to 2.6% of NSCLC. The effectiveness of the therapies with TKI and NSCLC depend upon the accurate determination of the genomic status of the tumor. Detecting the ROS1 rearrangement offers the patient the opportunity to receive the highly effective targeted therapies. So this was our institutional study published showing the incidence of 2.8%, which was a relatively higher frequency in the North Indian patients. So these are the testing modalities. The IHC, which is primarily done for the screening, but a very important tool and the orthogonal testing confirmation by FISH and NGS. So IHC, the most popular clone is the D4D6 from cell signaling, and that has been utilized in the clinical studies and has stood the test of time. And I'm personally using it for the last 5 years in my department. The other popular clone that has emerged just last year, that is SP384 by Roche. So the guidelines recommend the use of IHC as a screening method, and the clones have a very high sensitivity of 90 to 100% as compared to FISH and NGS. And that's how it should have a very high sensitivity, because if the patient is missed at this point, the patient is unlikely to be tested again. So the ROS1 specificity is variable, ranging from 70 to 90%, and it depends on the clone used and the positivity threshold applied. But the bottom line is that all positive IHC cases must be confirmed with orthogonal test before starting on targeted therapy. So these are some cases from my case library, and various patterns have shown the ROS1 positivity. So this was showing a acinar pattern of growth, and we can see a strong and diffuse cytoplasmic expression of ROS1. And this turned out to be positive for the FISH rearrangement for ROS1. The second case showing a solid pattern with a very highly pleomorphic, mitotically active and tumor giant cells were also seen. However, in this case, the expression of ROS1 was heterogeneous again, but eventually it was positive for the FISH rearrangement testing. Even with the micropapillary pattern also, we found a strong and diffuse expression, eventually positive for the FISH rearrangement. So immunohistochemistry has advantages. It's a very effective screening tool and requires just one section. Cell blocks can also be used. It avoids unnecessary FISH testing, which is expensive and tedious. And the very important thing is that it has a very short turnaround time. So the medical oncologists do get across the clinical situations that actually require expedition of results. So many a time, like my colleague, Dr. Ullas, he tells me even in the evening that I'm anticipating a ROS1 or a ALK mutation in a particular patient. So by next day, by 12 or 11 a.m., I'm ready with the results of the immunohistochemistry. So it's not even a single day. So standardization and validation is very easier. More labs can do it. It's not an arduous task. So disadvantage, different interpretation criteria were suggested with the different cutoff points. For example, positivity defined with moderate or a strong intensity, and few authors have suggested a H score of more than 100 or a more than 150 as a cutoff. But currently there is no standard cutoff criteria accepted, and it is recommended that each laboratory validates its own interpretative range. And there are three practical challenging scenarios in ROS1 immunohistochemistry that has important clinical consequences. So I'll be just taking off one by one. So first is when you have a true positive immunohistochemistry result, but eventually not confirmed by the orthogonal method. So that can be attributed to the limitations of FISH and NGS because they can be false negative. Or you can have an unexpected discordant equivocal or a low confidence in a confirmatory test. Even the most expensive and sophisticated NGS panel might fail to detect the fusion. And the risk of false negative increases when a DNA-based NGS approach is used. So the precise knowledge of the coverage of the assay and its real-world performance can help to rule out a NGS false negative result. And it is now recommended that IHC positivity and questionable ROS1 orthogonal test result be confirmed with another technique. The second challenging scenario is you have a false negative IHC result. So patient with a negative IC results are unlikely to be tested again for this biomarker. So one should actually consider the overall context. So if clinically the patient is never smoker, young age, histologically you have a acinar or a solid pattern with signet ring or mucinous cells, and also the genomic context. If the patient is negative for the other driver mutation, so one should go for a multi-gene assay, NGS testing. The third scenario is the significant ROS1 expression can be present in ROS1 amplified tumor or ROS1 negative tumors containing other oncogenic drivers, mainly EGFR mutation, also KRAS, BRAF, ALK, and HER2 abnormalities. So if confirmatory method by break apart FISH negative for ROS1 gene rearrangement, one should go for a NGS testing. So this is the workflow algorithm of the ROS1 IHC interpretation along with the challenging scenario that I've just explained. So coming to the break apart FISH, it's a gold standard to diagnose the ROS1 gene rearrangement, and it has played a vital role in the initial clinical trials of crizotinib. It is done by using a dual probe break apart design with two different fluorochromes labeled on either side of the fusion breakpoint. So this is the probe we apply. One is at the centromeric end, this green probe. So this green probe at the centromeric end, and this is the breakpoint, and the orange probe is at the telomeric end, the 5'. So this is the criteria and the prerequisite for a positive test, that more than 15% of the cells should show separation of both 3' and 5' probes, or more than 15% of cells show isolated 3' centromeric signal, but not 5' signal. And the prerequisite is that more than 50 viable tumor cells must be present to validate a positive finding. And these 50 cells that we evaluate should be in a sequential. There should be no cherry picking that this particular cell is showing a break apart signal and that particular. So in uncertain cases, if there is a range of 10 to 15%, a correlation of another diagnostic test is recommended, IHC or NGS. So this is showing the ROS1 rearrangement when it is absent. So there will be no break apart, and there will be a fused yellow signal will be seen as shown by the white arrow. And when there is a ROS1 gene rearrangement is there, so the classical pattern is showing one fusion signal and two separated 3', 5' signals. And these two signals should be separated by twice the diameter of the signal. This is the atypical pattern with the native ROS1 fusion signal and isolated 3' signal. That is the green, which is towards the centromeric end without the corresponding 5 signal. So the false negative break apart FISH can occur when certain fusion partners, primarily GOPC ROS1 or EZR ROS1, they are known to cause a false negative break apart FISH. It is the inability of certain FISH probes to detect rearrangement that result from small genomic deletions, and there can be complex staining pattern also in which many atypical fusion doublets are seen, but the percentage of cells with the split signals was below the 15%. So this was the study published in JTO. So showing the comparison of the molecular testing modalities for the detection of the ROS1 gene rearrangement. So the FISH was negative in 2 out of 20 cases. So in the first case, it was attributed to the GOPC fusion partner. So the deleted region was so small that leaving behind the complementary region for the binding of both the probes. So it was false negative. The second case.
Sir, sorry to interrupt, but kindly conclude your talk.
Yeah.
We are running out of time.
Okay. So false break apart can be because of the unproductive rearrangements and aberrant probe hybridization. So NGS has a advantage that it has the potential to detect several fusion, not only the known, but also the novel fusion, and also other targeted multiplex panels able to analyze the hotspot region of all the approved molecular biomarkers. So even the partners with a very low frequency can also be identified with this. So DNA and RNA based sequencing, I think the advantages and disadvantages have already been discussed in the previous. So I can conclude that the ROS1 positive NSCLC have been identified as a distinct molecular class. The effectiveness of the targeted therapies depend on accurate determination of the genomic status of the tumor. It's incumbent upon the pathologist to make the testing reliable by optimizing the pre-analytical, analytical, and the post-analytical steps. And multidisciplinary communication is essential for the quality information within the required time frame, and that too at a judicious cost. Thank you so much.
Thank you, sir. We now move on to the next talk. That is the selection of first-line therapy for ROS1 rearranged non-small cell lung cancer. And I would like to request Dr. Venkata Pradeep Babu, a senior consultant and medical oncologist at Assam Cancer Care Foundation, Assam, to give the talk.
Good evening, all of you. And I thank Dr. Vijay Patil and Dr. Akshay Kappe for inviting me here. Today, I am tasked to discuss the selection of first-line therapy for ROS1 rearranged NSCLC. So I divided my talk into these subheads of historical perspective, pathobiology, and clinical features. Testing level, as already it was discussed by Dr. Sunil. So we know that nearly 3 million deaths occur annually across the globe due to lung cancer, and NSCLC account for 80%, and ROS1 fusions account for 1 to 2% of NSCLC. When we see the incidence across various parts of the globe, the incidence is nearly 1 to 2%. In India, it is slightly higher. We saw the Rajiv Gandhi data of 2.8%. So when we see the ROS, it is a receptor tyrosine kinase, a sarcoma oncogenic factor. Like many other targets, it was initially described in the glioblastoma cell lines and later in the GBM tumor tissue. And the initial fusion that was discovered was the FIG-ROS. So 1981, it was the initial cDNA isolated, followed by ROS1 fusion NSCLC only 30 years later detected in the NSCLC. So this is a TISA question that was usually asked. So what are the cancers that with the ROS1 fusions? Cholangio cancer, ovarian cancer, IMFT, and acanthus melanoma. So this is the timeline of ROS1 targeted therapies. We have seen the 1987 timeline, and then initially crizotinib followed by ceritinib, and then lorlatinib. All these were evaluated in the, and then came the approval of the entrectinib. When we see the pathobiology, ROS1, it is located on chromosome 6q22, and the most common fusion partner with the ROS is CD74. There are so many partners, but the most common is CD74, just like EML4 for the ALK. It is called as, it is referred to as orphan receptor. Why it is called orphan receptor? Because the ligand is not known and its physiological function is not known in adult. It's the main function of ROS is known during the embryogenesis and it becomes silent in the adult. However, it becomes re-expressed during the oncogenesis like many other genes. And when it becomes activated, the pathway that gets activated is RAS-RAF-MACAC pathway. So this ROS and ALK, it gives a distracting message that it may be membranous receptors. No, they are cytoplasmic receptors. Both ALK and ROS are the cytoplasmically expressed proteins. So the type of mutation we have seen that CD74 fusion is most common, and it seems to have more brain metastasis at the baseline compared to other fusion partners. And the co-mutation matters, just like our colleague during the training, during the residency matters, the co-mutation do matter. Initially, we know that only the mutation and the targeted therapy. After that, we know that all the mutations are not equal, so the co-mutation matters. If there is TP53 mutation, it will have shorter PFS with the same TKI. When we see the clinical features of ROS positive NSCLC, it seems that majority of the patients, more than 60% in of all the trials, they are the non-smokers. Majority of them are females and adenocarcinoma histology in more than 90% of the cases. Testing was exclusively described by Dr. Sunil, so I am skipping this. But as a clinician, my take-home point is never start treatment with IHC positive ROS. All IHC positive reports to be confirmed by FISH. Only then we have to start the treatment, because no trials have used IHC as the screening as a method of detection of ROS in the clinical trials. So coming to the ALK inhibitors as ROS inhibitors, why it was done in the initially? Because there is more than 60% homology between the tyrosine kinase domain of the ALK and ROS, and so there were the preclinical trials done and seen that ALK inhibitors do act against the ROS tyrosine kinase also. So there are 4 drugs that are currently active against the ROS rearranged NSCLC: crizotinib, ceritinib, entrectinib, and lorlatinib. The good thing is that any of the drugs at least gives a response rate of 60%, and ceritinib, lorlatinib, entrectinib in those orders have the highest amount of intracranial activity. And one more drug is in the trial, that is repotrectinib. So this is a 1 year ago NCCN guidelines showing crizotinib and entrectinib. Now certinib is also included in the first line guidelines of ROS positive NSCLC. The initial approval of crizotinib was done in 2012, nearly 5 years after the discovery of ROS1 in the NSCLC cell line. And entrectinib was done very recently in 2019. Coming to crizotinib, we know that it is a multi-kinase inhibitor against all ROS as well as MET. The profile is a trial of crizotinib predominantly for all patients. However, there is an extension cohort to study of efficacy of crizotinib in the ROS1 mutated patient. It is a phase 1 small study, single arm multi-centered study involving 53 patients. I just want to focus on important points. In this trial, brain metastasis were allowed, and most of them are in good performance status. However, ECOG-2 patients can be enrolled with the discussion of the investigator and sponsor mutual agreement. So they have looked at the response rate, PFS, and overall survival, and the median PFS is 19.3 months. Looks very good. Nearly 50% of patients, they are alive after 4 years also. And median OS is crossing 4 years and is nearly 51.4 months, which is really encouraging. Coming to the safety summary, there are no grade 4 and grade 5 side effects with the crizotinib in these set of patients. However, there are some deaths regarding to the trial, but there is no treatment related deaths. So any death that occurs during the trial is included in the trial, so that but regarding the crizotinib toxicity, there are no deaths. So these are the side effects that occur in more than 10% of treated patients, which include vision disorders. The vision disorders may be as small as photopsia of floaters, and as severe as retinal detachment, retinal derangement, and severe vision loss. Followed by nausea, edema, diarrhea. These are all the GI side effects. We know that there are lab abnormalities, elevated transaminitis, which requires the dose modification as discussed by the previous speakers. However, whenever we are discussing any costly treatment or any newer treatment, it is always good to refer to the package insert. So what does the package insert of crizotinib says? It says there are 3 important organs that may be affected, that is GI system, including the liver and GI side effects, and pulmonary toxicity, interstitial lung disease, and cardiac system, which includes QT prolongation and bradycardia. And if the bradycardia is severe, it may require discontinuation of the crizotinib as well. So this is the summary. Median PFS 19.3 months is the takeaway from this trial. So this is the crizotinib trial from the profile study. However, there are 2 important other trials which have looked at the PFS of crizotinib in the Asian subset as well as the European subset. So what are the results in the Asian subset? So we know that Asian population is different compared to the Western population as far as lung cancer is concerned. Within the Asians, Japanese, they have separate trials, separate results as far as the targeted therapies are concerned. And this is the study which included predominantly Chinese and Japanese population. And the primary endpoint is overall response rate. We can see here the response rate is 71%. And I want to concentrate on this point of population. Nearly more than 40% they are smokers. So when we see a smoker, we should not be nihilistic to test them for the targeted therapies. So median PFS is 15.9 months. So similarly, another study conducted in the European population, UCROSS study. Here, the number of population enrolled are very less, 30 patients. Median PFS is nearly 20 months. So this is the co-mutation activity that was analyzed here, present in ASCO 2022. So if a patient is, if we have done the NGS and the patient is P53 mutated, they have shorter PFS. We can see here the PFS is 7 months compared to P53 unmutated, which is 24 months, nearly 3 times the difference. And similar way with the patient having CNS mets, they have poor PFS of 9 months compared to 20 months without CNS mets. So a patient with CNS mets and imaging and P53 mutation and NGS, they are the worst subset. They will have the least PFS. Coming to entrectinib, why entrectinib is important? Because 36% of patients with ROS ROS derangement, they have the brain mets, and when we treat with crizotinib alone, more than 50% of patients develop the brain mets. And we know that entrectinib acts against all cross as well as MET. Why entrectinib is approved is because based upon the data from the combined analysis of 3 trials of ALCA trial as well as Star Trek 1 and 2. So what was the result? Almost all Asian, European and Western population was included. Majority of the patients were non-smokers. However, more than 40% are still smokers. And the most important fusion partner that was detected is CD74. And there were the CNS mets in half of the patient nearly. So 2 important points to note from the entrectinib combined analysis is the overall response is 77%. Intracranial activity is seen in more than half of the patients. And some of them have complete clinical response in the brain also. So this is the waterfall curve of the intracranial activity of entrectinib. What are the common side effects? Change in taste, dysgeusia, dizziness, constipation. Some patient might have diarrhea. But what does the package insert says? Just like we do echo before adriamycin, before starting entrectinib, we need to do 2D echo. And sometimes it may cause severe myocarditis also. And any drug which is acting in a CNS, like lorlatinib, do have CNS side effects also. And so the entrectinib also have cognitive impairment and other similar side effects. Certinib also has been shown to have some amount of intracranial activity. The response rates vary anywhere between 60 to 90%. Not going into the details. Coming to lorlatinib, it is not approved in the first line or ROS1 patients, but there is like the ALK resistance, ROS1 G2032R is the known mutation after treatment with the TKIs in this subset of population. So there is a subset with 12 number of patients with TKI naive as well as crizotinib exposure who are being treated with lorlatinib. And it was seen that even in TKI patients, the PFS is better and it is more than 20 months. So coming to the drugs approved for ROS1 positive NSCLC, FDA has approved crizotinib, entrectinib. EMA has approved crizotinib, entrectinib. Now NCCN has adopted certinib also in the first line of ROS1 positive NSCLC. This is the summary. When we see the extreme right column, we need to see that they have done RT-PCR, FISH and NGS, but none of the trials have included even IHC as a screening tool also. So this is the main takeaway from this slide. This is the recent NCCN guideline showing certinib, crizotinib and entrectinib. However, there will be certain situations where we cannot have hands-on crizotinib also for some of the set of the patients, particularly in a setting where I work. I see literally very poor patients and we do not have much access to the trial due to logistics on the terrain we live on in SM. So it seems that chemotherapy might be an option in some of the patients. For 2 of my patients who are having ROS, chemotherapy is going on. It seems that pemetrexed is a reasonable option compared to the other subsets. The reason explained is that ROS1 positive NSCLCs, they have lower expression of thymidylate synthase compared to the other types of other subsets. So pemetrexed based regimens, when there is no option of targeted therapy, seems to be a reasonable option. So with this, I conclude my talk. Thank you so much. This is our Tejpur Cancer Center. It was inaugurated on 28th April, this April. And there are so many challenges that we face at the periphery. At the same time, it is also satisfying. Even we get EGF for all cross by individual mutation analysis and treat them, it gives a lot of satisfaction. And thank you for inviting me from Assam to here. Thank you so much.
Thank you, Dr. Venkat. Now we move on to the next talk, which is mechanisms of resistance to ROS1 and treatment post-resistance. I would like to invite Dr. Ajit Chanana, consultant medical oncologist at Dharamshila Narayana Super Speciality Hospital, New Delhi, to give the talk.
So good evening, everyone. I think most of my slides are repetition of the slides of the previous speaker.
So I'll be discussing regarding the mechanism of resistance to ROS1 and what are the possible therapy that can be given post-resistance in non-small cell lung cancer. So this is one of the repetition. We know that 1 to 2% of the ROS1 of the non-small cell lung cancer, they are ROS1 positive. And once activated, ROS1 kinase activates the SHP2 phosphatase and upregulates MAPK, ERK, PI3K, and JAK-STAT signaling pathway, which ultimately leads to cell growth and promotion. So as discussed by the previous speaker, that CD74 ROS1 is the most common fusion partner, and that occurs in around 40 to 45% of ROS1 rearranged non-small cell lung cancer. So apart from CD74, there are many other fusion partners that can be found. So there are two presently approved drugs for ROS1. First is crizotinib, second is entrectinib. So previous speaker has discussed it beautifully. So this data has also been discussed. We have maximum data is for crizotinib. The median follow-up of 62.6 months. The OS is around 51.4 months. So with the next approved drug, again this trial has been discussed. The median OS is not yet there with entrectinib, but the median PFS is around 15.7 months. So entrectinib has a better CNS penetration, that we know for sure. With the median follow-up of 15.8 months, the overall response rate is around 67.1% and the duration of response is 15.7. The CNS overall response rate is around 79.2%. So we should remember that entrectinib can effectively cross the blood-brain barrier, acting on pre-existing CNS lesions and preventing or delay the onset of METs. However, we should know that there is no activity against the known ROS1 resistance and the common ROS1 resistance mutations like L2026M, G2032R, and D2033N. And it is not advisable to give entrectinib after once the patient has progressed on crizotinib. So there are four basic mechanisms of resistance, I think, which is common for all the tumors. The first is the on-target or the intrinsic resistance. The second is activation of bypass signaling pathways or off-target or extrinsic resistance. Third is inadequate CNS penetration, and fourth is phenotype change. So the on-target resistance means that the secondary point mutation develops within the ROS1 kinase domain that occurs in around 50 to 60% of the patient. The most common and the earliest one detected is ROS1 2032R mutation. So other secondary mutations include D2033L1951 and ROS1 independent mechanisms like mutations in KIT proto-oncogene and beta-catenin have also been detected. So that is an off-target mechanism. So this slide is trying to show that what drug can possibly act in these resistant mutations. So the important point to highlight is that in the G2032R mutation, you can see that cabozantinib has some activity. There is no activity of entrectinib and there is no activity of lorlatinib. So two possible drugs that can act on the most common mutation, they are cabozantinib and repotrectinib. The other common mutation L2026M, you can again see that entrectinib and lorlatinib has no activity. The possible activity can be shown by repotrectinib or cabozantinib. So activation of bypass pathway, it is a lesser common mechanism of action, and retrospective studies have shown that it accounts for around 42 to 44% of the crizotinib resistant ROS1 rearranged non-small cell lung cancer. So the bypass pathway includes EGFR, MET, HER2, KRAS, BRAF, MEK, KIT, and NF1. So if the patient develops a bypass pathway, then the treatment is either a combination or it depends on the activation pathway. The third mechanism is intracranial failure. I think that has been discussed that crizotinib has a limited blood-brain barrier penetration because it's a substrate of P-glycoprotein. And CNS progression to crizotinib reflect a pharmacokinetic failure rather than a true biological resistance. The CNS concentrations are usually low. So in these patients with only CNS progression, then novel ROS1 inhibitor can be offered like lorlatinib or like entrectinib. So if a patient has an isolated CNS mets, then novel ROS1 can be offered. Phenotypical changes includes two main types, that is EMT change, epithelial to mesenchymal transition, and the second common is the small cell transition. So these patients should receive the standard treatment as per the change. So how do we overcome resistance? I think that has been discussed, that we need to do NGS in both liquid and solid tumor if it's possible. And depending on the resistance mechanism, we can offer the treatment for CNS only progression. Then a better ROS1 inhibitor can be given. For a bypass pathway, we need to combine ROS1 with the targeted TKI. Chemoimmunotherapy also remains a possible treatment option, and according to the phenotypic change or bypass activation pathway. So this is a case study which has shown that in patient who had progressed on crizotinib with a G2032R mutation, that patient was treated with a chemotherapy regimen. Then once the patient progressed, then there was loss of the previous mechanism of resistance, and the patient was re-challenged with the TKI, that is crizotinib, and the patient had a good confirmed partial response when the patient was re-challenged also. The response was around 41.2%. So there are certain drugs that are not approved as of now. So one is ceritinib. Ceritinib does not work in those patients who have previously received crizotinib. Repotrectinib, there is only phase 1-2 data. It is a promising drug, but it is still not approved. The PFS is remarkable, 24.6 months, and it works in the common mutation like G2032R. In fact, it is the only TKI that has not shown resistance to acts on the common G2032 mutation, and it has a better CNS profile also. So this is a Trident-1 study of repotrectinib. You can see that it has shown remarkable response. The overall response rate is around 93%. And the common side effects include dizziness, altered taste, and constipation. Other drug that is not approved but is promising, it is lorlatinib. So lorlatinib can be given in those patients who have CNS only progression or who have oligoprogression. So the data is of median PFS is 21 months, and those patients who had received prior crizotinib, it is known to work not as good as repotrectinib, but the median PFS is 8.5 months. So it's important that it does not work in G2032R mutation. So the overall efficacy, you can see that even in the patient who were previously treated with crizotinib had a median PFS of around 9 months. And lorlatinib also has a better intracranial efficacy. So this is a real world data which is showing the activity of lorlatinib in the patients who were previously treated with ALK and ROS1. So in this, around 71% were ALK and 29% were ROS1. You can see that the response rate was also there. If lorlatinib was given in the second line, the response rate was around 54% and the PFS was around 13 months. So on the right hand side, you can see that the graph, the PFS was 7.1 in ALK, and in ROS1, it was around 11 months. The OS was also better. So lorlatinib can be given in second line, but we need to understand what is the mechanism of resistance before we can plan lorlatinib. The other upcoming drug that is not yet approved but is showing promising result is taletrectinib. So taletrectinib has shown a median PFS in TKI naive patient of around 29.1 months. And those patients who had received prior TKI, the median PFS is around 14.2 months. And those patients who had received 2 prior ROS1 TKI is 4.1 months. So it has also shown to overcome the resistance mechanism of to ROS1 G2032R. And it has shown a response rate of 33% in those patients who were previously treated with TKI. So another TKI in the pipeline is brigatinib. So in the brigatinib study, around 3 patients were ROS1. So 1 patient was crizotinib naive and had a partial response. So it should also, we should understand it does not act on the common mutation mechanism. So cabozantinib, as I discussed, there is a phase 2 data that it can act on the common mutations like G2032R and D2033N. So once we do the NGS and we know what is the resistance mechanism, then we can plan our next line of treatment. The PFS ranged from 4.9 to 13.8 months. So another standard treatment, not exactly standard, but can be a possible treatment after the failure of targeted therapy, includes either chemotherapy or combination of chemo plus IO that we used in other patients who are negative for any actionable mutation. So it is known that pemetrexate-based chemotherapy for ROS1 fusion positive tumor, it is associated with a better response rate and a longer PFS. And the potential role for combination needs to be evaluated, but it is definitely one of the possible treatment option. So this is a wonderful slide that I've taken from a paper. So it is shown how should we manage ROS1 positive patient. So if the patient has a CNS disease, then the first line should be entrectinib. And if the patient is symptomatic, then RT should be offered. If there is no CNS disease, then patient can be offered crizotinib. And on subsequent line, based on the type of progression, suppose there is CNS only progression, then a novel TKI which has a better CNS penetration can be offered, like lorlatinib. And if the patient is symptomatic, then RT should be given. If there is systemic progression, then we should do a liquid and a tumor biopsy, and based on the type of mutation, we should plan our treatment. The most common is G2032R. So if that is the mutation, then either cabozantinib or chemotherapy or chemoimmunotherapy. If there is G2032R mutation, then lorlatinib is probably a better of the treatment option. If there is a bypass pathway activation, then that pathway activation treatment and combination with a ROS1 TKI. If there is CNS or systemic oligoprogression, then we can give RT and continue with that treatment. So to summarize, there are several major resistance mechanisms that has arisen due to oral TKI that can lead to treatment failure. And we have novel next generation TKI that have been developed to overcome those resistance. And intracranial activity, efficacy against the ROS1 mutant kinase, and testing combination therapies for the bypass signaling resistance pathway, they may be keys for prolonging disease control and also to improve survival. And it's important that we find out the type of mutation. For that, a tissue or a blood-based or both NGS can help to identify the resistance mechanism to ROS1 TKI. And it may be considered after tumor progression so that we better select on the basis of whatever treatment options we have. Thank you.
Thank you, Dr. Rajit. We now come to the end of this session and we'll move on to our sponsored session. So for the first session sponsored by AstraZeneca, I would like to invite Dr. Alok Goel. He will be speaking on immunotherapy in combination with chemotherapy in first-line non-small cell lung cancer.
At the outset, I would like to thank Dr. Kumar and other organizer for inviting me for this academic feast. So I will be talking on IO combination in first line, exploring new treatment avenues. The slides are provided to me by AstraZeneca, and I don't have any conflict of interest. So we know that almost 80% of lung cancer are diagnosed in metastatic stage, and they have a poor survival. With the advent of driver mutation and driver mutation driven therapies, in the last 10 years, the outcome of these subset of lung cancer have improved. But in cases of driver mutation negative cancer, there is still an unmet need, and chemotherapy IO combination has come up in a new way, and there have been new developments. And there have been various trials which have shown efficacy and safety of IO combination with chemotherapy in stage 4 non-small cell lung cancer. So if we see what is the rationale for combination of immunotherapy and chemotherapy combination, so chemotherapy provides rapid disease control in these patients. Also, chemotherapy causes cancer cell death and thus reduced tumor burden. This releases new antigens into the system which prime an immune response. The subsequent immune response requires the presence and activation of T cells, which can be done by a combination immunotherapy in these cases. So there have been studies and there have been combinations of different immune checkpoint inhibitors. So it has been seen that combining both CTLA-4 and anti-PD-L activity might have some complementary effect and might lead to some additional advantage when seen clinically. So as we see, so it has been seen that CTLA-4 therapies inhibit suppressive Tregs and T cell activity primarily in the lymph node. And when these activated T cells are migrated to tumor cell, The inhibition of anti-PD-L1 leads to activation of effector T cells and can complement the activity of CTLA-4, thus leading to a complementary action and can supplement the effect of CTLA-4 inhibitors. What is important to know that even this response is persistent even in the absence of continued therapy, and thus a short-term control of tumor can achieve a long-term survival benefits. That's the rationale based on which IO and chemotherapy combinations have been taken further into phase 3 trials. So this slide must have been discussed multiple times. What is to be highlighted that despite multiple driver mutation which have been identified in these patients, there still remains a subset around 30 to 35% which lack any driver mutation, and the outcomes has been dismal in this. And there has been a resurgence of a lot of therapies, mainly combinations of IO as well as IO alone, which are driving the treatment landscape in this subset of patients. So this is a busy slide showing what are the treatment options which are available to us in a patient which lack a driver mutation. So these basically, the results are based on the PD-L1 status, which tell us the effect of immunotherapy in this patient. And I will not go into detail of this, but there are various approaches which have been used in each type of patient, including immunotherapy monotherapy, a combination of immunotherapy and chemotherapy, a dual immunotherapy with Nivo plus EV, and there has been now interest in combination of dual immunotherapy with chemotherapy with Nivo EP plus chemo, and further with Durva tremelimumab and chemotherapy in these type of patients. So this is just to highlight that with the explosion of treatment options, and there's still a lot of confusion in choosing the first-line therapy in these type of patients. And as we can see, almost 15 therapies have a category 1 indication in NCCN, thus making the life difficult for us in clinics. So now coming up to Poseidon study, this was a phase 3 randomized open-label multi-center global study, which included treatment-naive patients with metastatic non-small cell lung cancer that lack an activating EGFR and ALK fusion. What I would like to highlight that these mutations were tested by using RT-PCR and IHC, and no NGS was done in these type of patients. These were further stratified based on the PD-L1 expression based on a tumor proportion score of more than or equal to 50, and whether their histology is squamous or non-squamous, as well as a disease stage. So almost 1,000 patients were randomized 1:1 to 3 groups, either a platinum-based chemotherapy group up to 6 cycles. The choice of chemotherapy is either a nab-paclitaxel plus carboplatin for both adenosquamous, a gemcis for squamous, or a pemetrexed plus carboplatin for non-squamous cell carcinoma. The 2 other experimental arms were durvalumab plus chemotherapy, where durvalumab was given as 1500 mg every 3 weeks along with chemotherapy for 4 cycles. This was the induction phase. And the third arm, durvalumab 1500 mg was combined with tremelimumab 75 mg along with chemotherapy for 4 cycles. Those patients who had some response were taken up to maintenance, was given maintenance. In the chemotherapy arm, that maintenance was pemetrexed, mainly in the adenocarcinoma group. Whereas in those who was given durvalumab and chemotherapy, they were continued on durvalumab every 4 weekly, which was shifted from 3 weekly to 4 weekly. And pemetrexed was continued 3 weekly until disease progression. Whereas in the double IO group, durvalumab was continued 4 weekly and a single dose of tremelimumab. Only one more dose of tremelimumab was given at 16 weeks and was continued on pemetrexed and durvalumab until progression. So the primary endpoint of the study was PFS, which was assessed by independent central review, and overall survival in the chemo versus a durvalumab plus chemotherapy arm. The secondary endpoints of the study was PFS and the OS in the dual immunotherapy plus chemotherapy versus the chemotherapy arm. They also wanted to study OS in patients with a tumor mutation burden more than equal to 20 mutation per MB in the chemotherapy versus the dual immunotherapy plus chemotherapy arm. Other second endpoints were objective response rate, duration of response, PFS is 12 months, best objective response rate, the quality of life, and safety and tolerability of the drug regimes in these patients. So if we come to the eligibility criteria, what I just want to highlight, they included patients with PFS performance status 0 or 1, which we now see in most of the trials, and most of these trials don't include patients with performance status 2. Secondly, what I wanted to highlight that, as I already told, that EGFR and ALK fusion testing were done not by NGS. They excluded patient with mixed histology and sarcomatous or small cell carcinomas, and patient with symptomatic brain mets were also excluded. Only asymptomatic brain mets were taken in the study, and other exclusion criteria were as per the contraindication for immunotherapy, which we see in all immunotherapy trials. So if we look at the patient baseline characteristics, we can see that all the three groups were fairly matched with each other. So median age was around 63 to 64, which is what clinically we see in our clinics also. So there was a fair representation from various groups. So Asian population was almost 37%, but these were mostly East Asians, and most of those patients were not from Southeast Asia. If we see the squamous and non-squamous histology, almost 60% to 65% of patients were adenocarcinomas. What is important to see that almost 66% of patients had a tumor proportion score of more than 1%. Just one thing where I feel there has been some inequalities. So there are numerically higher number of patients with CNS and liver mets in the chemotherapy arm as compared to the chemoimmunotherapy arm. So if we come to the results of the study, so this is the interim results which were presented at World Cancer and Lung Congress last year, and the paper, the full paper has not yet been published. So if we look at the primary endpoint of the PFS in the Duva plus chemotherapy arm versus the chemotherapy arm, we can see that at 12 months period, the PFS improved from 13.1% to 24.4%. And we look at the hazard ratio, it is 0.74, and the confidence interval does not cross unity, and the p-value was significant. But when we look at the OS curves, the curves doesn't seem to separate much. And although numerically the OS was higher, but statistically the confidence interval crosses 1.02. So statistically there is no OS benefit with durvalumab addition in chemotherapy. Although this was an interim results, and the median follow-up for OS was 34.9 months, and for PFS the patient was followed up to 10.3 months. So if we look at the major secondary endpoints, when comparing the dual immunotherapy plus chemotherapy arm with the chemotherapy arm, as seen with durvalumab alone, the PFS at 1 year increased from 13.1 to 26.1, with the median PFS increasing from 4.8 to 6.2, which was also statistically significant with a hazard ratio of 0.72. But if we look at the OS in the combination immunotherapy plus chemotherapy arm versus chemotherapy, here it was statistically significantly better in the dual immunotherapy arm with a hazard ratio of 0.77, and a numerically increases from 11.7 months to 14 months. And if you can see, the curves are separating quite early at 12 weeks till when the chemotherapy was given. So if we look at a subgroup analysis, trying to understand why the benefit was there in the dual immunotherapy arm and the single immunotherapy arm doesn't have a benefit, we can see the benefit is mainly driven by the benefit which was achieved in adeno group in the dual immunotherapy arm, which didn't benefit as much in a durvalumab plus chemotherapy arm, as well as the benefit in the patient with even the tumor proportion score less than 1%, which is seen in dual immunotherapy arm, but not in those patients who were given single durvalumab. So if we look at the other secondary endpoints which were there, so we see the overall response rate was definitely higher in patients who received any kind of immunotherapy, whether it was a single immunotherapy or dual immunotherapy, with a significant increase from 24 to 38% in patients with durvalumab plus chemotherapy as compared to chemotherapy alone. What is important to look at, if we see that the median duration of response almost doubled from 5.1 months to 9.5 months in patients who were given durva plus tremi plus chemotherapy. And if we see that at 12 months, as compared to 21% patient, almost 50% of patients were progression-free in a dual immunotherapy plus chemotherapy arm, which was 40% in patients with durva plus chemo arm. So if we look at the pre-specified groups, stratified groups, so if we look at the outcomes in patients with non-squamous histology, we can see that the median PFS was numerically similar in patients with either given a single immunotherapy or dual immunotherapy plus chemotherapy arm, being 6.4 and 6.1, with a slight improvement from the chemotherapy arm. If we look at the hazard ratio was better for the immunotherapy plus chemotherapy as compared to chemotherapy arm. And if you look at the OS here also, the OS benefit was seen only in patients who were given dual immunotherapy, and the durvalumab plus chemotherapy arm doesn't seem to derive benefit even in adenocarcinoma group as compared to chemotherapy alone. So if we look at the squamous histology, in terms of both PFS and OS, that is clear from the curves we see, the outcomes didn't improve over chemotherapy alone in patients with either a single immunotherapy or dual immunotherapy arm, and there was no OS benefit or PFS benefit in the squamous histology. So if we look at the safety results are, there were no new safety signals which we found from this study. And the usual side effects, what we see in normal immunotherapy trials, the grade 3 or grade 4 adverse effects were fairly comparable between the chemotherapy as well as immunotherapy plus chemotherapy arms. If we look at even the treatment-related side effects, they were fairly comparable, and there was no new signal or new alarming side effect which came out of this study. Similarly, to this, the incidence of immune-mediated adverse effect were also comparable with any other immunotherapy trials, and there was no new or a specific side effect which is seen with a combination arm also. So if we put data into context for IO and IO trials, so we have two IO and IO trials which are available to us. One is the Checkmate 9LA trial, which combined Nivo plus EPP 2 cycles of chemotherapy, and the present Poseidon trial. So if we look at those, there was not much to choose between the two arms. The only difference was in Poseidon trial, 4 cycles of chemotherapy was allowed, which is what we use in clinical practice for patient, whereas in Checkmate arm, they gave 2 cycles of chemotherapy to reduce the tumor burden, then continued as Nivo plus EPO or the immunotherapy alone. And what is important to see that in both of the trials, crossover was not allowed. Crossover was not there in any of the trials. So if we look at a dosing schedule and what is difference between these two IO and IO trials, we can see that in Poseidon, we see in the induction phase, 4 cycles of durvalumab along with tremelimumab and chemotherapy was given. And then only 1 cycle more of tremelimumab was given at 16 weeks. And then only PD-L1 inhibitor durvalumab was continued and tremelimumab was discontinued. And PEM was optional, given to physician discretion. If we look at the Checkmate 9LA trial, we can see that Nivo and EPO both were continued until progression or 2 years, and the chemotherapy cycles were 2. What is the clinical significance of giving 2 versus 4 cycles? It is yet to be seen. So if we look at the comparison, although it's a cross-trial comparison, we cannot decipher much out of it. But what we see is, even after combining 2 immunotherapies, the outcomes have not been what we would have expected, with a median OS of only 14 months in the Poseidon study with even a dual immunotherapy plus chemotherapy combination, which is much lower than what we see with a Pembro plus chemotherapy combination reaching OS of around 20 months. Similarly, with the Checkmate trial, a combination of Nivo plus EPO plus chemotherapy gave a OS of almost around 15 months, which was updated 2-year follow-up, remained at around 15.8 months. One thing is more important, that as compared to Nivo plus EPO, where almost 22% of patients discontinued treatment because of safety side effects, it was a little lesser with around 15% in this combination of Durva plus tremelimumab. So if we look at this, as we have seen in squamous histology also, there is nothing much to compare between these two trials, and the results are not as good as we would have expected, and the OS was pretty 10.4 months in the Poseidon trial, and in Checkmate it was around 14.5 months, which is what is seen in squamous cell histology with any immunotherapy combination which we have available. So the authors concluded that in the phase 3 Poseidon study, first-line Durva plus tremelimumab plus chemotherapy improved PFS and OS versus chemotherapy alone. The PFS hazard ratio was 0.72 and the hazard ratio for OS was 0.77. And the survival was more prominent in patients with adenocarcinoma histology. So they proposed that it could be a potential treatment option for metastatic non-small cell lung cancer. So here at this World Congress on Lung Cancer, they will be presenting an exploratory analysis for OS outcomes in patients with STK11, KEAP1 and KRAS mutation, which we know are inherently resistant to all chemotherapy as well as immunotherapy. And it will be interesting to see if some of these combinations do good in these resistant subgroups. And recently we had the center which are long awaited opened in Mullanpur, And we'll be happy to host you there for the next academic session. Thank you.
Thank you, Dr. Alok. Now we move on to our next session, which is sponsored by Roche. This is going to be a panel discussion. So I would like to invite our chairperson, Dr. S.H. Advani, Director of the Department of Oncology at Jaslok Hospital. So will be joining online, and he will invite the moderator for our session. So I would like to invite Dr. Ullas Batra, who is a senior consultant medical oncologist and the chief of thoracic medical services at Rajiv Gandhi Center Institute, Cancer Institute and Research Center, New Delhi.
Good evening. Looks to be a very sedate kind of atmosphere right now. I think needs some amount of, good entertainment to wake everyone up. So Dr. Advani is online right now, or can I start? Okay, fantastic. So this is the first time, I think, in many times that the session has started early, and I don't know the reason for that. So my panelists were Dr. Kumar Prabhash. Kumar Prabhash is not there right now. I think sir has got some health-related issues. So Dr. Nandini Menon will join on behalf of Kumar Prabhash, and Nandini will give double the dose of entertainment which Kumar was supposed to give. So Nandini, welcome, please. Dr. Deepak Kopaka, Dr. Samir, and Dr. Rajat Bajaj. And please be aware, are there any residents over here? No residents. All are residents only. Any residents? Fantastic. I think we should call you guys over here now. You guys will be asked questions left, right, and center. Because this master class is supposed to be for residents. They're not supposed to be for the consultants. Okay. Any more residents here? All young people. Who are these young people? Oh, all are consultants. Wow. Great. Yeah, sit. Rajat Bajaj is not there? Rajat is not there. Okay, fantastic. So we are asked to, I've been asked to moderate about optimal sequencing of TKIs in ALK positive non-small cell lung cancer. And my first reactions on optimal first line therapy in ALK positive non-small cell lung cancer are like this. This is a non-small cell lung cancer ALK positive patient who is looking at various options that we have right now. You have crizotinib, ceritinib, alectinib, Lorlat. I'm not supposed to utter the L word in this symposium, and I'm not supposed to utter the A word in the next symposium, which I'll be conducting for this thing. And as usual, we have reserved the best for the last. Rajat is joining us over here. Rajat looks like a real consultant, And Nandini, see all ties and all everything here. So we have crizotinib, ceritinib, alectinib, lorlatinib, brigatinib, chemotherapy, maybe some chemotherapy, immunotherapy also. And definitely we are confused by too many choices that we actually have here. My subsequent reaction on ALK positive non-small cell lung cancer is like this. It's all a matter of perspective. There is no real answer. So this may be 4 for some people. This may be 3 for some people if you are on that side of the road. And as usual, the truth lies somewhere in between. So we are not going to pass any judgments on what is the best line of treatment for ALK positive non-small cell lung cancer. We're only going to discuss what exactly in various situations, what is right, what is wrong, and things like this. So let's start with a case scenario. We have a 50-year-old woman who has no history of smoking. She comes with a history of breathlessness and cough for 3 months. CT scan shows solitary tumor in the left lower lobe and a moderate ipsilateral pleural effusion. Histopathology reveals moderately differential adenocarcinoma. EGFR wild ALK positive by IHC. PET CT scan showed lung carcinoma with pleural effusion. CNS and spinal mets. This is exactly, you are not supposed to, for all the residents who are listening, this lung carcinoma with pleural effusion, CNS and spinal mets is exactly not the way you are supposed to present when you present your consultant. So this is just for, this is not the way you are supposed to present. The patient was asymptomatic for brain mets. Final diagnosis is NACLC stage 4 ALK rearranged non-small cell lung cancer. So I think this was easy. Let me ask the question to the experts, and I'll start with that side of the expert first. Rajat, what is the incidence of ALK-mutated non-small cell lung cancer in your resident institute and in your present institute and the other institute we're going to head in the next 6 months that I have heard?
Sir, resident institute, I think it's about 8 to 10%.
Okay.
And here also, I would probably say 5 to 7%.
So how does, in Delhi, from Delhi to Noida, the incidence decreases by 2%, is it? How does it happen?
So there's a range, about 5 to 11%, 12% can be the range. And,
okay, so somewhere around 5 to 7 or 8 to 10%, maybe depends on the number of volume of patients that we have and the amount of data that we keep actually. That is also very, very important. Your institute, yeah?
My place, when we analyzed our data, it was around 6%.
6%, okay.
We had 10% positivity.
You had 10%, so we have 8, 6 and 10. And then 12%.
Sir, ours was around 8%.
12, 4, it will be good evens over there, no? Okay. So by and large, what we are talking about is 5 to 8%. And what is the preferred testing method at your center? I'll again, for ALK, again, ALK mutated is a very wrong term. This basically shows that this is what happens when you come 2 minutes prior to the conference and you make your slides in the plane, and there was turbulence, so they didn't allow me to recheck my slides. So this is exactly what happened. There is nothing called as ALK mutated non-small cell lung cancer. You have ALK rearranged or you have ALK amplified lung cancer. There's nothing called as ALK mutated lung cancer. Okay, so yes, I think we can start from you. No, we can start from you. Yeah, sure. You have the mic. Yeah. So how do you test? Okay, just 1 second. Huh? I'll ask the residents there. This is a master classes for them. Come on, I'm going to make a consultant. So how do you guys test for in which institute and how do you test for ALK in non-small cell lung cancer? Kumar is not listening to this, no? So it's okay. Kumar fell sick before listening to all these rubbish questionnaires that I'm going to say. He fell sick before that. So how do we guys test for ALK in our practice in your institute? IHC. And if you have an IHC positive, do you confirm by FISH or do you confirm by NGS? And how do you go about that? You confirm by FISH. Fantastic. So Rajat, we have the young crop of generation who says you do IHC and you confirm by FISH. What would you do?
So there are 3 methods of doing ALK to find out whether the ALK is gene rearranged or not. One of the methods is IHC, which is not exactly looking at the gene rearrangement, but the protein expression.
Okay.
But that is the central dogma that we know. And the other is NGS and FISH. And if the ALK comes positive by either of them, then it is taken as positive, and it is not to be reconfirmed by any other test.
So ALK IHC standalone is good enough for you. If it is done by Ventana D5F3, it is exactly right. So Nandini, at your institute, what do you do, guys? You guys do?
Same, sir.
So do you guys, and you guys also, do you confirm, Deepak, do you confirm by that or not?
No, sir, we are not.
You're not confirming?
IHC is enough.
IHC is enough. 5%. So 5.6%. Okay, 5.71 was Chetan Bhagat. Okay.
So, coming to practice, what we routinely do is we predominantly see if the patient is symptomatic or not. At least if the patient is symptomatic, when we are doing TTF1 itself, we ask for an ALK IHC. In other patients, what we do is we send for an NGS, and the platform where we are sending, they're doing an RNA-based sequencing. So we are doing NGS, we're not doing IHC.
You're not doing IHC. Fantastic. So how much time does the IHC report take, Rajat, for you?
2 days.
2 days. So, Nandini, your Tata?
3 to 4 days.
3 to 4 days. I think 2 days or something. Okay, I'll come to ALK and IHC versus NGS versus FISH. So, but this is what Rajat said was absolutely right. If you have an ALK IHC positive, there is no need to confirm it by FISH. This was happening around 7 years back, 6 years back, that we used to confirm. There was a study in Tata, there was a study in Delhi, which is with us, which basically said there was a 98% concordance between IHC and FISH. At least all FISH positive are IHC positive, or IHC positive may not be FISH this thing. So that brings me to my favorite question, which I always ask in my panel discussions. What about patients who are positive by IHC and negative by FISH? We'll start with Nandini.
Still treat them with ALK.
You will still treat them with ALK. No chemotherapy? No KN regimen? You know what is KN regimen, no? No. KN regimen is Kumar Naronoha regimen, the very famous TA, the Tata regimen of chemo plus TKIs.
Not for ALK inhibitors. We are not using it.
Not for ALK. Why?
So right now we have data for EGFR, so we're using
Okay,
that.
fair
For
enough.
ALK, we've not started.
Can someone please switch off that light? It's coming into the way. Can someone please switch off that light, please? Okay. What about this? Positive by IHC, negative by FISH.
Treating with
Treating the ALK
I may do
inhibitor.
NGS. Just
You may do NGS. Okay. What about you? And do you think it's a relevant problem in the clinics that we are saying? Do you think it's a relevant problem?
we are not checking this, but again, if it's ALK positive by IHC, we don't usually do FISH in our practice.
So
But
it's an IHC positive. You have tested. The patient came to me for second opinion.
has a FISH report and then it's negative.
Yes.
There's a conflict here because the data from our centers, both from Tata and from the North, are told that there is response either on which, whether it's positive on IHC or on FISH. The data from the LX data, again discussed by Tony Mock et al., they told that patients who are FISH positive and IHC negative did respond to TKIs, but other way around, patients who are IHC positive and FISH negative didn't respond.
Absolutely right. And Rajat is there with a mic up his hand.
So I will like to start these patients on ALK inhibitors, but be a little cautious with them and probably have an evaluation early on, probably 1.5
Absolutely
to 2
right.
months to see whether exactly it's working or not.
These people, ALK inhibitors are still better than chemotherapy, but they are not going to do as well as your normal typical ALK inhibitor is going to do. The KM's curves were both less in the Electinib and this. This is our data which we compared IHC versus FISH, and this is a reality. Around 25% of people who are IHC positive or 14% of people in the LX trial, 25% in our trial will be negative by either NGS or by FISH. So, ALK by IHC, I'm a big fan. We also do NGS for everyone. Why I do ALK by IHC? It's easy, it's cheaper, it's rapid, and it's a no-brainer. Any Tom, Dick, and Harry or Lars Batra can interpret an IHC. It's all brown shape which we have over there. You want to ask some question?
Now, preferably, sir, we are doing NGS. Cost is not been so. So, IC was asking for some specific group of patients or for all patients.
So, what we do in our institute is that we do EGFR separately by RT-PCR. We do ALK separately by
You
IHC.
are ordered NGS for patients.
So that's what we do. We do NGS for
patients who are having aggressive disease.
I totally agree. That's what I'm telling you. It is difficult to, NGS is very observer dependent. NGS will depend on cellularity. Sometimes your fixation is not right. And IHC is a very simple test to do. I mean, I am not willing to let go of IHC in my clinical practice till the time in my clinical setup, they are absolutely okay. What we are going to do is we are going to prospectively see the concordance of ALK by IHC and ALK by NGS. If in next 200 patients, my pathologists are okay, they're not missing anything, then only I'm going to go ahead and remove ALK by IHC from my clinical armamentarium. We get ALK by IHC report in 1.5 days, EGFR report in 3 days time. You can start the treatment for the patient, and it's because we all send sample to our own lab, it's very cost effective also. So that is the one which we are doing. Yes, Rajat.
Yes,
Have you observed any discordance?
Yes,
in
we
the
have. Yes,
treatment
we have.
patterns with IHC?
Yes, we have. So we have had people who are ALK positive, FISH positive, NGS negative, because there are different variants which are there which may not be picked up on the NGS. Again, ALK is a protein, very easy to do. Anybody and everybody can actually do an IHC. You can interpret the reports very, very easily. NGS is typically observer dependent. Your person, you never know how is good or how bad, how much is the tumor cellularity, whether they're able to extract the DNA or not, whether they do DNA and RNA or not. So simplify, make your own protocols. So our panel, what we call is we typically call as a lung cancer smart panel. I think Mansi is there. We guys were both instrumental in making that protocol. As soon as the patient gets IHC, we get a PDL1 done also with that, whether squamous or non-squamous. Once we have an adeno or a non-squamous with, or a non-squamous with a non-smoker or a squamous with a non-smoker, we order something called a lung cancer smart panel. In that smart panel, what we do is EGFR goes by PCR. The report comes in 3 days. ALK comes by IHC. The report comes in 2 days. I am reasonably satisfied. If both of these come negative, I put the patient to chemotherapy. If then also, and I do not start immunotherapy then and there. Immunotherapy, I'll start in second cycle. So it's a very cost-effective, patient-friendly protocol that we have made, but then we have an advantage. It's an in-house thing. We don't have to send by coupons to 2 weeks and stuff like that. But if you are not very sure of your NGS lab, please go ahead and do an ALK by IHC separately. That's my master class tips which are there for ALK for you. Yes.
Tissue adequacy will be the issue.
Tissue adequacy, you'll be easily able to do IHC.
But for NGS,
See, generally there is, so again, it's some benefit of being in a typical tertiary cancer center. Tissue, I don't remember has ever been an issue for us in the last 2 years now. Liquid biopsy for ALK don't. Any fusions for NGS, yes. But again, so liquid biopsy, again, this is again a very, very important thing. Liquid biopsy, if you are looking for a DNA-based mutations, yes, very good. But if you're looking for an RNA-based fusions, I would be very, our experience with liquid biopsy has been terrible. We are going to miss at least 30 to 40% of fusions. If it is there, it is there. If it is not there, please don't go ahead and treat your this thing. So again, if you have a high volume of number, if you send a particular thing over there to one particular lab and tissue is not an issue, I will definitely do an ALK by IHC, cheaper, faster, no worries with that. And you can actually start the treatment as early as possible. That's my take. That's what we are doing. Yes, Rajat, do you have a point?
I completely agree. I've had 2 patients where NGS came out to be negative and IHC came out to be positive. And IHC was not done at the center that the patient came from. We did the IHC. So I always do a separate testing for EGFR and ALK. And because if you're missing ALK, if you're missing EGFR, eventually as a clinician, you tend to think that you've actually had a very disappointing,
Again,
clinical
I will give an example. There was a patient who was referred from Gujarat to us. The patient's EGFR, ALK, ROS, everything was negative. I only counseled them for immunotherapy. Patient was admitted. My resident and my consultant saw that the tumor cellularity was only 10%. Now, how many medical oncologists see that? Tumor cellularity was 10%. They did NGS. Nothing came. We got a repeat biopsy done. We got an ALK by IHC and NGS done again. It was NGS positive. And why I am stressing so much is because the survival difference between chemotherapy and ALK is huge. So you're looking from 9 months to at least 6 years, 7 years also with that. So there is no harm. Again, if tissue was an issue, obviously go for NGS. But, NGS lab, I'm not sure how many diagnostic people are here. NGS reports, please take them with not a pinch of salt, take them with a handful of salt, especially if they're negative. If they're positive, fair enough. Negative, please be there. Simple tests like IHC should never, ever be this thing. Forget that, I'll tell you. There was a patient who was referred to me by someone from outside, ROS positive. Fine, fair enough. ROS positive, patient on crizotinib, did not do well for 3 months, 4 months. Given crizotinib, given ceritinib, given lorlatinib, was basically came to me for opinion regarding entrectinib. I said, fantastic. Again, busy. We didn't see. Told them, nahi milegi. It was only in first year. Then again, my resident saw. ROS was by IHC, was not confirmed by FISH. So as and how medical oncology field is growing, for all the people sitting over here, because you are the one guys who are going to treat us, please read your molecular pathology report properly. There are too many things which we need to observe in that. And everybody should actually go ahead and meet your dry and wet pathology lab, see how things are done, read in between the lines. That's the point that I would want to make. Okay, I think MRI brain will go for this. So let's start with, Roche people are getting restless on this now. It's a Roche sponsored symposium. So we are going only on IHC. So Nandini, we'll start from you. What are the key factors that you consider while selecting the first line treatment? So patient comes to you. I think he said, about symptomatic or asymptomatic one. What comes to your mind when you start a patient on ALK, once you see an ALK positive, whether by NGS or by IHC?
So the first thing we would, as said, symptoms and also the presence of brain mets, CNS mets.
So one is symptomatic, one is brain mets. Brain met is supposed to be spoken in the next session, not in this session.
So especially because in our setting, not all patients can afford the newer generation. So we would especially note brain mets because we can counsel them accordingly for.
Fair enough. So brain mets, then the symptomatic. Anything else? And how to decide about various generations of inhibitors? That's what I want to bring on to be.
So if there are no other limitations, then we would prefer a second generation.
You would prefer a second generation ALK, and not because it's a Roche symposium.
No, not because it's
even in the Pfizer symposium, you will prefer that. Yes. They will not invite you. Okay,
so that is commonly used. So we've not yet started using.
Fair enough. How would you decide? Yes, how would you decide? I'm getting confused between the your names, actually, two of you. So that is why.
So efficacy and presence of CNS mets definitely, and finances.
Okay, so finances, CNS mets, efficacy. Any other point?
Start with finances.
Start with finances,
Start with
okay?
finances.
Oh, it is always there. It's always there. But again, for my this thing, the finance of lorlatinib and electinib is absolutely same. Bang on, 1.2 lakh rupees.
If patients are beyond serotinib, our finances are anything beyond serotinib,
Okay.
and that's where actually it will boil down to the performance status and
Okay, performance status was a fantastic thing. Yes, Rajat.
Same. I think every point has been covered.
comorbidities.
That is what I exactly wanted, because do not ever forget the comorbids now. In times to come, and we will see in this symposium and the next symposium, that the comorbids are really going to make a hell lot of a difference. So I think a CNS efficacy, long-term safety, resistance pattern. What about resistance pattern and after progression? Any later options, whether they're available or not? Does it make a difference? What after? You have an B option after electinib or serotinib. Do you have a B option after lorlatinib? Is that a concern?
Yes.
I'll invite you for that next session talk also. Okay, we will see.
So definitely there is a concern. If post lorlatinib, there is nothing much which is there right now, and we are also a little blank regarding the PFS of lorlatinib. If the PFS was like Flora, if the osimertinib PS was way high as compared to the others, it would have been
PFS is going to be, even if it's a Roche symposium, PFS is going to be good. It's going to be mouth-watering PFS. But there are a lot of other things
that
also.
We'll have to see.
Yeah.
Another thing which I would like to emphasize is where is the patient, what is his occupation, and how, because eventually it's more about the adherence on the treatment rather than giving the best PFS.
Fair.
So that is one thing which will have to be clear when we are assessing these patients for one of these.
So absolutely right. I think that is why I put the caption over there. Follow your heart, but use your head too. Don't break off the branch in which the girl is sitting. Else you will have a wonderful things over there. So this is the currently approved first line treatment for advanced non-small cell lung cancer, crizotinib, and I said over there, the median PFS with electinib till now has been 34.8 months, with brigatinib 29.4. With lorlatinib, it has not been reached, but it is going to be higher. I mean, everybody's feeling it to be at least 42, 43, or maybe even more months over there. The OS data, 5-year data of 62.4% survival. With crizotinib, you have a 57.4 month survival. That was, and that is exactly the point why I don't want to miss out on an ALK. Because, even with a simple drug such as first generation TKI, you are going to do great. So a 5-year survival rate of 62.5 versus a crizotinib 45.5 is absolutely fantastic. I mean, again, just see, crizotinib is 45.5 and it is in the lesser one. 5-year survival with immunotherapy, pembrolizumab in the first line is 32%. And pembrolizumab is the king. And here crizotinib is still down, and we're looking at electinib because that is the amount of, progress that actually has been made. So ever since electinib has come in the first line 2 to 3 years, Rajat, how has the impact or usage of first line electinib or your patients' lives been?
It has been very good. It is a well-tolerated drug. That is also a very important aspect. He also very clearly mentioned that the patient has to adhere to that drug. If the tolerance is not good, then one is wary of it. Then, of course, the very robust PFS that it has. So, and the response rates, the intracranial responses that it has. So, to me, electinib is a very good drug, and it should be one of your first choices.
On a scale of 0 to 10, if you see 10 patients in one day of ALK positive non-small cell lung cancer, okay. I mean, that's for Nandini probably. I'll put that for 8 for you. How many do you give serotinib? How many you give electinib? How many you give lorlatinib?
Cost is not an issue.
No, not for you.
No, so
for the patient. Generally, in your practice, what has been your practice actually?
Electinib. My go-to choice is
your go-to choice is electinib. Fantastic. What about you?
On an average, at my practice, we see around 20 new lung cancers a month. And currently in our team,
my heart skipped a beat when you said 20. I said
lung cancers a month, and of which again 6% is our number of ALK.
Okay.
I remember not more than 5 or 6 patients on electinib.
Okay, but do you discuss electinib with your patients now, or it's only look at them and say crizotinib or serotinib, whatever?
Options again, they decide between serotinib or
like how we discuss, immunotherapy in small cell lung cancer. हाँ एक दौर नहीं दी भी दवाई है, but आप छोड़ दो. And then you discuss pros and cons, not willing.
I strongly
okay, fair enough. It comes on to your discussion. Fair enough. Okay. What about you? How many in this thing?
Sir, I have used lorlatinib in my center when there was a phase 4 trial going.
Yes.
I've seen the patients closely. So
but that was second line, second or third line.
Yeah.
I also had the same trial.
It's not easy drug to handle. So main concern is neurocognitive dysfunction.
Okay.
So it was almost 20% in the trial, and I think that was less because the many times neurocognitive dysfunction mild patient may not report. You have to take it
from there. Yeah.
So this must be more. So, and dyslipidemia, it's difficult to handle. Each and every patient develop hypertriglyceridemia, hypercholesterolemia, and each and every patient requires it to be monitored. So, if a drug which needs to be given for 3-4 years and with such a monitoring, it's always difficult. So
We
it's
will
better
come
to
to
have a
that.
drug
We will
which
stick on to Alectinib now. Lord Latinib we will discuss in the next symposium.
Alectinib is definitely very easy to handle.
So
Just
again,
give it
out of the last 10 patients, how many have you discussed Alectinib? So the choice is between all patients. The choice is between first and second generation or second and third generation now in your practice.
So, sir, second generation from the
Okay.
I will go with Alectinib.
Okay. Nandini? The ocean of ALK positive non-small cell lung cancer.
Sir, despite being the ocean, our patients, we always discuss alectinib and other second generation, but the practical real story is getting crizotinib is often a challenge.
Okay.
So for the significant number of patients from the general category, they get crizotinib from various support programs through NGOs. Some of them can't afford to buy, but maybe around 10 to 15% would take alectinib in the first line setting. Maybe another 20% would take ceritinib. And the rest of the almost 60 to 75% will.
So this is going to be something which I'm going to show you our data. This was crizotinib in the blue. Year-wise, crizotinib for us is now coming down. This was ceritinib, and I hope Novartis is not seeing because the numbers are very, very low. We also had a first-line trial going on for ceritinib, so that is why the numbers are a bit high. I think Rajat was there when the trial was going on. And this is alectinib, which is almost going on over there. So in the last, and this number has from 10, it has already become 16 or 17 this year at least. So I think my practice has actually significantly changed. It is now becoming more of a, the discussion that I'm now having is between second generation and third generation, as you rightly said. It is not actually between first and second. First is going to be in a passe. And this usage that was there. So how does the safety and tolerability profile of alectinib compare with other ALK inhibitors? I mean, if you guys have used, what has your experience been? Anything of any peculiar side effect that you have encountered? And I'll tell you one peculiar side effect which I never thought we would have encountered. We got in 3 patients. I'll tell you after that.
We had one patient with pneumonitis and one patient with edema. Really,
edema. Okay. And how do you treat that edema?
We've given diuretics in the patient. It did respond in that one patient which we had.
Okay.
Pneumonitis, we started at 600 mg BD. We given steroids, tapered it down now to 300 mg BD.
Okay. Anything, Rajat or Nandini, anyone who has a very peculiar side effect?
No one too good side.
So we had 3 patients with renal dysfunction. In fact, one guy on 600 mg BD went up till 4.5 he came with. He went on to 6.8, required one amount of dialysis. The first thing I saw was whether bisphosphonates was given or not. It was given. So I thought it must be bisphosphonates. Re-challenged. Again went up till 3.4. Put it down to 300, 450 mg BD, become okay. The second patient right now is on 1.7 creatinine. And third patient also had 2.5, 2.8 creatinine. It is basically coming down now. So it is, I mean, renal dysfunction is something which we have to encounter very, very, very importantly actually over there. So does the safety and efficacy data, I think you said it very rightly, 3 years you have to give hypercholesterolemia. Does it really make a difference? I mean, when you discuss this with you, so how do you take a call between a safety and the efficacy data? I mean, Nandini, how would you, explain about the safety efficacy to a patient?
Definitely important, and especially in TKIs, because they have to be taken daily. And if there are a lot of toxicities, patients are not going to be compliant. So even if there are good efficacy in trial setting, we might have poorer in the real world setting. So we need to, that plays an important role, and we have to actually really counsel the patients well to maintain the compliance and report any new toxicities immediately.
Okay.
For alectinib, we have OS data. Lorlatinib, we don't have any OS data. And what I remember in that trial, there was no possible.
No, but again, let me come back. Alex, you didn't have the OS data 2 years back when I have shifted all my practice to alectinib. Although the difference was that.
But sir, now the comparator is already having.
The comparator is already having this thing. Okay, fair enough. Okay, fair enough.
So for me, it's more about comorbidities, and see, effectively finances in this for alectinib versus lorlatinib is not going to be there. So it's predominantly about where is the patient, young, fit patient who is not really having any neurocognitive dysfunction. We're expecting that's not going to happen in day-to-day activities. I prefer to give lorlatinib if the patient has
fair enough.
brain metastasis.
Fair enough.
And patients who are usually in the 40s with comorbidities and with or without brain metastasis, prefer to give alectinib. Okay.
So I think again, there was some time of my training that I did in MD Anderson, which basically changed my outlook towards life. We all talk about the PFS and the OS and everything, but the comorbidities and, patient has to take there for 3 years or 4 years really has to be, kept into mind actually over there. So Rajat, this is for you. What would you choose?
So which one of this is alectinib?
Which one of this? Money, luck or love? Money, you have lots. Love, we will not talk about right now.
So coming back to the question.
Coming back to the question.
easier.
So you all know what would you choose actually now over here.
So of course you're saying that we don't have to talk about the next session, but then we can't help but talk about it because we're talking about one over the other. So if we have a drug which is first line PFS of say about 32 months, and then we have a subsequent drug which can be given in the second line.
I will come to the subsequent lines of treatment. I am coming to subsequent lines.
If we have a PFS of about 12 to 13 months there as well. So if we are giving the second line drug in the first line, we have to have at least a PFS which will quit the PFS of this one, first line and second line.
So
together.
what PFS of lorlatinib you will switch? I wanted to ask this question in the end. Let us say, 34.8 is alectinib. What PFS of lorlatinib? 47? Will you shift?
No, so if it is solo one, 56 months, I'll
56 months. The guy wants everything. He doesn't want money, luck, love. He wants all three of them. He wants loads of money with loads of luck and love. So khair chodo. We will talk about that later. Okay. So this is our data actually of crizotinib, and I was inspired by Kumar. I thought Kumar would be there. We had a median PFS of around 11.8 months with crizotinib. Our median OS with crizotinib of 78 patients was actually 33.5 months. And this is starting from 2015 when we didn't even have second, third generation for almost everyone. The best part about here was people who had brain mets at diagnosis. This was 8.8 months. Brain mets absent. This is brain met. Okay, out. I don't know. So brain mets absent was 11.8 months. Very importantly is the one graphs on the below. If you had TP53 mutant, so we went back and did NGS for everyone. If you had a TP53 mutant, the PFS was only 6.2 months. It was 9.1 months. It was unmutated. The median PFS in ECOG PS 1 to 2. For me, performance status, and this has been shown in many papers, that performance status 1 or 2. We always tell patients we have got people out of ventilator, out of with alectinib and stuff like that. But the bottom line is that if you have a PS of 1 to 2 months, you're going to do for 11 months. If you're going to have a PS of 3 to 4 months, it's only going to be PS of 3-4 is going to be 3 to 4 months only. So PS was very, very important. Median OS with PS 1 to 2 with crizotinib was not even reached. So if you take only the good patients actually over there, and if you are TP53 unmutated. So again, I agree with everyone who wants to do NGS. You're going to get more and more. It's more of a predictive marker rather than, or a prognostic marker rather than being a predictive marker actually right away. Now let's come to alectinib. We have a data of around 41 patients in the first line over the last 2-3 years. 1 year, 93% people survived. 2 year, 87% people survived. 3 year, 80% people survived. And we are not talking about stage 1 and stage 2 breast cancer. Median PFS, again, 1 year, 2 year, 3 years. Again, performance, PS was something which was bad. If you have a bad PS, but the numbers were small in this. So again, the same data could be replicated in the clinical scenario also with alectinib. To me, a wonderful drug. A fantastic response rates, a good brain penetration, a good tolerability toxicity profile, and it's a good drug. Lorlatinib also is a great drug. I'll come to it in the next session. Yes, Rajat.
So I completely agree that this must be the data, and we know that it's a good drug. But one point I want to bring across, and I want to ask others also, is that I've seen that 2 of my patients didn't do as well on alectinib. We start alectinib and tell them that is going to be very, very good. So, these were the patients who were having brain metastasis upfront, and they were asymptomatic brain metastasis, but the volume of disease was too high in the brain.
So again, volume of disease high,
and patient was asymptomatic, but alectinib did not have a very good.
So Rajat, the response rate is 70%. Not everybody will respond. The PFS in a poor PS is bad, with liver mets is bad. It is the biology of the tumor which actually is very, very important. Maybe if you do NGS, you will find this P53 or a PIK3CA mutation also. So that is also positive. So that's why if you do NGS, you will find out more and more mutations which will tell you whether to give this or not.
So what we do RNA-seq in patients who are affordable, but RNA-seq is another variable which comes in as the variant.
Variant, yes. So,
Variant 1, variant 3. This is what we've come across. We've not seen variant 2 much in fact. I've not seen even one right now. So again, that is one factor where alectinib data, this data says that irrespective of the variant, there is benefit and there is no difference. Whereas with lorlatinib, they say variant 1 outperforms brigatinib.
we will talk about variants in the next session. I thought I had to, after alectinib, I have to talk about lorlatinib. I have to tell variants about that. I'll show you our data also in variants, and I will show you about the variants in that. But what you are saying is right. Again, people who do NGS, how many times are your molecular pathologists reporting variant V1, V2, V3, or V5? Not many. I can show you umpteen number of reports. They will just write ALK rearrangement positive. That's it, and that is all what the medical oncologists want to see. Also, you also don't want to see V1, V2, V3. So it's going to come. I will show you the data about the variant thing also over there. This was second line data. Although this is not a point, alectinib was doing very, very well. It's 13.8 months PFS. I don't know. Normally it's 6 to 7 months PFS. Small numbers over here. This is there. So now let's come out to what about plan B? Is treatment after progression a concern? With alectinib, so this is almost like if you have plan A as lorlatinib or alectinib, do you have a plan B with Rishabh Pant and Hardik Pandya and people like that? So I will show you a case over here. And first I'll ask you a question, and then there's one case which is very interesting which has come to our clinic. So do you, Nandini, do you rebiopsy after progression on alectinib? There is a supraclavicular lymph node.
So we would like to.
You would like to do. And then do what?
So then look at the mutation profile.
So you will do an NGS. Fantastic. Absolutely right. That is why I do it. Foundation medicine free. We're free sale season. We'll definitely do it. Yeah.
So yes, a rebiopsy, or otherwise we can do a CTC DNA as well.
So you will either send a liquid biopsy or this thing. Fantastic. So everybody wants to do, especially because it is free. Even if it is not a free, we will do. So I'll just tell you a case once again. A 55-year-old male, ALK rearranged non-small cell lung cancer, stage 4. See, now this is a slide which has been made by me. So that is ALK rearranged non-small cell lung cancer. Received alectinib as first line. It was PD after 3 years. A repeat biopsy was done, which basically came as adenocarcinoma, and an NGS was sent. Now, NGS basically sent two things. One, the EML4 ALK fusion was already there. It also said that there was an ALK mutation with 1171I. L117I was the mutation which was there. The moment you get this report, what do? You send the patient out, say you do a CBC and come back. I'll go to Google. That's what I did. Or maybe, I have the advantage of a team. So I'll say, आप जरा 2 मिनट में नीचे होके आता हूँ, आप जरा वहां जाके दिखाइए. So we tell Mansi or Amrit, do this. So what we did this. So we've searched this. Now, this is a mutation, particularly this mutation is a common resistant mutation in ALK positive non-small cell lung cancer patients, and it is sensitive to seratinib. So now you have this patient, you have taken your 5-minute break. Patient says, CBC, sir, ye ho gaya, LFT, sir, ye ho gaya. Now tell me, I have to go to Nepal. This is a Nepalese patient. What will you do? So alectinib, symptomatic progressive disease, what would you do? We'll start with Nandini. Most difficult questions to the gold medalist people over there.
So start on seratinib.
You will start on seratinib. Fantastic. You will not start on lorlatinib. On basis of seratinib. Fantastic. I had already given till the time biopsy report came, I had already given 1 cycle of chemotherapy to that patient actually, but it's absolutely okay.
So I think lorlatinib works in most of the variants. So that is also option, but if the patient is not opposed.
So that brings me to the first thing. Why did you get a biopsy done?
So sir, means better to have our own experience also.
Fair enough.
It was
Nand-
G1202R, then seratinib would not.
Yeah, but you didn't know that, no? So what he said was absolutely right. Lorlatinib is a designer drug, third generation drug, will work for everything. Then why do a
There can
biopsy?
be other mechanisms of resistance as well. At least we know that there is no other mechanism of resistance. I think if I'm not wrong, this mutation is taken care of by lorlatinib as well.
Yes, so this will respond to seratinib, it will respond to lorlatinib also. So what would you now? Lorlatinib. Then why did you get a biopsy?
Setting the stage for the next.
Why did you get the biopsy done? No, lorlatinib first line they want. Why did you get a biopsy done? Foundation, just because it was free.
So the thing is that there can be other mechanisms of resistance as well. At least we find out that there are no other mechanisms of resistance.
Okay, fair enough. What would you do?
I would do seratinib. I'll try to introduce as many things as possible. Then I know.
Fair enough. So I mean that is what exactly we did. So by the time this was a progressive disease, Somebody just fell off after saying Serotinib. Is it money diya Pfizer ne or Roche ne? Agla session jo hai wo Pfizer ka hai. Where does Novartis come into the picture? Roche guys must have fallen down somewhere. Okay, so he had already got one cycle of gem carb. Okay, this guy was squamous cell to begin with, and we got an ALK done, non-smoker. On biopsy, he came as adenocarcinoma. We got an NGS done, came as this. We had already given him one cycle of gem carb. So then he was PS0 because of the cost reasons and everything, and I wanted to try and wanted to have a publication. That is why we gave him Serotinib. He probably is going to have a PET scan this week. If any one of you is there, is going to be next Saturday meeting with Dr. Advani series, I'll be absolutely happy to tell you about what happened to this patient. But I'll be absolutely okay if somebody gives Lorlatinib also. Yes, Rajat.
First scan.
First scan after that. The patient, I just did a teleconsultation, is absolutely okay. So there is a role of CGP. I think, if you're going to go the way, and I told the patient, and we took a signature from the patient that this is not a standard of care. Since you are okay, we are going to give you that. And there is no harm in doing that and reserving a lecture over there. So would you guys, so let's say, okay, fine, fair enough. So what does the optimal sequencing look like? You want to go with Crizotinib, Serotinib, then Crizotinib, Alectinib, and then Lorlatinib, or you want to start with Alectinib and Lorlatinib, or you want to start the other one? How do you, final words from you?
Alectinib followed by Lorlatinib.
Alectinib followed by Lorlatinib.
As of now. But
as of
one
now.
caveat.
In the 15 minutes from then, you will change over to Lorlatinib followed by chemotherapy.
Only one as of now is that if the patient has got symptomatic brain metastasis, if the patient is getting radiation done for brain metastasis, probably from now on my practice will change to the other molecule. But for otherwise, Alectinib followed by Lorla.
Fantastic.
Till the time we have a PFS for.
Fantastic.
Again, it's patient-based, both Alectinib and Lorlatinib. Alectinib, then Alectinib and Lorlatinib. Lorlatinib, I'll wait for some other time.
The panelists in the next session, Akhil, you're going to have a tough time, no? We will have to defend all these things. I'm going to call them over there. Okay. Yes.
If the finances are issue, then
finances are same for everyone.
No,
finances are exactly same for both. Okay, Serotinib also is there.
If the patient is not affording for Alectinib, otherwise Alectinib, Lorlatinib.
So if there is no financial cost issues, and Alectinib and then Lorlatinib in second line, so that there's an option available.
So you want to have a plan B.
And if in real world scenario, our patients usually end up on Crizotinib, Serotinib, followed by Lorlatinib.
So what, if I'm not wrong, the data that you guys have submitted to JTO CRR also says 34 months, I think, for the Crizotinib. But I think it's a very, very, very nice thing to say, lung cancer from 3 months to 9 months with Pemetrexed, PEM maintenance, then to around, with the Crizotinib, and now with Alectinib, Lorlatinib, you're looking at 7 years and 8 years. In fact, I just had a patient who we did a teleconsult yesterday, which was a shocker for me. Lung mass, bilateral lung nodules, and a C6 lesion. We gave Alectinib. Patient responded very well. He has gone to US because he stays over there, taken an appointment from the MD Anderson, some thoracic surgeon. He says, I'll remove of the lung in the first scan only. Lobectomy, and he will do radiation to this in the first scan only. So I think the more you give Alectinibs and Lorlatinibs and good TKIs, more the concept of oligopersistor, oligoprogressive, maybe surgery, maybe radiotherapy for them will come, and it's going to be an absolutely fantastic way to treat our patients. The guidelines say both Alectinib, Lorlatinib are the one. So with this, I end my first session on ALK, and I would like to end by saying seeing is believing, but the truth depends on your point of view, and the point of view might change in the next 15 minutes. So stay tuned for that. Thank you. Thank you, my panelists. Thank you. I'm the moderator. You're supposed to ask questions to the panel. Okay, tell me. Yes. I mean, I am a very staunch medical oncologist. In the last 15-20 patients with brain mets, so if it is symptomatic, single, patient goes ahead with surgery. Asymptomatic, no role of RT. No role. So what we are now doing is we start with Alectinib or Lorlatinib. We see, I'll talk to you about the next session also. In 3 months' time, we'll do the scan. And I have hardly seen a patient actually responding. And one new problem which we are seeing now with usage of radiation and SRS is radiation necrosis. People are now living ahead for more than 2, 4, 5 years, and you are not able to document whether it is a true progression or pseudo progression. So radiation therapy to the brain, absolutely out till the time it's only in SRS and patient is not on this alectinib or lorlatinib. Otherwise, if only with crizotinib will give that. So single bone mets. So the issue over there is, I mean, this is oligometastatic CA lung. So what I would do is I would go ahead and start with alectinib only because the response, or ALK TKI, because the response rates are 80%. Response rate with our chemotherapy are only 45%. Then after 4 months or 6 months, when the disease has been biologically stable, we have been giving RT as a consolidation RT to both the lung and to the bone, if it's a solitary one. So oligopersistor, oligoprogressor, that concept is really.
Also adding RT after we are seeing a stable disease or CR. And
so I think Tata is also doing a trial right now, and we are also doing a trial in which people who are responded, we are going to give them 2 arms. So one arm, you had a patient like the Gomez protocol, people who have responded, and we give RT to the only that particular site in the lung, followed by continuation of TKI, versus no RT followed by continuation of TKI. So that trial is going ahead both in Tata and with us. We would be giving.
I'm just asking for the bone modifying agents, whether you will add a bone.
We give once in 3 months. More from a very perspective that somebody else will say, "Aapko wo nahi diya." That is why we give actually.
Third thing, sir, is this. In KMH, we seem ki patients also having hyperbilirubinemia. Not very high, but in the range of
hyperbilirubinemia, you should always go back and see the protocol. If it is more than 3 times the ULN and SGOTPT is not raised, you can actually go ahead. So till grade 2, you do not need to decrease the drug. So every time this thing comes, it is on my desktop, the dose modification for alectinib. It's a very confusing thing, but you should always look for hyperbilirubinemia.
Things are persistent, it is not increasing also.
That's okay. You can continue with that. That's absolutely okay.
Dose, sir. We have a JLX data there. They use 300 mg BD.
So the 300 mg BD was used in the JLX trial, in which the survival was absolutely fantastic. I don't advocate using that, but if your money is an issue, you can start with 300 mg BD. But I will recommend to start with 600 mg BD only. We have no data of Japanese. They will do well with S1. They will do well with S1 OX. They'll do well with everything. See, the data about NEG trial with the only TKI plus chemo was 16 months with us. It was 52 months with them. So the Japanese data cannot be extrapolated to the Indian population. We cannot use the data when it suits us. So if you really want to be okay, start with 600 mg BD. Patient has a problem. I have reduced to 450 mg BD in at least 5 patients of the 40 patients, but it's a very well tolerable drug.
Just asking for the purpose of finances, sir. Safety is definitely, it is a very tolerable drug at 600 mg BD also.
Yeah, it's a very tolerable. So the reason for that has been, 1 was liver function and 2 or 3 have been the renal dysfunction that we have got actually. Dr. Advani is there. Sir.
Yeah. Good evening, colleagues and Dr. Ulas. I have been listening to you. Very aggressive talk, and I think that's what really we need to learn. It just shows how in-depth knowledge is there and knowledge is expanding. So today in this session, we are supposed to discuss the sequencing of the ALK inhibitors. And that has really happened because we have so many competitors. And right from the first one, crizotinib, ceritinib, and alectinib and lorlatinib. And all of us get used to it. Initially, we were used to writing crizotinib, and it was so difficult to change anything. But then slowly we have learned how to change. And now that the data is mature, we can really take a decision based on the science and not by what you are used to it. So I think in today's session, you are the moderator and going to moderate on the optimal sequencing of the ALK inhibitor in the ALK positive non-small cell lung cancer. Mind you, this is a seminar from Roche.
Thank you.
Thank you, sir. Thank you, Dr. Advani, and thank you, Dr. Ullas Batra, for the interesting panel. We now move on to the next session. The next session is sponsored by Novartis. It is going to be on capmatinib, the unmet need in MET exon skipping mutated NSCLC. I would like to invite Dr. Ashish Singh, Professor, Department of Medical Oncology, Christian Medical College, Vellore, to give the next talk.
Good evening. So the next few minutes, we will discuss about treatment of MET exon 14 mutated lung cancer. And the disclosure for this session, we know is a sponsored symposium. So we will be discussing about the approved drug capmatinib in India. And as of now, at least I don't think there's any other approved therapy specific for this disease currently in India. So MET mutations, this is not something new. We figured this out long ago in small cell lung cancer, but we didn't know what to do about it. Later on, as and when we started treating more and more EGFR mutated patients, we learned that this is maybe an important mechanism of resistance. And then newer drugs were developed to target this. So we had savolitinib by AstraZeneca, then we had amivantamab, the bispecific EGFR MET. Also at the same time, we have capmatinib and tepotinib just to target this. And it's only more recently we realized that actually this MET alteration could be of many types, could be amplification, it could be increase in gene copy numbers, or it could be an exon 14 skipping mutation. And it's actually the exon 14 skipping which is the main mutation which makes it a driver mutation in a subset of lung cancer patients. So how common that is, not sure if we have proper data from India, but I'm sure it's easy to get it because now most of our panels have MET as part of it. But what we see from the West is about 3%. It could range anywhere between 5 to 22%, depending on what you're looking at. And there is some suggestion that this is possibly more common in older people. Now, per se, whether having this mutation is a poor prognostic feature, difficult to say, because when you see comparisons like these, even though they look like that these people are not doing that great, but in the comparator arm, you have people who may be getting maybe a osimertinib or an alectinib. So it's difficult kind of comparison. But what is interesting is if you see how do we select patients in the clinic. So if you only check for EGFR and ALK, then as by default, you would be offering them based on the PD-L1, mostly chemoimmunotherapy. And so if you have a patient where you have missed this mutation and the patient is on chemoimmunotherapy, how likely is he? What are the response like? Again, the numbers are small. It's the waterfall plot on your screen. You can see that not many patients actually have done well on immunotherapy combination. And even if you look at the tumor mutation burden, the pink, I don't know if you can make out, most of those patients had a higher tumor mutation burden. In spite of that, the chemoimmunotherapy or immunotherapy combination resulted in a PFS of only 1.9 months. So this is something which we make note. Now, so how did this whole story started? So initially, we all know that we had drugs like crizotinib and cabozantinib, and also there's another drug called gelasatinib, and then became capmatinib. So initially, when patients did have any MET mutation detected, either earlier or subsequent course of treatment, they were given these drugs. These older reports show us that their median overall survival was about 24.6 months, which is very good for a metastatic lung cancer, and a median and patients who never had any MET TKI and they did have that alteration, their median OS was only 8 months. So after having established this as an important driver, and after having kind of convincing, I hope I'm able to convince all of you that we do need to find this out, because if you miss it in your patient before deciding first line therapy, there is a possibility that you may not be giving him the best treatment. So of all the available MET inhibitor, why do we need so many? What is the difference between capmatinib and the other available agents? One thing is it's about how specific it is, how selective it is. So so if you see here the IC50, capmatinib has the lowest IC50, 0.6, as compared to say savolitinib or tepotinib. And if you compare that to crizotinib, that's 22.5. So lower the IC50, more selective, less side effects is how you look at it. So as of now, we know the drug has got approval, but we all need to know based on what data, right? So we know in these rare cancers, it's very difficult to do large randomized trial. I mean, many times, even if what we see, all of us are convinced that this is an active drug based on small trials, but they are phase 2. And initially, when Novartis tried to develop this, they decided to try this drug across various MET alterations. It could have been a gene copy number aberration or amplification or mutation. So just focus on the blue part. So they had various cohorts, and the main thing was what is the alteration, and the patient was treatment naive in first line or subsequent lines. So we're going to focus mainly on the cohort 4, 5B, and later on they added on a expansion cohort 7. And all these cohorts had this exon 14 skipping mutation. Being a small single arms trial, your endpoint was only overall response rate, with secondary endpoints being your PFS and duration of response. So we do have good numbers. When I say good numbers, is like if you compare to like for an NTRK fusion or some other mutations, we have 20, 30, 40, 50 patient data. But here it's close to 100 patients by combining cohort 4 and cohort 5B. The striking thing here is that if you look at the median age, is 71 in years. So that's all. I mean, most of these patients are senior people. More than 65 years, if you see, almost 80%. So again, if you have an old person, I mean, maybe it's more likely that this patient may have this mutation. Now, how does smoking play a role here? It seems like about 40% of them had some history of smoking. So, and also another important thing is that this is a mutation which may even be present in squamous cell carcinoma. So some of your centers, when you don't sequence squamous cell carcinomas, that's, I think, is not the correct practice. We should be sequencing every patient except maybe small cell lung cancer. And then if you see in these cohorts, the number of patients who had brain mets was about 15%. And if you look at, does this mutation correlate with gene copy number? Actually, no. The spread was kind of even across low and high. So the kind of treatment these patients had before they went on to this study, the 28 patients were treatment naive, so no treatment. And then for the remaining, if you see, majority had 1 or 2 lines of therapy, and immunotherapy use was used in about 30%. So that goes along with the routine practice of using chemotherapy or chemoimmunotherapy in the first line. The endpoint of the study was response. And if you see in patients who were pre-treated, that is, they were in second, third, or later lines, the response rate was 40%. And which is pretty good, right? We all know what is the response rate of docetaxel in second line. And then if you add stable disease to that, and the clinical benefit rate or the disease control rate goes up to almost 80%. So that was in pre-treated patients. Now, if you look at in patients who have never seen any treatment before, the partial response was 60 to 64%, which is pretty impressive for at par, I would say, with the ALK inhibitor or the EGFR inhibitor. And the disease control rate going up to 96%. So definitely, if I am a patient, I would want to know if I have a MET exon 14 skipping mutation before deciding my first line therapy, because these waterfall plots are pretty impressive for an oral therapy, which is so well tolerated. I'll come to toxicity. And so literally, if you see here in this thing, the number of patients who progressed while taking this drug was only 1 patient in this entire cohort. So now response is okay, but how durable is the response is the next question patients going to ask you. So duration of response. So here, if you see the numbers are 28 and 19, that's because only people who have responded are on this Kaplan-Meier curve. And you see most of them actually have this response going for about a year or so. If you see, that is if you give it in the first line. So the first line treatment naive PFS is 12.58, and for subsequent line patients it's about 9.72, which is compared to any other treatment, even take docetaxel or immunotherapy or even combination chemotherapy. This is probably a better agent to use in later lines. Now, if you see progression-free survival, this is again in patients who were treatment naive and pre-treated, it's about 12.4 versus 5.4. And the swimmers plot here shows you that for people who respond, the arrow marks actually shows you they're continuing to respond, they're on treatment. So again, this is, I would say this is one of the first drugs we have it here, and this is at par with any other TKI which we use it for at least for the first generation TKIs and the second generation TKIs which we have for EGFR and ALK mutation. Now, activity in the brain is something important. We were talking about use of radiation or no radiation. If we have a patient with exon 14 skipping who has brain met, should we be doing radiation? Now, again, if you see these trials did have some patients, and they were like 13 out of 13 patients, 7 of them did have a response. So there is, and if you look at stable disease also as intracranial disease control, 12 out of 13 patients. So the message here is you don't have to jump with radiotherapy, but then the point is because still early days, less number of patients data, not like we're not so convinced as we are with lorlatinib or alectinib. So you should do a repeat scan little early. I wouldn't wait for 3 months. Maybe I will scan it within 6 months. 6 weeks or 12 weeks to make that decision. Now does the kind of mutation matter? The conclusion is no, it doesn't. Whether you have a single nucleotide variation or any deletion, it doesn't matter. So all what I've just explained to you is actually put together and it's published in NEJM 2020. The results they combine the cohorts and when you look at it all together, you expect a response rate in the first line close to 67%. And disease control rate close to 100%, except for that one patient. And in later lines, the number comes down to the response rate comes down to 40%. And the other thing is how rapid the response is. So across these cohorts, when we see that if you define an early response as a response at the first scan, that is at the time of 6 to 7 weeks is when we do the scan, and the number is almost 70% of your patients who are going to respond would respond at your first scan. So that's something which we all can actually hold on, and even in the absence of a randomized control trial, 7 to 8 weeks is not a long time. And we can definitely give this agent and then see whether the patient has a response and then make a call on timing of use of chemotherapy. And then these are the progression-free survival for patients in second and third line. And you see, we already have discussed, this is the published data. Now coming to toxicity. So again, now, I mean, we were all used to thinking that TKIs are less toxic, but we are learning from drugs like lorlatinib, afatinib, dacomitinib that that's not the case. So here, if you look at it, the most of the side effects listed here, if you see grade 3-4 is in single digit, so that's a good news. Peripheral edema seems to be a class effect of this class of drugs, which is present even with the other molecules, and some edema is expected in close to half your patients. When I look at these tables, I usually look at what is the treatment discontinuation rate due to adverse events, and that thankfully is low, and this seems to be a good, well-tolerated drug. So in conclusion, the take-home messages would be that please do not miss an exon 14 skipping mutation, and the best time to test it is at diagnosis, not for in later lines. If you have these mutations, the response rates, the PFS, the duration of response, they're all convincing enough for us to favor this over and above chemotherapy. In India, currently, we are recruiting for a trial, which is a Geometry trial, which is a randomized control trial in the second line. The control arm has docetaxel, but there is crossover. So if your patient is in second line, I think you should find a center closer to you and then refer the patient over there. But for all other patients, patients in the earlier lines or unfit patients, the drug is available for use. And with that, I'll close. Thank you. Thank you.
Thank you, sir. So now we move on to our next session, which is sponsored by Pfizer, and it is going to be another exciting panel by Dr. Ullas Batra, and it's on ALK, the frontline, walk the frontline in ALK NSCLC, and the panelists will be Dr. Akhil Kapoor, who is assistant professor in medical oncology at Tata Memorial Center, HBCH and MPMMC in Varanasi. Dr. Ajay Kumar Singh, who is assistant professor at Tata Memorial Center in Mumbai. Dr. Moses Arun Singh, consultant clinical oncologist from Tata Medical Center, Kolkata, Dr. Rajat Bajaj, and Dr. Venkata Pradeep, who will also be joining, and Dr. Sunil Pasricha will also be joining this panel.
I think Dr. Sunil has gone, but that's okay. I think we've got 3 original panelists, and I normally say we have got 2 accidental panelists. Accidental or forceful panelists, you know. I mean, Rajat and Venkat could not say no to me. So Venkat was because I wanted to understand his perspective. Rajat was how he does a U-turn. That is why I have called him here. Okay. So I think we have 20 minutes to deliberate upon walking the first line in ALK positive non-small cell lung cancer. And you know, you talk about ALK, you walk about ALK. I don't know what all you stalk the ALK. I don't know what are you going to do more with ALK now. Pfizer is doing that. So again, my first reactions when I heard about first line strategies in ALK positive non-small cell lung cancer was this. You know, this was a tweet which was done on 2020 by WHO, which says that preliminary investigations conducted by the Chinese authorities have found no clear evidence of human-to-human transmission. And if you are still thinking that what is the relation of that to this, the relation is I just spoke about alectinib, and I'm now going to speak about lorlatinib. So I'm sure most of you would be saying like this, ab ye phas gaya. How will I, get out of this? And that is why Rajat is here to see how am I able to wriggle myself out of this situation. And my subsequent reactions of that was, if you want to look at an ideal man, or an ideal drug. So, for somebody, an ideal man does not smoke, does not drink, doesn't do drugs, doesn't swear, doesn't get angry, and doesn't exist. So, the lady over there agrees with that. Absolutely right. So, there's nothing called as an ideal drug. So, you can have you have a different battles of perspectives there. So there is no ideal sequencing strategy. And there is your truth and there is my truth. And there is, as for the universal truth, it doesn't exist. So Rajat, can I make my point now and go on to lorlatinib? Ground is set for speaking about lorlatinib for everyone over there. No, so I think it's a lot of time people do ask us, what would you do? And I think I would do what I did in the last panel. I would discuss a lot with my patients and then take it from there, try to understand what exactly things are and try to understand the pluses and minuses of both the drugs and then put it across to my my patient. So the first question to the expert, and I think we were there in the last panel when we were speaking about the NGS. So how many of us, Venkat, will start from the peripheral oncologist and the accidental panelist? Yes, Varajat. Venkat.
So, level in the NGS, the first start that I will get a patient with lung cancer is to get a biopsy, sir. To convince for biopsy itself is a big task.
Seriously?
Yes, sir. Because biopsy
Not now, Rajat.
Biopsy is done of 4 hours journey in Guwahati, in a place where I am there. In that entire district, lung biopsy is not done, sir. So the patient has to go to Guwahati and get the biopsy done. But the satisfactory thing is that a patient who has come on the stretcher, able to get the biopsy, all positive, counsel for lorlatinib, at least start done crizotinib.
No, but so I mean, I'm slightly surprised, Venkat. In the last 100 patients that you saw yesterday, how many have you got a biopsy done?
So there is no other alternative. So they go to Guwahati, get the biopsy done, get the block, and we send to TMC Kolkata for the.
Okay, and how much time does it all? I mean, this is almost like this is strange. Akhil?
Yeah, it's actually an eye opener.
Yeah, I mean, I was actually, here we're talking about alectinib and lorlatinib. Rajat, it's okay. We will talk to him. So what Venkat is saying, he works in Tezpur, Assam, and he's saying is there is no facilities for doing a biopsy at there. The patient has
lung
to
biopsy, sir.
Lung biopsy. The patient has to go to, so that is why you do a good clinical examination to see whether supragraph lymph nodes are there. But if you have to do a lymph node biopsy, lung biopsy, he has to go to Guwahati. get a 4-hour journey from there, come back with the block then goes to TMC Kolkata, then the report might come in a month's time and stuff. Here we're talking about alectinib and lorlatinib, but the stark reality of the issue is something different. I mean,
Yes,
that's
for that particular patient, she has mets all over all the organs, sir. She has terminal mets. I requested the local surgeon, so he removed the part and I sent to Kolkata. It is all positive, sir.
okay. So Akhil, what is it in Varanasi, Modi's constituency?
So we are fortunate enough to have our in-house team where we definitely do large chunk biopsy, multiple core biopsy, at least 5 to 6 cores as needed for molecular testing.
And how many times has the sample come as quantity not sufficient?
So that is usually only in patients where we rely on pleural effusion and block making. But it is our policy to do a biopsy even when we are sending pleural effusion for block.
So I would again agree, I mean, pleural effusion, cytology, cell block, I think Dr. Sunil has just gone. But the point here is that, a lot of time the cell block, always talk to your pathologist. How much is the cellularity? How much is the tumor content? Is the tumor content good enough for doing NGS and IHCs and stuff like that or not? See, the point is if you do not have that tumor content, then there is no point of relying on that test. We need to talk to the molecular pathologist. That's what my take is. So Rajat, how many times does the tissue come as not sufficient?
Very rarely, and even if it does, a rebiopsy is available. So biopsy is not a problem. But then if you're talking about NGS, of course, NGS we are doing in-house as well. And we're routinely doing NGS.
So how many times your report comes as variant? We were talking about V1, V2, V3.
So V1, V3 for me is more of theoretical as of now. I have not seen V1, V3 being written in any of the NGS report.
Maybe you are not getting them from your parent institute.
Yeah.
Okay, fair enough. Do you get an NGS done?
Yes, sir.
And does the report come as V1, V3? And does it make a difference to you?
We are doing most of the time NGS only, and it is reliable. And so very occasionally we are seeing their sample is not adequate for testing.
But for NGS, they do require a tumor content, tumor cellularity of at least 20%. Do they write it across over there? I have seen many times, I've got that. I told last time, 10% patient tumor cellularity, and they did everything on that. No, nothing formed. And छोटे से नीचे से लिखा था वहाँ पे कि only 10% tumor content was there.
No, sir. In our center, we are
you're doing it.
Highlighting the tumor percentage.
We routinely do IHC, so.
Okay, fair.
So one comment I would like to make. Yeah, variant 1 to 3, we get in the reports of the TMH, but it has prognostic significance, but doesn't add to the treatment selection. That is what we can say.
So this is what was the IC50s among the variant V1 and V3. And what we basically found out for V1, if the IC50 for crizotinib was here, for V3 it is here, for alectinib it is here. For lorlatinib, by and large, it is the green one is by and large similar for both V1 and V3. And maybe V1 and V3 V3 you will have more of lorlatinib. But this is preclinical. Now, what we did again at our center was we got a variant analysis done. We got an NGS done for them. And what we basically found out was even with crizotinib, there was no difference between V1 and V3. So a lot of time your preclinical data and what you propose and IC50s and all, it all looks good, very good on paper. But when it actually come onto the ground, it doesn't really stand the test of time. For us, there was no difference in crizotinib. We are now routinely doing NGS for every, most likely next year or next to next year, I'll tell you the data about alectinib and lorlatinib also. But to me, the importance of V3 is it will not do as well. You have concurrent co-mutations. We have already seen it will not do as well. That's all that I am interested right now is. And Akhil very rightly said, it's just saying it's a poor prognostic factor prediction. You can give whatever you want on that.
One more point. Variant 3 has more chances of having G1202R.
Just G1202R.
So at least 33% patients who are variant 3 will have G1202R. So next choice of treatment without biopsy becomes directly lorlatinib.
Fantastic. So again, first line treatment of ALK in non-small cell lung cancer, we are spoiled for choices here. And we have spoken about how do we discuss, so we will not discuss that. Let me rate them, not me, rate the following factors according to this. On a scale of 0 to 10, when a patient comes to you, this is the doctor's, very smartly, Akhil has given it to Venkat. Very smartly, see, this is what they do. And this is exactly Modi's Shishya. Very smartly on this question has given it to Venkat. Okay, Venkat. So for you, the trade-off between safety, efficacy, everything, second line strategies, how much would you really want to there was Shah Rukh Khan dialogue in that movie, na, kisi ke baal achhe hain, kisi ki aankhein achhi hain. So, you can't take out the best from everything, right? So what is it for you?
So most important is CNS efficacy.
The most important is CNS efficacy.
Because we know that most of the drugs do well in almost all the molecules. So the factor that I will consider while selecting the molecule is CNS efficacy.
CNS efficacy. Akhil?
So definitely CNS efficacy an important parameter, but what is that should be a balance of all the factors. Okay. It should not be like that one drug is very safe, but it is not effective. Then what is the use of using that safe drug?
So upon what level of, so between safety and efficacy, in the last panel, everybody said the drug is to be taken for 3 years, hypercholesterolemia, this and that, we will not. So, let's say 8 on 10 is efficacy. Safety is how much? Or this is how much? Rajat?
For CNS efficacy, I'd say 10 on 10 probably.
Okay.
Progression-free survival.
So how many patients, Rajat, of ALK rearranged non-small cell lung cancer have got brain mets diagnosis? 30%.
30%.
20% more will get. So your choice of treatment will be lorlatinib in 50% of people.
I agree. I completely agree. Even in the last
you didn't agree in the last one only.
I said that is the only point that I think it should be in favor of lorlatinib
30%.
First line. That if the patient is having a upfront brain metastasis, if you look at the Kaplan-Meier curve of the intracranial progression of crown, it is like
it's a line. It's not a
line. It's not a curve.
Yes, Ajay.
That's for me, sir. All the factors are important because we are seeing heterogeneous population. I can't rely on only one factor.
Okay. Fair enough. Typical politician answer. But I'll come to you. I'll just come to you. I'll just show you some data about the CROWN. So CROWN, as we know, was a study between lorlatinib and crizotinib. The update was presented in AACR 2022. And this was the data which was there. A 3-year PFS of 63.5% versus 18.8%. And that was actually mind-blowing, exactly what I exactly say that. There was no subgroup which did not derive a benefit from lorlatinib. Everybody, this is very, very important, and that is what everybody is saying. PFS in patients with or without brain line metastasis was fantastic. Not reached in the lorlatinib arm. Time to intercranial progression was also longer with lorlatinib than with crizotinib. If you look at this, 92.3% were not progressing at 3 years, and that is what we felt. And this is the slide as far as, I think Pfizer should actually put it across over there outside their office. If you do not have a brain mets, there's a 99% chance at 3 years that you will not develop a brain met. So, that is something. And, if you are a big fan of the Met Twitter, in Met Twitter, it actually came as, this is not a graph, this is a line. Where is the graph in this? It is almost a straight line. So this is for me absolutely a fantastic thing which actually got a standing ovation from there. So your thoughts, we'll start from Dr. Moses. So tell me one thing, as a clinical radiation oncologist, you must not be liking lorlatinib, no? He asked me a very nice question, asymptomatic brain mets, would you irradiate? So has your practice changed from giving radiotherapy to giving oral TKIs?
Yeah, with all these brain penetrant TKIs, we always wait for a decision on whether the patient will be able to afford those drugs.
So let us say affordability is there.
Yeah. So then I am very happy to avoid full brain.
You're very happy to avoid radiation. Has there been a paradigm shift in your practice, Dr. Ajay, to, in which you have not given, or in the time you give radiation, has there been a paradigm shift?
No, sir. Right now, still we are, Lola is not in my first line.
Alectinib has also got 70% response rate. Okay.
I'm concerned about the subsequent therapies.
No, okay, fair enough. So, no, let's talk about the brain. Let us say you have some 2-3 lesions in the brain, 1.2 centimeter, 5 lesions are there in the brain. You want to give them lorlatinib, and I'll come to the case over here, or you want to say give SRS or whole brain RT, and then I will give my TKIs. What would you say?
Sir, if alectinib is the option, I'll prefer the alectinib.
Okay, we'll come to that. Rajat?
So like I said, lorlatinib for me is in the first line if we are talking about brain metastasis, but brain metastasis also should be taken in the context of it being in probably 3 or 4 subheadings. If I talk about asymptomatic brain metastasis, it's a tricky term probably to use because there can be patients who are right now asymptomatic, but they are having involvement of critical brain sites. They are having a good perilesional
So in that patient, let's say
shift on MRI.
So what would you do? Will you give radiation?
these patients I still would like to give radiation.
Why? What is the, Dr. Arun, Dr. Moses, how much is the response rate of SRS or whole brain vis-a-vis, I will show you some data about brain, this thing. I will show you. I mean, just 1 second. I will just go and discuss the pros and cons. We'll discuss later. I think I'll come to that later. This is the patient that I was talking about. This is a 65-year-old male with a history of some cuff and backache and everything. And we can all see there is, I don't have the MRI images. There's some edema over here, the central lesion. The patient absolutely asymptomatic for brain. There are 5 lesions which are there. There is a good amount of pre-lesion edema also, but we can see. What would ALK positive, young, fit male? What would you do? Asymptomatic.
I wouldn't give them any brain radiation.
You would. So the radiation oncologist says no radiation.
No radiation.
No radiation.
No brain radiation.
Why?
5 lesions you said.
There's so much of perilesional edema.
So
You said.
this perilesional edema is peripheral lesion in the brain. This perilesional can still.
Okay,
be
this guy has a lesion cerebellum.
Yeah, so I'm talking about patients who are having infratentorial, supratentorial, almost diffuse metastasis in the brain. These are the patients, like I was talking about in the previous panel also, I've burnt my fingers giving a particular molecule and then patients
The plural of 2 patients is not evidence, Rajat. I mean, we all have burnt our fingers in giving this thing, but Akhil, what would you do? And I'll show you some data on that, this Akhil.
So there is an option to avoid radiation, but we should be very cautious while avoiding radiation in such patient with significant edema, because the patient might develop severe seizures and might deteriorate. So that is a concern.
So, like in impending visceral crisis in breast cancer, we have impending brain. Yes.
Yeah, but giving radiation is also not going to immediately have an effect.
So you give steroids. Okay, Venkat.
Steroids will be there definitely.
Yes, Venkat, what would you do?
So a similar case was being discussed in the molecular tumor online tumor board across the 7 centers of ICCF, sir. I was the only medical oncologist. The rest are clinical oncologists, mainly radiation oncologists. I said no radiation for all positive patients, and the health broke down. That's all I can say.
Okay, so this is what the data about, what I will show you is I'm comparing Crown versus I'm comparing LX. And if you look over here, confirmed intracranial overall response rate was 59%. Complete intracranial response was seen in 59.5% in patients who had any brain mets. If you had at least one measurable brain mets, you have an intracranial CR or a complete intracranial response rate in 72.2%. So in fact, to me, I mean, the paradigm shift that I was talking about in my practice, I don't remember having given whole brain RT to any patient in the last 2-3 years at the time they are post all these lines of treatment. Even in the, we avoid giving radiotherapy to anyone who is asymptomatic or mildly symptomatic. We give this. We probably, if it's a single and symptomatic one, we would go and do a neurosurgery and then go ahead and give something. We tend to avoid whole brain RT. We tend to avoid even SRS, because with SRS, what we are seeing now, as I said in the last panel, was radiation necrosis. And then the patients are undergoing surgery after, because these people are now living for 2 to 3 years. And your radiologists are not able to determine that what exactly are we, is it PD, is it radiation necrosis? We're not really telling about that. And if you really look at the HR value for intracranial time to progression, it's actually 0.07. And this is a HR, this is not a P value. And this is one trial in which, the P value looks like an HR value. Now let's look at the data efficacy also, and I'll go for over here. The pros and cons of lorlatinib, I think the time is less and I would like to tell you both. The pros of lorlatinib basically are impressive HR. It crosses the blood-brain barrier. The latest AACR data actually is mouth-watering, and I'll show you the data exactly in context with the LX trial. The cons are, I would not say unfavorable toxicity profile, I'll say a different toxicity profile. What after lorlatinib, and the final data remains to be seen. So this is the data. At 36 months, this is the data over here is the comparison of an HR value. Your HR is 0.27 at 36 month maturity. Lorlatinib versus crizotinib. And over here it is 0.43 with LX. So if, just in case lorlatinib had come 5 years earlier than alectinib, the comparator arm would have been a totally different arm. So both of them are absolutely right. I think if you have a young fit male, and this is what exactly I'm telling you, the HR for alectinib the HR for lorlatinib is 0.21, 0.28, and is 0.43 for this. So definitely things are there. The only speculation right now is median PFS for alectinib is 34.8 lorlatinib is 6 or 7 months after that. What? And I think December, the data is going to be out. In the last meeting in the Best of ASCO, I said 43 months. I was immediately corrected by a lot of people who said they are expecting a 48 to 49 months PFS in the crown. So Venkat, if you have 49 months PFS in crown, will you shift?
Definitely with CNS meds, lorlatinib.
Without CNS meds.
So when I have option to have a direct train, why will I take a pickup station, sir?
I didn't get you.
When I have a direct train, why
When
will
you
I
have a direct train. So when you have a direct train, there's
for the longer PFS?
Absolutely fantastic. Akhil, 49 months. Will you shift?
So definitely, if it is crossing 50 months, I would be happy to use it.
Okay. Rajat?
Yeah, anything above 45, 46, certainly yes.
Anything above 45, 40. Rajat said 43, 56 in the last one. Now he has gone down 12 months over there. Yes.
For me also, sir, because cost for both are same.
Okay.
I'm not concerned.
Okay.
Another advantage, another important advantage is the pill burden. That is very important. When we counsel the patient, it becomes different.
So again, the safety data. I mean, I'm sorry, Dr. Moses, I didn't come to you. Just the last 2 minutes, I think, after this. I have just 13 seconds and I'll answer your question. The toxicity profile is very, very important. And I would like to remind everyone who is over here, whenever you start a patient on lorlatinib, please do not tell the patient it is imatinib or gefitinib or something. Please call the patient after 7 days. Tell them 3 toxicities. 1, hypertriglyceridemia will occur. 2, weight gain will occur. Sugar may increase. Neurocognitive dysfunction may happen. Patients will come and tell, मुझे तो कुछ नहीं होता है. मेरे तो आज तक कोलेस्ट्रॉल बिल्कुल दिख गया. Tell them, boss, nothing will happen. You will have an increase. In out of 25 patients that we gave lorlatinib in the second line in our clinical trial, 23 on 25 patients developed hypertriglyceridemia, developed within 2 to 4 weeks. Weight gain definitely will occur. But again, if you see over here, discontinuation due to AEs was only actually 7% in lorlatinib, plus 14% in alectinib. Drug reduction also was more. You should know. I mean, it's not a difficult drug. It's a different drug, and you need to be prepared. Like with serotinib, you need to monitor the amylase, sugar, everything else. With this, the QTCs, with lorlatinib, you need to mention the triglycerides and the weight gain and everything over there. And yes, Akhil, you have a point?
Yeah. So I was just trying to highlight our own data. That is actually Kumar's opinion. So we have 41 patients who have received lorlatinib. Most of these were compassionate access program who received in the second line. 85% patient had hypertriglyceridemia. Our policy is to start rosuvastatin and fenofibrate both at the baseline, even when it is completely normal. From the day one.
So our policy was slightly different. I mean, I call them on day 15. I start with rosuvastatin. If the triglycerides are more than 400, then I add fenofibrate. आप टाटा वाले हो, आप कुछ भी कर सकते हो. हम प्राइवेट वाले हम नहीं कर सकते हैं, because that is what was written in the book. That is what I do. So one thing I did was I asked my internal medicine guy, कि यार कैसे करना है triglycerides, tell us what to do. So Rosavas 10 mg doesn't make a difference. 20 mg fenofibrate, more than, if its triglycerides are more than 300 500, add fenofibrate. That's a simple medicine rule which almost everything is done. Weight gain will occur. We have had a patient who had increased 10 to 15 kgs, but the brain meds, I haven't seen a single patient actually not responding to the meds over here. This is what is very, very important. Forewarned, forearmed to be prepared is actually half the victory. With lorlatinib, call them in 2 weeks time, call them in 7 days time, and then tell them what happens. 2 more minutes. What after lorlatinib? Is it a concern? I'll go to Akhil only first.
No, definitely it's a concern, but when it is able to give the combined efficacy, alectinib, first you give alectinib 35 months, 5 months, 5.5 months is expected. With lorlatinib, it is 42 months. But if you are getting already close to 50 months, it's fine for me.
So, but there are things which are coming after lorlatinib also. And now we have, I think, the very important thing is you are now going to get MET amplification. Ashish spoke very nicely about capmatinib. MET amplification as a resistance mechanism, KRAS 12C as a resistance mechanism. 4th generation ALK TKIs are now coming, which may be able to take care of the things post lorlatinib also. One point of caution, I have had a lot of consultations with the Ross Camage and everything. Nobody seems to be believing in giving ABCP after ALK. Typically, immunotherapy will work after EGFR, doesn't really work very well. The ABCP combination doesn't really work.
Even the subgroup analysis of that trial was not showing that.
So that is what we exactly did. The rapidly evolving landscape has changed slightly. from the Roche to the this thing, the green curve which was there before, less has now come on the right thing. But I think that's just a perspective difference. To conclude, there are a lot of drugs which are there, which are making life very comfortable for the patient. And I don't know about others. This is the patient and the medical oncologist who are now spoiled for choices, and they are the ones who are smiling away to glory. And then this, I would like to again conclude, everything we hear is an opinion, not a fact. Everything we see is a perspective and not the truth. You need to find your own truth. That was the perspective of Alectinib and Lorlatinib. That was the most difficult last 1 hour of my academic life that I have done, and I hope I have done justice. Thank you. Thank you.
One more point. Even with Lorlatinib, 50% patients progress in brain. So that needs to be taken.
They will come over there in the end. Yes. You had a point. To the panelist.
Perspective versus the JLX data, the PF 24 months, but the OS was 84 months. So up to 15 months improvement irrespective of the drug. Again, the problem is not that like pure 5 months, like the problem is what after that is also complete. And then PFS I think is not a very good metric in that. Probably CNS and the comorbidity are
Absolutely right perspective. I mean, you are right when somebody has to take the drug for 5 years, but just in case somebody has got multiple brain mets and you want a response over there. So, you have to weigh the pros and cons. So there is no one right answer. That's exactly what I said in the beginning. Anyone else? Okay. Thank you. Thank you. Thank you all my panelists. Thank you.
Thank you, sir. And thank you, sir, and thank you to all the panelists. We move on to the last session for today, which is a session sponsored by Lilly. The speaker for today's session is Dr. Akhil Kapoor, who is assistant professor at Tata Memorial Center. He will be talking on the role of Cyramza clinical evidence in second-line lung cancer.
So we are heading towards the last talk of the day. So I would like to be very brief and would not like to spoil the Saturday evening of our dear colleagues. Hopefully we can start in a minute. So now we are starting with the sponsor sessions from Lilly. Disclaimer slides have been provided from Lilly. So I would like to do a very basic case presentation Young 60-year male presented without any systemic symptoms. Patient was diagnosed to be stage 4 NSCLC with a lung lesion. The patient was initially started on treated with platinum-based treatment, pemetrexed plus cisplatin, and after second treatment, after 2 cycles, follow-up scan showed stable disease. Patient's performance status was fine. At 12 weeks, it was found that the patient is having progressive disease. So a patient having rapid disease progression within 3 cycles of starting of treatment, patient had baseline EGFR ALK cross wild type, PD-L1 expression was less than 50%. So we see these type of patients in our practice. Around 30% patients are rapid progressors. What is the rapid progressor definition? Usually the patients who are progressing within 12 weeks of starting the treatment. That is important to understand, and this is what is required. So this is an important point which we tend to forget. We do not realize, but it is very, very important. Aggressive disease, identify it, rapid progression at 12 weeks or earlier starting the platinum-based treatment. So when treated with docetaxel alone, these patients who are progressing rapidly, these have very poor outcomes. This is only 5.8 months of PFS. While in the overall data, if you see the overall PFS in the intention to treat population, it is more than 9 months. So definitely 3.5 months of stark difference in the rapid progressors. So it is clear that the patients who are progressed rapidly on the platinum also progress faster on docetaxel based treatment as well. So what is important to understand, how many patients are actually rapid progressors, that means having aggressive disease biology. If we see, our experience is close to 30% in our practice. Now coming to Cyramza, we know Cyramza is a human receptor targeted antibody, and it is shown specifically to block the activation of VEGF receptor 2. And it was seen to bind directly to VEGF receptor 2 to block binding of all VEGF A, C, and D. So that is what we need. So this REVEL study, which we have seen previously, it is a large pivotal phase 3 design, randomized double-blind trial, which has for patients who have progressed after first-line platinum-based treatment. And major efficacy outcome measure was overall survival. Again, a very important point here, overall survival was taken as the endpoint, and other endpoints were PFS and response rates. So key exclusion criteria, it is similar with any VEGF-directed treatment, patients with major blood vessel involvement, intratumoral cavitation, that is any chance when there is high chances of tumor bleed. And also the patients who are already having GI perforation history or fistula, or patient who are having thromboembolic event with the last 6 months, these are excluded. Also, gross hemoptysis within 2 months or grade 3-4 bleeding within 3 months were excluded. Also, major surgery within 28 days. So these are the basic things which we look before giving any VEGF directed treatment to our patients, and this remains same for this trial as well. So if we see the data, best response to platinum, and approximately 1 in 6 patients have rapid progressive disease. So that is very important. In these patients, you need to be careful. Even these patients are not going to do well on the next line of treatment, which is usually docetaxel. If we see the data of Cyramza plus docetaxel, this is the key demographic criteria, demographic functions. It is somewhat similar in both the groups, which is standard in the randomized trial. And you can see for intention to treat population, it was 5.8 months versus 9 months. So around 34% patients survived 1 year longer with Cyramza plus docetaxel, and this is for rapid progression patients. So definitely it makes sense if you can identify the patients who are progressing rapidly and utilize this drug at the correct time. So what happens? You can in fact double the progression-free survival. Close to doubling is important. So if we see the data, we want to compare the data of intention to treat population of the REVEL study. It was 9.1 month, and if you add Cyramza, it was 10.5. So it doesn't seem so exciting. But if you see the rapid progressive disease, you can clearly see the difference is stark, 5.8 months versus 9.1 months. So it is important to understand, you need to identify rapid progressors, to be precise, within patients who are progressing within 12 weeks of platinum-based treatment, and utilize them docetaxel plus Cyramza combination. And in intention to treat population, even in intention to population, even if you see the median values are not so starkly different, but in the hazard ratios, it is 43% patients are surviving 1 year or longer, which is commendable. So patients where there are rapid progressors, the absolute benefit is close to 3.5 months, and it is 57% improvement in the median overall survival. So median survival, which is improving by 57% in patients who are EGFR, ALK, ROS1 positive, negative. PD-L1 is also low. There we don't have many options, and there in those cases where we don't have much options, even in those patients, this drug is able to improve the survivals, and that is overall survival. We just had a small discussion on PFS versus OS, and in that case, we are seeing improvement in the overall survival by 57%. So that is worth commending and recommending. So if we see this data again, this is the values in the intention to treat population, PFS 3 months versus 4.5 months. And in patients who are having rapid progressors, it is increasing from 1.6 months to 3.6 months. So 1.6 months is hardly 2 cycles of docetaxel alone. And by adding Cyramza, it is actually improving to 3.6 months. So that is very, very important. So if you see, if you are administering docetaxel alone to a patient who has progressed rapidly post-partum, most patients will progress within 2 cycles of docetaxel, and that is somewhat improved by utilizing Cyramza, and median PFS becomes 3.6 months. So this is very important to be noted, and the percentage also is significant. 10% more patients, it is more than double the exploratory subgroup analysis, the benefit in these patients of having overall response. So adverse effects, yes, we are very well aware of the toxicities of drugs like VEGF inhibitors, and this is somewhat similar, no much difference. Docetaxel is causing most of the myelosuppression, and F1 rates are also similar, not much increased, and so toxicity seems to be well balanced. And if any one of us has used Cyramza alone, it is not so different from that. It is the addition of docetaxel which is causing most of the toxicities, and we very clearly know how to manage that toxicities. And this is the additional adverse events to consider with Cyramza as antiogenic agents. Treatment discontinuation due to adverse effects occurred in around 9% patient, and it was 5% in docetaxel alone. So it's not too much different, and these drug it seems that it is well tolerated in our patients. And definitely, this is the reason why in this particular case, we would like to add Cyramza to docetaxel, because the patient is rapidly progressing. Patient is looking for having some response as an additional treatment, and there is no evidence of central location or major airway or blood vessel involvement, and there is no history of hemoptysis. That makes one of my patient an ideal candidate to add Cyramza apart from docetaxel. And also, if we see the doses, Cyramza doses is 10 mg per kg, infusion time is around 1 hour. Docetaxel infusion also takes around an hour, and it is 3 weekly cycle, so you don't need to call the patients additionally, and it is very, very can be given simultaneously with the similar pre-medications as well. So this is the dose modification can be done accordingly. Only important thing which should be considered is hypertension and proteinuria, which we know for our patients with bevacizumab, and similarly with Cyramza, somewhat similar guidelines. And therefore, we can consider Cyramza in these particular patients who are progressing rapidly within 12 weeks of start of platinum-based treatment. So with this, I stop here and would like to take any questions if there are. Thank you. So another problem with nintedanib is that it has we need to be careful with the toxicities of nintedanib. We initially thought it is a good drug to inhibit pulmonary fibrosis. It was used in COVID time a lot, but our experience is somewhat different. If we see the TMH analysis which we have done, we have the data of around 25 patients who received nintedanib. The data is not so encouraging, and especially in the patients who are progressing rapidly, I don't think there is a place for that. Thank you. Thank you.
So thank you everyone. So we are closing for today. So please join everybody for dinner. And definitely again tomorrow we'll be meeting at around 10 o'clock at the same place. That time we will be having more discussion about immunotherapy and also in small cell lung cancer. So good night everybody.